This conference will now be recorded.
Okay. The few queries about the free sessions which I have done, they're not opening. I think they're opening on and off. I have admin to look into it, but do not worry. There was nothing new in those free session ones. All those stations which we discussed there, they are part of our course. So we will be doing them, but that will be put on YouTube at some stage. I think he needs to break them into three different parts to put them on. So they will be there at some stage. Okay. So let's see who. Okay, so anybody, if you want to join by a different name, please let me know. So I'm aware that there's you. So somebody has joined in by the ID of B or Dr. B. So can you please tell me who you are?
Ma'am, I'm Dr. Bridgie.
All right, okay. That's
Yeah,
fine.
I changed it, ma'am.
That's fine. Okay. The rest all are familiar. That's absolutely all right. Okay then. So we're gonna start now. So from the new batch, who wants to take the first station? Okay, so shall I call the names then? Neelam?
Yeah, yes, doctor.
Neelam Bhabna, do you want to take this first one, yeah?
Okay, okay, doctor.
It's absolutely fine if you can't perform, so please, nobody hesitate to come forward and present. It's absolutely fine if we don't do it very well, okay? But please do not lose
Okay.
the opportunity to speak today, during the sessions. We can always improve it, yeah? And these are very first
Yeah.
sessions anyway, so.
Any other slide, doctor?
Okay, that's your first 2 minutes.
Yeah. Hello, I'm Dr. Neelia, one of the doctor in the gynecological clinic today. May I confirm your name and age, please?
Yes, my name is Joe Hurst and I'm 38 years old.
How may I address you?
You can call me Joe.
Okay, Joe. So from your GP letter, I understand that you have been trying to conceive since last 2 years, and that's why you are here. GP has referred to us because it was not successful with the drugs he has given you. Is that right?
Yeah, that's right, doctor. I have been trying for 2 years now, and I'm already 38 years old, so I really want to just, crack on pregnancy. I don't really want to waste any time. Um,
Yeah.
so I really want to start the treatment to get pregnant. GP gave me some tablets, Clomifan, for, for eggs and all that stuff, but
Mm-hmm.
that hasn't worked. Um, so I just want to really start the next step. I think there are some injections we can take, and I can get pregnant.
Okay, Joe. Yeah. Actually, since we are meeting for the first time, I want to know more about you, to know about all about your history, and then we can come to a conclusion, and then I can give you a management plan further, right?
Okay, yeah.
So, Joe, can you tell me about your periods? How are they? Are they regular or?
Yeah, so periods, my periods are not quite regular. They are, I can miss a period. Sometimes I miss even 2 periods. So
Okay,
yeah, so he gave me those pills,
okay,
but they didn't help. They didn't make my periods either become regular or get pregnant. So I
okay.
think I do need something, some injections or something to control my whole cycle.
Okay, so your periods are regular, but otherwise the flow is normal and they are not prolonged, right?
Well, when I get the period, as I said, like sometime it's 2 months or 3 months after, then I bleed for 5, 6 days. Yeah, that's just normal bleeding.
Okay, and what was your last menstrual period? When was it?
Well, last one was about 5 weeks ago.
And you are trying since last 2 years, no, for
Yeah,
this pregnancy, right?
yeah, yeah.
So can you ask something more detail about your sexual history, if you don't mind?
Yeah, no, that's okay. Yeah.
So you are with your partner, same partner since 2 years?
Well, no, we've been together more than that. We've been together for about 6, 7 years, but
Okay.
we both were, doing our PhDs, and we were really busy at that stage, so we didn't want to have
So
kids.
you were using, okay.
Yeah, so we were using like condoms, and
Uh,
then now because
uh,
I have completed my I have a good job at the moment. I think this is the right
mm-hmm,
time. I need to get pregnant.
mm-hmm. Okay, so there's no problem in relationship, any intercourse and anything. There's no problem.
No, there aren't any issues.
Okay,
No.
and you know the fertile period. You know the cycle. When are the fertile days? You are following those.
What for fertile days? No, as so like
Yeah.
my cycle is not regular, so
Mm-hmm.
that doesn't quite work for me. So no, I'm
Okay. 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 And otherwise, everything is fine. So you never had any sexually shared infection? Sometimes, anytime in the past?
I had chlamydia when I was really
Uh-huh.
young, I think 16, 17, and that
Okay.
was treated then.
Okay. Now, anything else? Otherwise, you are fit and healthy. Any other illness you have?
No, I don't have any health problems. Like I don't suffer with
Uh,
any diseases or anything.
okay, diabetes or hypertension or nothing. And
No.
any surgery on the tummy or down below?
I had my appendix taken out. Nothing
Okay.
else. No.
Okay. So, okay. Any allergy to any drug or any medicine or any substance?
No, as far I'm aware of, no.
You are taking any drugs right now? Any medicine for any concern?
So I've been taking folic acid. That's the only thing I'm
Uh,
taking.
uh,
Yeah.
that's good. That's very good. Okay. Any family history of concern, like clots in legs or lungs or anything, any
No, there
chronic
isn't.
illness? No.
No, there isn't anything like that at all.
So, okay, what are you doing for your living?
So I'm working I'm teaching in a uni at the moment as a lecturer.
Okay, so everything is fine at home. Your partner is supportive.
Yeah, he is.
Okay, may I know whether you smoke?
I was, but I stopped smoking since we started getting pregnant. To get pregnant,
That's
yeah.
very good. Yeah, that's very good. And any alcohol? Do you
Yeah,
take?
we do just on occasions or over the weekend, but very small amount.
Okay, so do you know your weight to height ratio?
Right, okay. So here it comes again then. Yeah, so my BMI is 42.
Yeah.
Yeah.
Okay. Okay, Mrs. Hurst. I can understand from your whole history that you have been trying since 2 years, and there is no significant history other than the chlamydia infection and once appendectomy. And may I know about your partner also? Did he has anything of significance in the past? Any medical or surgical history?
No, he's pretty healthy.
Okay. And okay, so any investigation you had undergone for this concept for this fertility issue in the past?
No, GP hasn't done any tests yet, and I don't really want to waste my time having these tests and stuff doing. I know the problem is my period is now regular. I need some hormones to
Okay,
take to fix it, and
okay,
then
Joe.
I hope I'll get pregnant. Yeah.
Yeah, Joe, I can understand your hurry because you are 38 only. But since I have to tell you about the management options, so first I'll like to tell you how a normal baby is conceived, how a woman gets pregnant. So you must be knowing that every cycle, one egg is produced in the women, and when the egg and the sperm meet, then the fertilized ova go from the tube to the to the womb, and that it gets implanted there, right? So for
Yeah.
a normal conception to occur, three things are very important.
Mhm.
One is one should ovulate regularly. The other thing is the tube should be healthy to transport the ovum and the fertilized ova to the womb. And thirdly, the semen count should be normal and the motile sperm count should be normal.
Mm.
Are you getting me?
Yeah.
Too?
Yeah.
So to rule out whether you and your partner have any problem in any of these three, we need to do some investigation to find out whether there is any problem. So I would we would recommend that you at least go the basic test for to find out what is the cause of your not getting results even after trying for 2 years. So I would
Okay,
suggest for
but
a basic semen
doctor,
analysis.
that took already quite a lot of time for me to get this appointment here. So yeah, I mean, my partner, you can do the test for him, but for me, I know
Mm-hmm.
he's just, it's just the periods stuff. So you can start me on some
Okay,
injections at the
so
same time.
yeah. So you must be knowing about your periods irregular. So you know that you have some hormonal problem, and this is called polycystic ovarian syndrome, right?
Yeah,
Do you
my
know
GP
anything about it?
thinks so. He says I have that PCOS, but then he keep going in a circle. He blames to my
Mm-hmm.
weight. He says because I'm overweight, that's why I have this, and I'm
Mm-hmm.
not getting pregnant. I have tried
Mm-hmm.
everything to get rid of this weight. I have tried the
Mm-hmm.
diets. I have done some exercises as well. I just can't
Mm-hmm.
shift this
Mm-hmm.
weight. But then I know there are other people in my family. We all are heavy. My sisters,
Mm-hmm.
my mom, but they all have, they all had pregnancies.
Yeah.
So
Yeah.
why
Yeah.
it's only me whose weight is the reason?
Yeah, Jago, I can understand your concerns, and I know you must be trying hard to lose your weight, and it's really difficult to lose weight, right? So initially, to tell you about more about the polycystic syndrome, that it's actually a hormonal disease where what happens that the body fat, whichever extra fat there is there, that there's an enzyme which converts the good hormone into the bad hormone, and that makes all hormonal imbalances, and that leads to an ovulation there, that the ovary will not produce an egg, right? Are you
Yeah, so
getting
for
me,
that
Joe?
one, yeah, for that reason, that's why I need to have the injections. One of my friends had polycystic ovarian syndrome. She was started some injections and then she conceived.
Hmm.
Yeah, so you
Yeah,
need to
that
start me on
is
some
true.
injections.
Yeah, that is true, but it's this basic pathophysi this basic defect in this polycystic
Okay.
ovarian syndrome is,
Your time is over,
yeah,
but you can take maybe
okay.
1 or 2 more minutes to conclude if you think there is something important you want to say.
Yeah, but otherwise I want to tell her that pre-pregnancy weight should be normal also, because
Yeah,
once you conceive with such high BMI,
yeah,
then you may have
yeah,
other effects on the pregnancy, like
yeah,
you may have a pregnancy loss, you can have high
yeah,
blood pressure, you can have
yeah,
low birth weight, and you can have
yeah.
small
But that we will
gestation
be
age,
able to
diabetes. Yeah,
do only if she will be prepared to listen about weight. Yeah.
yeah,
This
yeah,
woman,
that's true, ma'am.
she is not.
Yes, that's
So
true.
the girls who have done
Yes,
this exam, they the way they have told this woman kept them up to the weight story and injections. She did not let them go beyond it. So
yeah,
yeah, so here we need to basically in this station, yes, there is we need to obviously do investigations as well and then start on our investigation. But the most important theme of this station is basically how we're going to approach this station. So it was fine. You started lovely. So you can just say, so I can see in this woman, because she's unhappy, I won't basically pick up and summarize anything from the letter. I will just invite her to start the conversation. So, so we will just start by saying, okay, so hi, Joe Hurst, my name is this, and can I confirm your name and date of birth? And then you can see, okay, so just very short point to say, okay, so I have this letter from your doctor regarding you've been trying to get pregnant and haven't been able to do so. So would you like to tell me in detail, about your, like, how long you've been trying, what has been done, and what has been the result? So invite her to start her story, her own. So this lady actually then went into quite a long, she volunteered a lot of information herself, all this story of career and this and this, and I'm doing this and I was doing this and I need to get pregnant. I don't want to waste time. The GP has given these clomiphene already, which is not working. Start me on some injections. And the weight thing, the GP has already said, yeah, she doesn't want to listen. So we are aware there's a sensitive matter to approach. So I will take a quick history. I think you took quite a long time to take the history to establish. By the time you started just the discussion, there were only less than 3 minutes left. Couple of words in the phrase, these are the words which you're using. They need to be some alternative words needs to be used. We do not use the word must. You must. That is kind of taken in the sense of like we are ordering them, we are forcing them, and we are ordering them. You must do this. So it's taken as a harsh word. So we don't use that word. So try to just practice. I know it might sometimes it's just our style. We use these words, but try to particularly focus on this word. To get rid of this. Okay, so I will take short history because from the letter it also, so there was quite long, I think, information given on the letter already about her medical surgical history and stuff. So you can just quickly go over that by saying, okay, so right, okay, I can see, so she tells you how long she's been trying and what has been done. Then you can say, okay, so tell me, do you have any long-term health conditions like diabetes, high blood pressure, or anything? And then did you have any operations, any sexually transmitted infections were important, that smoking you can ask. And then you can just ask her about, you know, any previous contraception she has used. And have her periods always been like this, irregular periods? And have she ever been given anything to correct her periods? And then she will tell you about whether the GP gave me this clomiphene and that didn't correct my period and that didn't help me to get pregnant either. I just want to start injection. You can say, okay, yeah, yes, I can see, that you have already tried 2 years. It can be a bit frustrating. So let me explain you. I will just simply start explaining right from the beginning. To say, let me explain you what happened normally, okay? And just quickly make the uterus picture ovaries on the other side and just say, so what happens every month? The ovaries produce an egg, and then that egg get released, from the ovaries, get up into the tube, the sperm meet in the tube, and then the pregnancy start, and the developing pregnancy then come into the womb and get implanted and start growing. The word ovum, fertilized ova, they are more technical terminology. We will just simply use the words egg, sperm, the meat, pregnancy starts, pregnancy then moves through the womb and start growing here. So there are different reasons why, the reason why people can't get pregnant. So the number one is obviously the sperm, the sperm count and the quality of the sperm. So then at this stage, no, I will address, has the GP done the semen analysis test for your partner? If she says no, then I'm going to say, okay, so this is very important that we do get this test done, right? Now you can see the difference, but she's right in the beginning saying, I don't want to have the test. So in this way, I have brought in now why that is important. She can now relate why that is important, yeah? So we're going to do that test. And then she was actually fine. She was actually encouraging as well to the girls who are now talking about the semen analysis. What test you would like to do for my partner? Okay, that's a semen. So that we will do, because there's only one test we need to do from the partner. And then regarding, in the female part, so I'm still not relating it to her. I'm just simply going to say, so for the females, what happens? Obviously, the problem can be mainly, commonly at two of these places. One, maybe their ovaries are not producing eggs, or they are producing eggs, but that's not getting to the appropriate size, and then getting released from the ovaries. That's the one issue. Most common issues in case of women are sometimes, for some reasons, their tubes may be blocked. So the egg is released, but the egg is not able to pass through the certain area of the tube, and that's why they don't get pregnant. Now, that's also then become very important to see what actually is going on in, and then I will ask, has your GP done any tests on you? And she will say, obviously, oh, well, he said it, but I don't really want to waste the time. I know I'm not having the periods, and that's what the problem is. Okay, yes, that seems to be one of the reasons. That could be one of the reasons. So we then need to find out as well why. So I'm not going to actually go on the diagnosis of polycystic ovarian syndrome in this women, because the GP hasn't done the any test. So he hasn't told us, from the R, unless you ask the history of hirsutism from this woman as well in the beginning, right? You need to meet two of the criterias. So I'm not going to say she has polycystic. GP feels from the BMI, unless there is some information given, yes, she has some hirsutism and all that stuff as well, then you can say that it is likely to be, maybe. Okay, so then I'm going to say, so the different reasons, causes which can affect the egg formation and the production. There are different reasons. Sometimes there can be some hormonal imbalance in the body, for which it happens, and so that's why it's very important that we try to do some tests, and they won't take very long. They can all be done in your one menstrual period cycle. We check all those hormones and try to find out at what level the issue is, so we can then correct it accordingly. And the most common reasons for these hormonal imbalances can be, sometimes they can be some weight-related issues that can also contribute to it. And I can see your BMI is, towards high side. At this stage, no, she might, it's okay, even if she, after all that explanation, hopefully she will be fine basically at this stage to understand, because we have told her like high weight can also be a reason. So in your case, your weight is this, so that might be contributing to that. However, I do understand in these particular circumstances, when there is a hormonal imbalance, it's very difficult to reduce the weight as well. Okay, so then you can ask, or she might have given you the story already that I have tried the diet and exercise and everything. Then I'm going to acknowledge and relate and say, and that's the reason, in spite of your all those hard efforts, your weight is not, coming down. So we will talk about that as well. If that is the only reason, how we can actually help you to reduce the weight. There is some medicine we can start called metformin, which can actually help reduce the weight as well, and as well as that will help the egg in the body, in the ovaries to get mature as well. So you can bring metformin. This woman needs to go on metformin, and she needs actually to start with the, we need to start her hormonal profile, yeah? So then you can ask her, tell her to say, okay, so what we will do, then your period will last period, we're going to give you some pills for 5 days to initiate your bleeding, and then from the second day of bleeding we will be doing one blood test to check your some hormones, and then we will do on the day 21. I will explain you that all in detail, more detail at the end of this consultation, how you feel about having these tests done in this 1 month's time, and then we can accordingly pick up and go ahead. Yeah, I will also arrange an X-ray test to check the your patency of your tubes to make sure they are open. If she still go angry by saying, well, which won't be, because just like people don't get angry or frustrated for no reason and just to give us tough time. The reason is she has been told the weight. So as soon as the word weight comes there, she just try again, because she has tried. She really has tried. And we know the women with PCOS, is really difficult for them to reduce the weight, because we know the reason is insulin resistance, and that will not let them reduce the weight. And that's a vicious cycle, keep going on and on. So they really appear when they come, they're really frustrated. Because they think, we're blaming them, then you are overweight, simply that's the reason you're not getting pregnant. But when we explain and acknowledge as well that the weight gain and the difficulty to reduce weight is also related to those hormonal imbalances, and actually we can help that with this medicine, they're fine. Okay. So at this stage for this woman, basically this is enough to tell her. I won't go into the details of SH, LH and progesterone and all those stuff, because you won't be left with the time go into detail. Or you can say there will be some tests which will be, yes, we're going to give you withdrawal bleeding, and then some test on day 2 and 21. Arrange your scan, that X-ray for your ovaries as well. And then I arrange your another appointment. Okay, so when she says, well, I have already, and it is true, basically, when they are referred to the gynae clinic, it takes already 3-4 months minimum for them to be seen there. And then we send them another 4 months time. We arrange these investigations, and we arrange the next follow-up in 4 months time, about 3 to 4 months time, because obviously the waiting list for all patients is so high here. But what we can then just, I will say, okay, we will try to arrange your next appointment, comparatively sooner. However, it's very important, because if we didn't do these tests and we just blindly try to give injections and tablets without knowing the reason, who knows, you might be producing the eggs but your tubes are blocked, right? So without knowing, actually, even those injections and everything, we will just be wasting more time. So once we will tell her they can be done fairly soon, and other way we might actually be wasting time for a few more months, it's better to start doing, and she will be fine, she will accept it. Any questions?
Assalamu alaikum, Dr. Safia.
Walaikum
Mubashra
assalam.
here.
Yeah.
Dr. Safia, is there any rule to explain bariatric surgery in this case, as her BMI is above 40 and she wants to conceive? So
No. And why not?
okay.
Okay, now you give me the answer. Why not?
Because I read in the talk that if the woman is above 40 BMI, then and she wants to conceive, then give her the.
Yeah,
but
give.
yes, after bariatric surgery, we need to advise her contraception for at least 1 year. So
Yeah.
that may be frustrating for her.
Yeah, so she's 38 already. What happens is that we know, like, okay, yes, we are doing these investigations and stuff, and then we will start her. We may need to refer her for IVF. So if we take her beyond the age of 41, she won't be eligible for NHS funding for IVF. So bariatric surgery, and then that's not something like we will decide straight away now and that will be done next month. That itself will take like at least 7-8 months before she will have the surgery done. Then she will have the surgery done, and then she will need to wait at least for 1 more year. She will be already 41 by then, or even more. So bariatric surgery is not a good option for her. And plus, the main trick in this, I won't say the trick, but for some reason candidates get confused. Everybody is just so much concerned and worried about the weight in this scenario. Weight may not be the reason. Yeah, she might have some issues in her karyotyping. She might have some issues with, she might be going into early menopause, premature ovarian failure. She might have the tubes blocked. She might be everything fine with her actually, and yes, she has some irregular periods, but she might be ovulating for those periods, and there might be azoospermia for the partner. Yeah. So yes, weight has some role here, which I have told you the way you can address up there to help her. But you need to focus on basically the themings. We need to investigate this woman. We can't just wait slowly. Yeah. So
Okay.
I won't be going for bariatric surgery offer for her at this stage because we do not have the time. And offering her bariatric surgery and then talking about few more years, it's going to take at least 2 more years then before she actually can start planning again. This woman is going to shout and kick back on us. Yeah. So no, the bariatric surgery I won't be offering her.
Thank you.
Can everybody else mute their please, because there is a lot of noise. Any other one more quick question before we go to the next station?
Ma'am, if the same patient with younger age comes, that time do we need to advise?
Yeah,
Like
if she
30
comes
years
like
or
she's
something.
on, yeah, so if she's 30, less than 30 or something, yeah, we can offer. But then again, in that woman as well, we cannot forget basically to do her initial investigations first, yeah. And then we can, yes, we can talk about. And if we have done the investigation, then we can talk about by starting this and this one as well. And yeah, in that case. So that's why it's very important that when we are taking the real scenario in the exam, we need to individualize all that information which we read in articles or in theory part. We need to, yeah, tailor it according to the patient need. Does that these options fit for this patient or not? The examiners get annoyed and the role players and the patients get annoyed when we are basically just divulging, kind of vomiting out what we have read without actually making any sense. Is that really be a suitable option for this patient? Yeah, that's what irritates and that's what makes us to fail as well. So just think about from all that information we have read, which one is suitable for this particular patient. And that's what you do all the time in your clinics, don't you? Yeah, good. Right, okay.
But then
So,
we need to, Dr. Sapir, one more doubt. But then we need to talk about the weight loss also, right here in this case.
yeah, so what did we say to this woman? We said, I can see your weight is high. That may also be a reason. I can also see you have tried already very hard. Yeah, so we have that bunch there by saying, and it can be really difficult. So we acknowledged first from her point of view, yes, you are trying, but it's difficult because there is a reason. When there is a hormonal imbalance, that make it more difficult. So we can consider to start you on metformin to help reduce that. And at the same time, we can do these tests and take things from there. Okay.
Okay.
And then obviously encourage her to continue with her exercise and stuff. Okay.
Dr. Sabia, if
Yeah.
she does, Safia, if she doesn't agree for all these tests, what do we do?
There is no reason she will not agree. The people she was not coming to, that was the reason. They were just all talking about. So one of my people who are passed, she did. She explained to her by saying, okay, so let's do those tests as well to see, because the weight may not be the reason. You might be producing egg, maybe irregular, but you are doing. So let's do these first main basic things to see what exactly is happening.
Okay. Do we ask for AMH as well?
Okay. And there's no reason why she will not. Yeah.
Oh,
No, there's no reason to do that at this stage as a beginning. Just do
okay.
your simple infertility investigation that we do for everybody. Yeah. Just do
Sure.
those and then see what's going on. Then we can go into further if we needed to.
Okay.
Okay. Fatima, are you with us?
Yes, Doctora, I'm attending, but I'm still in the clinic. I cannot participate.
Hello.
Yes, you can hear me, Doctora?
Fatima?
Yes, Doctora, you can hear me?
Okay. So you're not able to present then?
Yes.
I can hear you, Fatima. Yes. So did you say you're not able to present because you're in clinic or yeah? Okay, that's okay.
Yes, that's true.
Neelam, is Neelam with us? Sapna?
Yes. Yeah, hello.
So we have two Sapnas, is it? Are you the one who just joined us, yeah?
Yeah.
Sapna?
Yeah,
Can you
I'm
hear me,
Sapna
yeah?
Sridhar. Yeah, I just
Okay,
joined recently.
you just joined this, yeah, okay, that's fine. This one is for you.
Okay.
So your 2 minutes start now. Okay.
Okay. Hello, I'm Dr. Sapna, one of the doctors in the clinic. May I please confirm your name and age, please?
Okay, so I'm Dr. Jacqueline.
Pardon me? Hello? 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 Hello?
So have you, yeah. Have you,
Uh,
Dr. Jacqueline,
Dr. Jyoti, okay.
you
And
read
your
your
age,
scenario?
please? Yeah. Shall I start?
Hello?
Hello?
Hello? Yeah, okay. So, yes, yes.
Okay.
Hello,
I'm,
yes.
hello, I'm Dr. Sapna, one of the doctors in the clinic. May I please confirm your name and age, please?
Okay, so this is structured discussion, Sapna. This is with the examiner, okay? This is not with the
Okay.
patient.
Okay. Okay. So
Okay.
I'm Sapna. I'm one
Yeah.
of the candidates for today's exam. I've read the instructions and I'm ready for the exam.
Okay, so do you want to summarize and tell me what is the your scenario and what will you do in this case?
Okay. So this is a 31-year-old third gravida with previous one normal child 7 years back and with one ectopic pregnancy. And she has a history of epilepsy, and she's currently taking carbamazepine. And she's now requesting sterilization. So the assessment, I'd like to take proper history from her regarding the history of what contraceptive method she is adopting right now, and what are her concerns behind choosing.
Hello. We can't hear you, Sapna. Hello. Can everybody else hear me?
Yes, ma'am.
Yeah,
Yes,
we
Can
can't
hear
hear
you.
Sapna, but can you all hear me? Yeah. Yeah.
Ma'am, we can hear you.
Ma'am, I think her
Okay,
internet
let's.
issue. She has left.
Yeah.
She have
Okay.
just arrived.
Yeah. Okay.
I'm
Right.
sorry, some net
Hello,
issues.
Sapna. Can you hear us? Yeah. Yeah.
Yeah, I
Okay.
can hear you now. Okay, so I'd like to know
Okay.
more about her history, about the history of what contraceptive method. Hello, can you hear me? Hello.
Yes, we can hear you.
Okay. No, because I'm not able to hear Dr. Safia.
Okay. And meanwhile, we use Sapna. There is a lot of. Can we take it to some other?
Yeah. Okay.
Anila
Okay.
Sri.
That
Anila
will be
Sri.
fine.
Can we take it to you? Can you do the
Yes,
station
ma'am.
meanwhile?
Yes, ma'am.
Yeah.
And
Okay. So can you please do this
and
station
Dr.
and
Anilu,
while she sort out her internet?
okay, ma'am. I'm Dr. Anila, one of the candidates for the exam today, and I'm ready for this discussion.
Okay. So if you want to tell me what is the patient details and what will you do about this?
Yeah, she is she's been pregnant twice, para 2 with non-epileptic with a high BMI, 31-year-old lady who has just started with a new relationship and have come for a sterilization. So I would like to ask her, since she have only one child, what was the reason for her decision to take sterilization? Go for the sterilization procedure, and then what is a current contraception she is on, and what are the drugs other, I mean, is it only the epilepsy what she is thinking of for sterilization procedure? And I would like to ask her further details about any um, sexually transmitted infection she had previously. Then about her work and support at home, and also about the husband, I mean her partner work and all those. I think that is a history I would like to ask. And other medical issues and any surgery she have undergone other than myomectomy, and what was the treatment she have gone for the ectopic pregnancy. Ma'am, next question.
Hello.
Hello, ma'am.
Okay. I think I lost some in between as well. Okay. So you wanted to get this of information, yeah? So she just has a self-injectomy not long ago, about 4 or 5 weeks ago, and she is No, not 4-5 weeks ago, 4 months ago, and she has been using condoms since then.
Okay.
So what management options, or what are you going to offer her? What options are you going to offer her?
As she has recently undergone surgery, I would like her to give her options of first in long-acting contraception, either an implant or a copper T, or I mean the IUCDs, or
Hello,
inject. Hello, ma'am, can you hear me? Hello,
Anila.
ma'am, can you hear me?
Yes, we
Ma'am,
can
I'm
hear
able
We can
to
now,
hear
you.
but there is
you.
a lot of interruption. It keep going off.
Ma'am, I'm able to
Okay.
hear you, ma'am.
Dr.
Yes,
Javeri,
Anila.
sorry to
Yes,
interrupt.
yes. Keep going. Okay, keep going, Anila.
We can all hear Anila clearly, but it's your connection which has been interrupted, I think. That might be the reason for you not hearing her properly. Sorry to interrupt.
Okay. Okay. Let's see now. Yep. Okay, Anila.
She had recent surgery, and she is a non-epileptic. I would like to give her first a long-acting temporary methods as an option for her. Discuss that IUCDs are available, implants are available, and injectables are available. Apart from that, I would advise her to wait for sterilization. I'll give the options if she is very focused on sterilization. There is also, apart from female sterilization, there is also male sterilization if the partner is willing, and give her the risks and explain her what are the
So
pros
which
and cons
particularly,
for each
okay,
one.
so which particular options you will, okay. Okay, Anila, I'm gonna stop you here to ask next question now. So options you gave are Implanon and IUCD. Are these the
Yes,
two
ma'am.
options you're going to discuss with her?
Yes, ma'am.
Okay, so is Implanon a suitable option for her being on carbamazepine?
Actually, it is not an option, ma'am, because
Mhm.
injectables are a better option than this, and the copper IUCD or Marina can be a better option. Impleno being
And why
I mean liver enzyme, it is
why
carbamazepine is a liver enzyme inducer which can decrease the efficiency of the Impleno.
why will you give these options to her?
Ma'am,
She has come for sterilization. She wants sterilization. Be considering these options.
but
Yeah.
because she had recent ectopic, one thing, the other one is she's into new relation just now. Maybe in the future they may plan to have a child. I mean, plan for a conception and to go ahead. And she had laparoscopic myomectomy. If
Okay.
she
So
goes for a
okay,
Marina,
just give me
that
one
will be.
second. No, just give
Uh,
me pause here now. So
okay.
you want to offer her some other alternative method in spite of sterilization, but then you're offering her partner to have vasectomy done.
No, no, no. I would explain
Yeah.
her those. These are the options available.
Mm-hmm.
But I would
Okay.
advise her first option would be long-term, long-acting copper coil or Marina.
Okay. Right.
As
Okay.
she's
So
an
what?
epileptic already, ma'am.
Okay. And why we want? I mean, what are the success rate of Mirena, IUCD, and Depo?
Success rate is almost 99%, ma'am. failure is very less than 1%.
Mm-hmm. And what's the failure rate of what? Sterilization is less than 1%. Okay. And
I don't remember.
okay, what are the success rates of those 3 lock methods you have offered her? Okay, so in spite of your all that information and everything, she still is adamant to have a laparoscopic sterilization done. What will you do now?
I would inform her that sterilization is a permanent method, and that if she wants in a future to go for a reversal, it is not funded by NHS, and the failure and success rate of the reversal, that how much it is, it depends on the many things, her age, then her length of the tube, the method used, all this will determine that time the success rate. And also I would like to inform the fix an appointment with my consultant one day for the discussion.
Discussion of what?
Regard her option of going for sterilization.
Mm-hmm. Okay, so you have discussed with me. I'm your supervisor consultant, and I agree that's fine if she wants to go ahead with that. Is anything you will be worried about? Is anything you will be worried about this woman?
I would like to get a opinion from the neurologist regarding her safety for going ahead with a surgery. I would like that it can be done
So what
by
is particular?
laparoscopy.
Okay, so why we want to consult the neurologist for surgery suitability? What are the concerns?
One thing is, when was last episode regarding, is there a risk for her to get another episode because the surgery itself is a stress, one thing. The other thing is, I want what it's drugs that are to be given during the surgery to prevent epilepsy to occur, and if she have any episode, how to manage it.
Okay, right. Anything particularly we need to be aware of or while we are performing the procedure for her?
Certain anesthetic drugs should not be given, like petidine and.
Okay. Okay, your time is over, so we'll stop here. Okay, so thank you, Anila. So what happens basically in these type of structured discussions, you need to, the first thing is obviously it's a clinical colleague conversation. So you need to keep your terminology just same as we do for our discussions. Okay, so when you go for structured discussions, you introduce yourself. I'm this and this candidate number, if that's given to you, this, and I'm ready for the structured discussion. Then you summarize your scenario. So you will say the patient we have here is a 31 years old woman. If the name is given, just take the name, whatever, Catherine Smith, 31-year-old lady who has been referred to us for sterilization. She is epileptic and she's on carbamazepine. I noted her BMI is high, is 38, and she is from the given information, it appears she had two pregnancies previously. She had a 7-year-old child, and then she has one ectopic done as well, right? After that, just like the same way as we do structured discussion, I always say there are very easy stations actually to do. You just need to stay organized. And again, logical. In the structured discussion, if a patient scenario is given, you must tailor your discussion for that particular patient. Don't just again give all the information which is given in the guideline or in article or wherever we read about. Yeah. So then you will say, okay, so in this one, first of all, we say I would like to gather more information about this woman, and then tell what exactly we want to know. You want to know, okay? So the first one will be to ask, as I would like to know her reasons to go for a permanent procedure just at the age of 31 when there are safe reversible LARC methods available. And the success rate of some of these LARC methods is even higher than the sterilization. So that's the first concern. I would like to understand her reasons, and we'll also like to ensure that she has been given those options and discussed and given the information about those methods. Okay, so that's the one very basic and initial information you want to gather from this. And then second, just like as you will do the rest of the information, has she tried any contraceptive methods before? If she has that ectopic pregnancy, did she get, actually she got this pregnancy while on some contraceptive method, or maybe she was actually, she had the coil and then she had this ectopic pregnancy. Yeah, so there might be the reason. So we need to understand that what contraceptive methods she has used already. And were there any problems with those contraceptive methods? Regarding her overall medical health, then obviously you need to understand we know she's on carbamazepine. Is there any other medication she's also taking? Is her epilepsy under well control at this stage? When was the last time she had a fit? And then the routine, the surgical history or any other obstetric history or any other histories, surgeries she had. I noticed here she has one ectopic, and how was that managed, that ectopic pregnancy? Was that like laparoscopic surgical intervention? That was medical. I have also noticed she had myomectomy twice. That means, so you need to just keep bringing that information. That means there can be quite high risk of adhesions in the pelvis. Okay, and because of that, there may be difficulties to, even to identify or separate the tubes to the sterilization. The procedure can be quite high risk. There will be a high risk of injury to obviously all the viscerals, bladder, bowels, and blood vessels, history of bleeding. And there is also a more risk of failure if there are tubal adhesions present already of the sterilization procedure. Okay. So then you need to be asked about just general history, generalized history about she's on any medication, she has any allergies. And after that, you just come to the point again. Okay, so then some examiners do ask you the next question. So she might just say, okay, so what discussion would you like to do with this woman? Or they may not. Okay, so if the examiner is, you can ask like, will there be a following question? And if not, then you continue by saying, so after gathering all that information, I would like to then have a discussion with my patient. They will probably give you some answer, right? So when you say, okay, so what is the information I have, right, about these answers of the questions I have asked? So this woman actually has a self-injectomy, and she has the previous birth was also cesarean section, so she's quite high risk of adhesions in the pelvis, right? And BMI being 38. So you will say, okay, so I will have a, discuss with her about the LARC methods, and then be careful again to suggest the LARC methods, what are safe with carbamazepine. So Depo, Mirena coil, and IUCD. Depo is not a very good option here for this woman. Number one, that needs repeating after every 3 months. I know Depo can be given theoretically, but we like these women to go on more, long term. So we usually recommend them strongly to go on the coils rather than, because they might forget to come back, and then she's already weight 38, and Depo obviously has the risk of weight increase as well. But yes, you will say Depo is also option, but you will discuss, I will make her aware that that can be, so may not be very suitable option, but obviously the choice will be hers. Now the success rate, particularly when we are comparing, and it's not unusual scenario, the women still come and they want to have a sterilization. And by the time they come to us, the GP has already taken that discussion to them. But if they're still not convinced, that means we need to give them more, know the authentic information. So we need to really know the numbers here. So what is the, you tell first the LARC methods, advantages and disadvantages. So talk about the sterilization. So instead of starting from the failure and all that stuff from the sterilization, talk about the good and the benefits of the LARC methods first. Okay, so I will give this, obviously there are reversible methods. You will give both, the numbers, the Mirena coil, and the success rate of Mirena coil is, you need to, so all of you please today make your notes of these exact numbers. What exactly is the success rate or the failure rate of Mirena, IUCD, and then the advantages, obviously they are reversible. They can be taken out once they're done, they're long term for 5 years or 10 years time. She doesn't need to work. They're less invasive. as compared to the sterilization. Sterilization will involve anesthesia, so there can be risks of the anesthesia, and then because of so many adhesions, there's a higher risk of those injuries. Okay, so this is how you're going to compare now. These are less, they can be done in outpatient, and then if she go for anesthesia and for the sterilization procedure, although it is day procedure, but because of the adhesions or bleeding or any injury, if that happen, obviously the length of the procedure and the total duration of the surgery time can increase, and that will further add the risk of VTE in this woman, and that can result in prolonged hospitalization, and obviously the more risk of VTE, and which can be life-threatening. And this is how we will compare and tell that woman why the LARC methods are more and that one, and what are the risks. Yeah, associate them parallel as you're going along. Then yes, these methods are reversible. If she didn't like, she can try. If she didn't like, obviously they can be removed, and she can go proceed with the sterilization as long as she understands all the risk associated with the procedure. And then regarding male sterilization, I won't even talk about that option here. Yeah, why we are giving these alternative options to her? Because we want her not to, for two reasons we don't want to. Yes, the main major factor one is this will be high risk because of additions and everything, but more important factor here is her age. She's very young woman, and she has just entered into new relationship. She doesn't know, like, she might like to have a child with this partner in coming years. So there is a high, at a young age, the procedure of sterilization is associated with a high, what should I say, regret.
Great.
Yeah, and they want to have the reversal procedure then, and the reversal procedure obviously in her particular circumstances again will be very difficult. Even on average, the reversal success of the reversal surgery is only 24 or 25%. Correct the numbers, double check the numbers, okay, this exact number what that is. But in her particular circumstances with high BMI and all that additions, there will be further addition obviously to the additions after this initial sterilization procedure. The reversal procedure will be very high risk, and the chances of success will be even lower than the average. Okay, it will not be funded on NHS. We will make sure that she has compare both the options. So the male sterilization is not an option. Some person which has just come into her life just for 3 months, why that person will go and have a vasectomy done for her? They don't even know which side this relationship is going to happen. We don't know. He might be even younger than her. He might just be 28 years old, and he never had a child already. So there is no point at all. This will rather penalize you, talking about male sterilization here. Okay, so vasectomy, please do not even talk about vasectomy in this particular scenario. And then when they say, okay, no, but after all that information, she still wants to go ahead with the sterilization, that's fine. I will say, as long as she understands all those risks associated we discussed, and even the VTE and all that, there can be even a life-threatening risk there. If she still wants to go ahead, that's fine. Obviously, there's a patient's right to make that informed decision. We will arrange for this sterilization to be done. Okay, so what you're going to do now that, but you will say, so after that discussion, if she wants to go ahead, I will take the consent. I will, document all those complications and the discussion which has taken place. And then I would discuss with my consultant as well. And we will like this woman to have some time before the sterilization procedure is done, like about 2 to 4 weeks time. So she has the time to reflect on her decision as well. Yeah. So because what is happening, all the information we're giving her now is just here in the clinic. She came already overwhelmed in her mind that I'm going to go for the sterilization, and these doctors are also going to refuse me, just like my GP did, and felt like I shouldn't go for this. So she's actually not paying that much attention to us, all those information we are giving. She may not do that, right? Because she's already prejudgmental that they will actually tell me not to, but I'm going for sterilization, right? So for that reason, I will also give that information about the procedure and all these complications with emphasis on that the risk of all these complications is much higher in her particular circumstances. Yeah, in her particular circumstances. And then obviously you will, for about those 4 weeks time, obviously we will offer her to have some contraception and use condoms regularly, or we can discuss. I mean, if we have to even give her one of Depo-Provera, I will actually offer her to have a Depo-Provera. I won't rely on the condoms for this woman either, if she, being on that medication. Okay, so this is how you proceed. And then obviously you will say, for if they say, okay, so what you preempt for this one, then you will say, okay, so this is going to be high risk surgery. Preferably should be done by the consultant, and if not, then under direct supervision or consultant being available. And then if the split the time allows you, then you can talk about planning and all that review size. So preferably we'll try to do through the laparoscopic because of, to reduce the surgery time and shorter hospital. Although you will mention, you realize the laparoscopic procedure is also going to be quite high risk. And because of this BMI and the adhesions, the entry route may need to be changed to open technique instead of just the Veress needle. You will be aware of high risk of injury to the blood vessels, and so there will be a discussion with and you will have the backup of those surgeries. You will also take the consent from this woman that if any injury happens to any viscera, or if she start bleeding, or it's difficult to complete the sterilization process through the laparoscopic procedure, we may need to, do a mini laparotomy, or you can do a small incision, penetrating incision to try to complete that incision. So that consent must be taken as well. So that's what is required for the discussion in this station. Okay. But in the beginning, the very first thing will be try to understand her reasons and the concerns. Does she has any pressure to go for sterilization? That is also important to be excluded. Is that her independent decision, or she actually has been pressurized? There is any pressure she feels on her, maybe from the partner or what? Any quick questions?
Ma'am, should we also do an STI screening because she's in new relation for last 3 months only?
Yeah, that's an additional thing. When it comes to the management and they say like what else you would like to do. So after that consent, yes, you will offer her STI screen. You will put her on contraception, maybe to preferably give her Depo-Provera while she's for the list, and she can also reflect. And you will give her open option that she can, if she wanted to change her mind, she can always contact emergency cancer and put her on LARC method.
Okay, ma'am.
Okay, so next one is for you, Pramila. Let me see which one. Okay. This is for you, Pramila.
Okay, ma'am.
Okay, that's your first 2 minutes.
Good morning. I'm Dr. Premila. I'm ready for the structured discussion. We have got here a patient, Haley Jones. She is 28-year-old, and this is her first pregnancy. And she is 9 weeks pregnant, and she has come with a scan report of CRL, single intrauterine pregnancy with a CRL of 10 mm, but there is no cardiac activity. And I also have got her investigation reports, which shows a low platelet count.
Okay, so what is your impression of these results?
So as far as her ultrasound report is concerned, her CRL is more than 7 mm, and there is no cardiac activity till now. So that means this is a missed miscarriage. But anyway, if only one person has done this scan, I would like to repeat the scan and make sure there is no cardiac activity to confirm that this is.
Yes, it has been confirmed by the second sonographer as well.
Okay, so this is a missed miscarriage. The person she has to be told that this is a pregnancy which is not viable, and there is no point in further waiting for the cardiac activity to appear, because otherwise it should have been appeared by this time. So she will have to think about, she will have to be given option of terminating this pregnancy. And but the concern here is her platelet is quite low. So I would like to take a detailed history, past medical history from her to find out whether what was her platelets, if there was any such history before, whether she has any history of ITP or any other platelet diseases earlier which has been told to her.
Yes, she is diagnosed with idiopathic thrombocytopenic purpura.
And I would like to know whether she is on any medications for the same.
So she's under care of hematologist, and she is taking the medicines which are given to her.
Okay. And did she have any recent fever or any viral infections recently?
No.
Which can explain this sudden fall in platelet also. And was she compliant with the, I would like to know whether she was compliant with the treatment also, because with the treatment, the platelets usually will remain at least above 50,000, they will usually keep.
Yeah, there has been a problem with the compliance, but she doesn't have any history of recent illness.
Okay, okay. So for her, normally when we have got people who have got missed miscarriage, we can give them 3 options. One is conservative management for 2 weeks, another one is medical, and the other one is surgical. But the problem with conservative and medical management is it will take long time for the missed miscarriage to be aborted, and during all this time she will have continued bleeding, which is, and with her low platelet, and this is likely to be more severe bleeding, and it can be a problem for her. So in her case, I think we will have to first try to correct the platelet, and along with that we will think about terminating this surgically once the platelet values goes above 50,000. So till that time we can keep her in the hospital. We can either give her platelets, or we can give her injectable steroids to improve the platelets. According, I will take the opinion from the hematologist who is seeing her, and according to his opinion, we will give her the treatment and try to improve the platelet first, because there is no emergency at present. She is not bleeding, or if she's not having any problems as of now, we can gain a few days to improve the platelets with the treatment, and then
yeah, okay, that's fine. She opted to have a medical management, and her platelets were corrected. She left the hospital with a platelet count of 130,000, and she wanted to have a medical termination, which she did. She was advised to do pregnancy test after 3 weeks, but when she did pregnancy test is still positive. and she's having some bleeding. So she has returned back to the hospital. What to do now?
Okay, so even after 3 weeks of medical management, if the urine pregnancy test is still positive, then we have to repeat the ultrasound and find out whether the products of conception is still remaining inside the uterus. And I will also like to, in these days when she went, her platelet was 1.3, but now in this few weeks it might have again dropped. So I would like to recheck her platelet level and find out what is the platelet level. And if the platelet level is okay, I would like to go and do a evacuation of the uterus under antibiotic cover with sufficiently arranging the platelets. And I will also explain to her that there are some problems which we can expect when we are doing a surgical evacuation. There is a small risk of injuring the uterus and the cervix, but we will be taking care for that. And with her ITP, there is a more chance of having bleeding also. So I'll make sure the blood products are ready, and if needed, she can be even given antifibrinolytic agents to prevent bleeding. And she will be closely monitored in the hospital even after the procedure.
So
and
is there
that
any
products, yeah, I will send those products.
Okay,
Yes,
just give me 1 second. So is there any
yes.
other investigation you would like to do before you do the
Yes,
section
I would
evacuation?
like to, because the UPT is still positive, we will have to also consider the fact that there could be a molar change in this. So I would like to do a baseline beta HCG level also. And after evacuation, I will definitely send the products for histopathology examination to rule out a molar pregnancy.
Okay, so right, okay, so she has the procedure done, and then the histopathology confirmed partial mole. What follow-up you will arrange for this woman?
So this lady, she has to be registered in the one of the 3 clinics where GTT centers are there, whichever is nearer. And according to their advice, she will have to follow up with beta HCG levels once in 2 weeks. And this is a partial mole. So once we get the report, if we get 2 normal values 4 weeks apart, we can till that time we have to have the follow-up. And after and she has to be told that this follow-up is very important, because there is a small 0.5% chance of she going in for persistent trophoblastic gestational trophoblastic neoplasia. So she has to have close follow-up. Until her follow-up is over, she should not get pregnant. So she should be given options of contraception also. And among the contraceptives, other than copra UCD, all the contraceptives can be used once the beta HCG level starts to fall down.
Okay. So what advice would you like to give her regarding her next pregnancy?
This is a partial mole, so the chances of recurrence is quite low, especially if she didn't have to have any chemotherapy. So if it was just a partial mole, when she becomes pregnant, you have to tell her that she has to have an early scan and make sure there is no molar change. But there is no need for sending placenta for HPR and doing beta HCG after 6 weeks after delivery, like we used to do previously in a case of molar pregnancy, which didn't require any chemotherapy.
Okay, so what will be the follow-up plan if she required chemotherapy? How you proceed for those patients?
Okay, if she required chemotherapy, in those patients, we will look at the score, their FIGO scoring we will look at, and depending upon the FIGO scoring, if the score is less than 6, we will give them single agent chemotherapy with methotrexate and folinic acid. And if it is more than 6, they will have to use combination chemotherapy. And those who had single agent chemotherapy, they have to have follow-up for 1 year, and those who had combination chemotherapy, they should have follow-up for 2 years. And during this time, we have to give them sufficient contraception to becoming pregnant till that follow-up time is over. And they should be also told about the need for taking these chemotherapeutic agents and they should be told that this is a condition which can be 100% cured.
Yeah. Okay. Your time is just over.
Yes.
Good. Well done. Very well done.
Thank you.
Nicely done. So yeah, this is how these sort of discussion stations should flow. Yeah, they are usually very, nice guidelines. Keep it individualized, and then after that, if the the examiner asks you the questions, then obviously you can answer from just from the guideline. So the first half was fine. So what basically happens now, we have just extracted that information and put, but in the real exam, there were few papers in those 2 minutes you were supposed to read. So in case we don't expect that next exam will be online, it is going to be normal exam. But in case if it's online exam, you must make sure that you scroll down your screen and keep reading all the information given. Because in this particular scenario, or even other ones, the candidates told there was some information in the first paper. They have to scroll down to look at the scan report. There was original scan report given over there. And then these investigations, they were given in the college, the hospital investigation form as well. I will add up now in coming sessions the actual, how these investigation results and blood reports, do they look like, and others, so you become familiar, all of you, with the hospital notes as well, what they look like. So make sure you scroll down right up to the down to get and gather all that information to pick up, because this platelet count and stuff which we have given like this is not given over there. It doesn't say it below. You have to pick up from the investigation report.
Will they
That's
give
one
some
point.
bold letters? Nothing. It will
So
be all...
the abnormal results usually are either highlighted, but I don't know exactly how on the screen it appears. But when we get those results from the lab, they are either highlighted or there is an asterisk mark next to them. And the most easiest way to do is there is always the range given, of normal range given next to them anyway.
Okay.
But there is usually some asterisk mark or something to point that this result is abnormal, so that we can, they can catch the attention of the clinician. I will put those so you are familiar with that. Okay, so yes, that's fine. To start with, the way you summarize was excellent. To say this woman is this many weeks and this CRL, and then explaining her about the second scan report, that was fine. To tell her this is no confirm at this one, if there is no heart activity, then obviously there's no weight, and this is we call missed miscarriage. Options, yes, it was fine. That information gathering was good regarding her low platelet count, what diagnosis she is ITP, or what else is she on medication, and what's happening. MDT approach here, yes, you need to consult hematologist regarding for the correction of her platelets. We don't need to keep her in the hospital till even she opted for to go path. That all depends what treatment we have to give her to correct her. Are we going to transfuse? So you can discuss the way you will say. So instead of saying she needs to have, she have to have, or she will, instead you will say these are the two options. It can be corrected by the either by the platelet transfusion or by injectable steroids. And then obviously with the consultation of the hematologist and also the information regarding what she chooses, you will try to correct the platelet count, and you discuss the options, yes, conservative, medical, and surgical. So when we say this will be, I wouldn't say that I feel this will be better option. There is a clear guidelines there, yeah, for these one. We know the guideline says the surgical management is better. So the way I will say, because it's again clinical colleague to colleague discussions, you can simply refer to the guideline to say, as the NICE guideline, or as Parker that recommends the surgical management of miscarriage or the miscarriage for these women, to have the control procedure to reduce the blood loss, and in case of any heavy bleeding, we can correct that immediately. But obviously, if she wants to, we can give her obviously whatever the option she takes, with the full information and safety netting that we need to inform her. Then, like if her bleeding is quite heavy with the clots, and she feels dizzy or lightheaded, anything in that case, she immediately needs to ring the ambulance and there is a risk of heavy bleeding with this. Okay, so that was very important point to tell her safety netting if she chooses any other method other than surgical. So the medical one, she goes and she comes back with the pregnancy test positive. A little bit improvement here, Pramila. You need to add a couple of points here. The first of all is, yes, so obviously this bleeding reason can be any. It could be because of IUP or it could be molar or something else going on, a retained product. So first thing we do is we will examine her, and then we do the beta ECG and a scan straight away. Yeah, the scan will be done. And beta ECG will be taken, her full blood count will be sent. So it's not only the platelets we need to check here, we also need to check her hemoglobin as well, yeah, if she has been bleeding. Roxana, please look into this matter. Sorry, what? Is it regarding the audio? Roxana, I have read your message from WhatsApp group, but you seem quite worried. I think you joined us late. Admin is actually opening those. They will be open and available to you people who are in the course for us. Okay, don't worry, that will be sorted out previous to sessions, those free session ones. Okay, so coming back to this one, yeah, so you will say like, so full blood count to check our hemoglobin as well, platelet counts, and also then the counseling about the possible reasons. Yeah, it can be because of this and it could be because of some other. So you send beta ECG and then you send the scan. The other important question here is to check whether, I will ask from the examiner here, that was the products of conception sent for histopathology or was she asked for? Usually, obviously, first miscarriage, we don't send histopathology, but that question needs to be asked. Yeah, so the answer is okay, no, we didn't. And then they give you the report, beta ECG, and then they put the scan report there as well. So from the look on the scan, it was honeycomb appearance, and beta ECG level was quite high, 51,000 or something, quite high. So from there, then you can start about your differential diagnosis. So your possible can be about this, the molar pregnancy. So that will require, again, you will inform your consultant. You're going to check her hemoglobin and platelet count as well. And, if platelet count is correcting, she will be given platelet transfusion. And then she will be planned to have suction evacuation. Now, this suction evacuation must be done by the consultant. Okay, these are the few important points which we must be picking up. Okay, so this section touch needs to be, because usually the molar pregnancy, molar evacuation should be done by the consultants or the consultant in the theater. But we do know even the section, normal section evacuations after, incomplete miscarriage or retained products, that become more high risk of perforation. But this one being molar, we need to know here, say that we are aware of this safety point. That this needs to be done by the consultant. Okay, so hematology consultation again, and then she will have a suction evacuation, and we will say this woman is very high risk of having heavy bleeding during the suction evacuation and the risk of perforation. So she will have ultrasound guidance. So we will be doing this evacuation under ultrasound guidance with the backup of, in case, with the plan of management of hemorrhage or perforation in case this happens. And then yes, so your counseling is also involve about telling about the molar pregnancy and histopathology. Do you want to put your mic off? I think it's causing a lot of echo. Yeah, so we will explain the woman just like as we do that is molar. So I will explain her what molar is. We can't forget the doing counseling to the woman. Yeah, so just say we'll explain what molar pregnancy is, and then all the follow-up. Follow-up was fine, excellent. Yes, you will send the histopathologies. It comes back as a molar, partial mole. She will be referred to, instead of she have to go there. No, she will be booked because we will be doing that. So she will be booked into regional gestational trophoblastic disease center, where she will have follow-up on urine test for beta HCG, and then it was fine. The rest was excellent. The way if it's partial, what will be the follow-up? If it's complete, what will be the follow-up? And if it's chemotherapy. And the examiners, the people who managed to get up to the paper, the examiners did ask them these questions, okay, about the chemotherapy and stuff, what it was. So just again, learn it from your guideline completely. So yeah, any questions? Awareness of the safety point is important in this scenario, okay? correction of these ITP, giving full information, evacuation to be done by the consultant, awareness, and to say the high risk of perforation, bleeding, hemorrhage, and the backup plan to control them if they happen. They are key points here. Right, any question?
Doctor, what about blood group and NTD?
Yeah, you can ask. Yes, the blood group will be done, obviously. That will be done in the beginning anyway. And what else? MDT?
No, injection NTD.
NTD. Yeah, you can mention that according to the blood group. If it's rhesus negative, then we will arrange NTD as well. Okay. Yeah. Okay, next one is for you, Sujata.
Okay.
This is for you, Sujata.
Sure.
Okay, your 2 minutes start now. Okay, that's your first 2 minutes. You can start
Hello,
now.
Hello, I'm Dr. Sujata, one of the doctors in the clinic today. Can I confirm your name and age, please?
Yes, doctor. My name is Dawn Morley, and I'm 32 years old.
Yeah. How do I address you?
You can call me Dawn.
Yeah, Dawn. Your notes say that you are pregnant and you had some abdominal pain and spotting, and you have done an ultrasound and you've come to discuss the report. Is that right?
Yes, doctor, that's right.
Dawn, is it all right that I ask you a few questions about your pain and bleeding before I discuss the scan report?
Yes, doctor, you can. I'm really worried, about my pregnancy though. I'm really worried because of this pain and bleeding.
Yeah. How is the pain, Dawn?
It's better now. It was really bad when I came in, but it's better now. There is hardly any pain.
Okay, and what about the bleeding?
That has almost stopped as well. There was just a bit of bleeding on the wipe, really, bit of spotting.
Okay, and is this your first pregnancy, Dawn?
Yeah, this is my second pregnancy.
Second pregnancy. What about your first pregnancy?
There was normal vaginal birth I have, yeah.
Okay, and baby is fine?
Yeah.
Dawn, is it all right that I ask few more questions before I discuss, or are you worried about the scan?
I mean, you can ask if you want to, but yeah, I'm really worried though.
Sure.
Is my pregnancy okay?
Yeah, I'll come to that in a little while. Are you medically fit otherwise, Dawn?
Yeah, I'm fine. Yeah, I have no problems.
Have you had any surgeries in the past?
No.
Okay, and are you aware of your blood group?
Yes, it's A positive.
Okay. Do you have any reservation for blood transfusion if needed?
No.
Okay. And do you have any known allergies?
No, as far I'm aware of, doctor, no.
And what do you do for a living, Dawn?
I work in a shop.
So, okay. And are you well supported at home?
Yeah, my partner is quite good and supportive.
Who takes care of your child, the first child?
I
Is there
look after my
somebody to?
child, my partner and I
Okay,
both together.
sure. And are you aware of your height for weight ratio?
Yes, that's 25.
And some few personal questions. Do you smoke?
No, I don't smoke, doctor.
Okay. Take alcohol?
I do, but I stopped since I knew I was pregnant.
That's good, Dawn. And any recreational drugs?
No, I don't use any drugs.
Okay. And have you felt down or depressed in the last 4 weeks?
No,
Okay. And is there any family history of clots in the legs or lung?
no.
Okay. Dawn, is there anything else you want to share with me?
Well, I don't know. I'm just worried about my scan report.
Okay.
I just want to make
Okay.
sure my pregnancy is okay.
Okay. We'll now come to your a scan report. Has somebody examined you when you came to the EPAU? Was your blood
Yes,
pressure and pulse rate?
yeah, they
Okay.
did examine me.
Okay.
They said it was okay.
Okay. And I've confirmed that this ultrasound belongs to you with your name and NHS number. And before I discuss, is anyone with you?
Uh,
Do you
no,
have?
no.
Do
Why,
you?
doctor? Is everything okay?
Yeah, I'll be. Yeah, I'm coming to that. If do you want my nurse to be with you while I share the scan findings with you?
No, I'm okay, doctor. Just let me know.
Um,
Is anything wrong?
sure. Yeah, I don't have very good news for you, Dawn.
What do you mean, doctor? Can you
Usually,
please tell me?
yeah, the thing is, in a normal pregnancy, we expect to see the baby inside the womb. But here, we are not seeing anything inside your womb. However, there is a mass in your right tube. Like this is the uterus. I'm showing you. This is the uterus, and we have every woman has two tubes, and then the ovary. Usually, the baby is formed in the tube, when the egg and the sperm meet, and then the baby moves inside the womb and then further it grows. So we should, in a normal pregnancy, we should see a baby inside the womb. But here, inside the womb, there is no baby. However, there is some baby we are seeing inside your tube on your right side. Have you
Okay.
heard of a term called tubal pregnancy? Have you heard of this?
Yes, I have. One of my friends had that. So is you saying my pregnancy is growing in the tube?
Yeah, so I'm very sorry to tell you that this will not be an ongoing pregnancy because the tube will not be able to support the growth of your baby.
Okay.
And I'm very sorry to be the bearer of bad news. Dawn, are you all right?
No, you don't have to be sorry. It's not your fault, doctor.
Yeah, so is your
All right.
partner around? Would you like to
Yeah,
call him
well,
for
no, he's at
support?
work, but I can ring him. But I'm okay for the time
Okay,
being. Like, what?
yeah.
So what happened now? Was
Yeah, since this pregnancy cannot go forward and there is heartbeat of the baby, I'm very sorry that can I offer you tissues? I can hear you sobbing.
it's all right. I'm okay, doctor. Just tell me what to
Okay.
expect now. Yeah.
Yeah. So this, since it cannot go forward, we'll have to remove this pregnancy. It it can be done through two means, either through a keyhole surgery or we can make a small cut on your tummy and remove the uh, pregnancy tissue because the baby's heartbeat is there. There are other options also. We could give a injection. So I would, but that is not applicable in you, or we cannot wait for it to die by itself because the heartbeat of the baby is there. So the
Sorry, doctor. I'm just a bit confused here. So, yeah. So I understand it needs to be removed. Then it can't grow. So one is to have an
yes,
operation. So what is the other injection thing?
the injection also would have been an option if the baby's heartbeat was not there. We need to get further details about your pregnancy hormone. I'd like to do some tests to see if the baby's the pregnancy hormone level as well as the size of the mass. But an injection will not be a good option for you because the baby's heartbeat is there.
What
So
is
a
this mass,
surgery will,
what you
yeah,
mean
the
mass? You have some,
yeah,
yeah.
sorry, the baby is growing in your right tube.
Okay.
Yeah, so we call it the tubal pregnancy, and
Yeah.
the baby's heartbeat can be seen in the tube on
Yeah.
ultrasound.
Okay. Right. Okay.
So I'll be offering you a surgery. You will have to get admitted. And when was the last time you had food, Dawn?
Um. I had breakfast this morning. It's about 3 hours ago.
3 years ago. From now on, please don't have anything because we'll be running a few tests. We'll see what we'll do a full blood count and further test before we do this surgery. And meanwhile, while you're waiting for your partner to arrive, I'll also give you information leaflet. You can go through the options. You'll be seen by the anesthetist doctor also. We can You can go for a keyhole surgery because your BP and pulse are stable. Is that right, Dawn? Yeah, a small cut under your through your tummy, and a telescope will be camera will be inserted, and we can remove the pregnancy tissue through that. Is that right?
Yeah. Your time is over, but you can, if there's anything else you need to tell
Yeah,
me. So,
yeah.
right. So,
So
does that mean, you will remove my tube as well?
yes, Don, that is the best option because there is something must have been wrong with your tube, that the baby started growing there. So it is better to remove the tube. That is the best option. And we will also see how your other tube is. And once you get over with the surgery, we'll repeat pregnancy hormone level after 3 weeks to make sure that everything is normal. And we'll be offering you contraception also, so that effective contraception, so that you will be safe from not getting pregnant for few months till everything
Okay, so we'll stop here.
normalizes.
Okay, we will
Yeah.
stop here. Thank you very much for doing this station. Okay, so few words. If you can intentionally try to remove them from your conversation.
Yes.
Have to, we have to, or you have to, and must, yeah? They must go away. We don't use these words, yeah? It can be done. We can do this. This can be done. These are the replacement words. It is recommended. It is assumed to be more safer option, like
Sure.
this. Yeah.
Sure.
Okay. So I wasn't very much clear, basically, at the point of tube, exactly what operation I will have and what, that injection and stuff. I think need to be a little bit organization at that point, how we explain these. So to start with, yes, introduction of the patient. The first one is to establish the immediate well-being. Just short intro first to say, I understand you came here because you had some pain in your tummy and some bleeding and you're 7 weeks pregnant. I won't talk about the ultrasounds yet. Can you all hear me?
Yes.
Yeah.
Dr. Sir.
So instead, I'm just going to first, if you remember, we did in our other presentation as well, is the first point is to immediate well-being. Yeah. So just after saying, I can see you're 7 weeks pregnant and you came here with some pain in your tummy and some bleeding. So tell me first, how is your pain now? Is it better than before? Is it improved? So she told you, well, that's almost gone now. And what about your bleeding? And then she tells you about the bleeding. No, this patient, I think the something which could probably penalize you was she's repeatedly saying, I'm really worried about the scan. Is my pregnancy okay? I know you did ask at some stage, can I ask you more questions, or I tell you the result? And the answer was, well, you can ask what you need, but I'm really worried
But
about my
again,
pregnancy. Yeah. So
sure.
it's not a
Sure.
straightforward option, because for a patient, I don't know, what is. You will say, and I will say, I will think it's really important to ask questions. Then I will say, okay, but you need to establish, I'm worried about this scan, okay, and the report. And when we have these type of scenarios, if the result, whatever we are going to mainly discuss and talk about, you need to ask yourself first, do I need to gather further information before I give this result? Or is that information actually going to change the way how I'm going to interpret this result and then give it to the patient? Or it's not going to make any difference. This report is going to stay as it is. Yeah. So this particular report is not going to get changed even after taking the history or anything. Why we need
Yes.
further information in this woman is then to
For
make the
management.
management plan. Yeah. So
Yeah.
I usually prefer, and we give results first, because this woman has
Okay.
gone through a process by the time till now. She came in A&E, the nurses have taken the history, she has been examined already, and then she had a scan. So there is a process going on with her. And now she's been told the doctor is coming to discuss scan report with you. And then the doctor comes, then she starts the morning practice all again. Tell me about this, tell me about this,
Yeah.
tell me about this. She's
Sure. Sure.
anxious. Yeah, she's anxious. The women know it's just the sixth sense of a human being. Yeah, she also know if the
Yeah.
pregnancy would have been okay. The sonographers, they happily tell you, don't worry, your pregnancy is fine, it looks okay. But yes, I'm gonna give this report. Just wait for your doctor to come and talk to you if there's anything they need to do about it, right? If she hasn't been given the report, it's just we all know then It's probably not right.
Yeah.
Something is not right.
Sure.
Yeah. So this woman is very
Yeah.
anxious. So the way I will say, the girl, I'm just going to be very open and straightforward. I'm not going to prolong her anxiety. Who knows how long she has already been
Sure.
waiting for me to come and tell the report. So I'm just going to say, okay, yeah, I can see, it can be quite worrying. So yes, I have the scan report with me, which I'm going to discuss with you. And now at this stage, instead of just in a general way to ask, is there anybody with you? No, I'm just clearly going to tell her why I want her to have somebody with her. So I will say, no, the scan result, the scan report may be unexpected and upsetting for you. Would you like to call some family member or your partner to be with you when I discuss this report?
Okay.
Are you okay for me to give you this report? Okay.
Sure.
So then obviously, no, she clearly know why we want her to, right? So no, that will be informed decision she makes. No, I'm okay. Tell me what the report is. Then I'm going to quickly make a picture, the uterus, tubes, and the side and the ovary, and I will say, so normally what happens, the pregnancy, the egg come into the tubes, sperm-made pregnancy starts here in the tubes, and then it moves down and, get into the womb and start growing into the womb. However, sometimes if the tube is narrow or if the tube is, kind of quite narrow or obstructed for some reason, this growing pregnancy cannot pass through the tube. It gets stuck into the tube and it tries to grow over there. But obviously the tubes are very narrow, pregnancy cannot grow in there. As a result, they will be first, initially there will be a pain the women will feel, and then sometime it can rupture. Okay. And then I'm going to say, I'm afraid in your scan, your pregnancy appears to be developing here. So then I'm going to actually make a circle, including the area, the tube, and the area between the tube and ovary, and a part of tube as well. Because be careful again here, what the scan says, right, adnexal mass.
Adnexal.
Scan doesn't say
Okay.
tubal. Yeah,
Tubal.
it doesn't say tubal.
Yeah.
I'm not going
Yeah.
to just make up that information for myself. So I will say,
Sure.
your pregnancy, the scan shows your pregnancy is growing over here. Be careful here. Do not use the word baby. Yeah, pregnancy. Your
Okay.
pregnancy is growing, because that can be quite, difficult word for a mother.
Upsetting.
Upsetting. Do not use the word mass, because what is happening when
Okay.
you are saying your baby is developing and then you're saying mass, that makes me to feel
Mass.
worry. Is that mass something else? Is that some growth? What is that then? Just say growing
Okay.
pregnancy. Your pregnancy is growing over
Growing
here
pregnancy. Yes.
in this area. And but at this stage, we're not quite clear from the scan report whether it is in the tube or in this area in between, or even it can be on the ovary. However, the most common side for these type of pregnancies is inside the tube. Okay, so
Okay.
it's probably likely to be in the tube, but it could be here. We're still not, that's not confirmed yet. And then obviously give her a little time to say, see what type of reaction she is. If she's not very much upset, we don't need to go into too much drama either. You need this or you need this.
Okay.
No, just see how she is. Obviously, she will be bit, or even
Yeah.
she's clearly upset, then give her support to say, if she's quite upset, start crying or anything like that, then you can give a little pause to yourself and then ask her, would you like me to give you some time? Offer her again. If she's very upset, offer her again, would you like me to ring your partner to come here for you? Or, instead of asking her, where is your partner? No, offer her, be supportive. Would you like me to ring your partner
Okay.
to come over with
Okay.
you? If she's not too much crying and upset or but just a bit quiet, then just say, well, I can see it's quite upsetting for you. Would you like me to give
Okay.
you some time to come to terms with this? You would like to now tell me what to expect from here? Yeah. So it
Okay.
depends. Different people have obviously different response to such situations. And then I will say, okay, so obviously this pregnancy cannot grow, cannot continue to grow here because if it's growing in the tube or even, on the ovary, it's a small space. So what happens? This pregnancy, it can rupture, and that can cause life-threatening bleeding. So it's very important that we actually remove this pregnancy immediately. Okay, no, I will bring the heartbeat and I will see. And your pregnancy seems to be quite advanced already because we have been able to see the heartbeat. And again, I'm not going to say baby, pregnancy. Your pregnancy has
Okay.
advanced and we can see the heartbeat as well. That means the risk of, and why I need to do that, mean the risk of actually rupture and causing right-sided bleeding is very high here in this
Yeah.
case. Okay,
Sure.
and then you say, so the way we deal with these pregnancies which grow outside the tube, there are 3 different ways we do. So there is a one way that we do a small keyhole surgery, which means we put a camera just below the tummy button, have a direct look inside, and then keep mentioning your picture as well to see exactly where the pregnancy is it tube on the tube or everywhere, and then remove it. So at this stage, just simply tell her small introduction, yeah? If it's in the
Okay.
tube, then with this type of, advanced pregnancy, then the most safer option is actually to remove the tube along with it, because otherwise, it may not be removed completely, or there can be quite a lot of, additions in that tube for the future pregnancy again to happen into the tube. However, that will all depend at the time when the surgeon who will be doing that surgery, they will check the other tube first. If that tube is healthy, that mean your chances to get pregnant will remain same, then the tube can be removed. In case if the other tube looks like diseased or maybe that's blocked or anything like that, then sometimes they try to, and then you can just on your picture again tell they might try to milk out the pregnancy. However, it's difficult for me
Okay.
to exactly tell at this stage what they will do, because they will all depend, it depends as well how advanced the pregnancy
What they
is.
find. Yeah.
All right. Now, in other cases, if the pregnancy is not this advanced, the pregnancy is where there is no heartbeat started yet, the other options available can also be to treat them with some medicines called injection we give called methotrexate, which can be given, and that can be repeated as well. However, that doesn't seems to be, that is not suitable and safe option in your particular circumstances.
Sure.
Yeah, because of the advanced pregnancy. If she says no, tell me the detail of that as well, then it's fine. Tell her the methotrexate, we will do some tests, give you this injection, and then this, and then you must say as well, like, okay, this will be something to discuss with my consultant as well. So all that stuff. So then after that, before we can't straight away tell her when you ate last time, so do not eat now, and we're going to take to
Okay.
theater, because we don't know what she wants. So at this stage now, I need to ask her how
Are
you
you
feel
ready
about
for
what would you like us to do. Yeah. So if she says okay, when you will do this surgery, that well, it's important that we do this and remove this pregnancy as soon as possible, because as I said, it can rupture at any time otherwise. Hello.
Dr. Safia, can we
Yes.
directly say to her, is expected management and medical management not option in your case, because we can see that pregnancy with the positive heartbeat?
So when you will re-listen this recording, just listen the way I have phrased the same things, yeah? So
Yes, okay.
the way I have said to her is, we have said like the safest option is to remove it by that keyhole surgery. And then the way I have explained is to her is to say, because I don't want to take the responsibility. Our job is to give them informed, the information, evidence-based information. If I say is not the safe option for you, unless basically she goes and say in spite of, instead I will say in a word to say the safer option in your circumstances is this, because the pregnancy is advanced. If the pregnancy is not as advanced that there is no heartbeat, then there could be these options as well. However, in your particular circumstances, this is the better option. Okay. So this is how you're going to phrase it. And then you will say at that stage now, after asking, now, yes, we need to get the information, okay, further, because that information now going to help us arrange her surgery or whatever. So now you ask her, what is your blood group? Is it your first pregnancy or whatever? Usually that information is given about the number of pregnancy, how was your previous pregnancy. I wouldn't be worried about here, because there is a quite lot here to tell. I know ideally we do talk about who look after your child and who is this and blah blah. In this particular scenario, there won't be enough time, because there is too much for you to talk about, to explain what the topic is, what are the options. Then you need to explain that laparoscopic procedure. So I won't worry about the child, who is looking after the child and all that stuff. All I'm going to ask her
Sure.
is previous pregnancy, yes, were there any problem in that pregnancy? Normal Okay, that's fine. And then ask about medical history. She has any, and again, simple history. Do you have any medical conditions, high blood pressure, diabetes, or any condition you need to see your GP regular? Are you taking any regular medication? Any operations is important here now.
Yeah.
So now you need to keep in your mind what can actually increase the risk of ectopic. So 2, 3 main things. One is obviously any previous history in that region, which could cause additions, any previous STIs. Yeah. So just ask
Yeah.
about those two. There will be marks for them. And then you will ask her about what she wants to do. If she has made a clear idea to say, yes, no, that's fine, doctor, if that's safe, then it's okay, I would like to go ahead. Then you can say, okay, so I'm going to discuss it with my consultant as well, and then we will make arrangements for this surgery to be done. And then you can simply tell her about the laparoscopy, just if shorter version, like we will tell you, and I will discuss that in detail again with you, just to give you an idea. What we usually do, we pass a camera through the tummy, just below the tummy button, have a direct look inside. So there's a blind procedure. When we put the camera inside, there can be a risk of injury to your blood vessels, bladder, bowels, and sometimes some bleeding as well. However, we are aware of these complications. It will be done by experienced clinician. And at any stage, if you had any suspicion that there might be some injury or any bleeding, then we may need to actually open up your tummy to correct those. Okay. So
Sure.
that's the answer. Then you can say, and then I will discuss with you after that. We will discuss you about how we're going to actually follow up your, further regarding this. That's enough.
Sure.
Any quick questions? Okay, that's fine. Everybody's happy.
Ma'am, suppose
Yep.
she insists on medical management, we will be keeping her in the hospital itself, isn't it?
Yes. So if she says, if after all that stuff, she still says, okay, but I would like to do, know about the medical management, then yes, we will explain her. Then we will need to obviously explain her first to say that, that can be quite tricky and difficult. And first of all, if it is in the beginning, I will say the chances of failure of that procedure are quite high in your particular circumstances. However, if you wanted to go for that, then first obviously we will need to give some injection inside to stop this heartbeat, and then we will do this injection. And because this is quite advanced, there is a very high risk it can rupture and cause life-threatening bleeding all the time. So at this stage, I will say, I will discuss with the consultant. We may then like to keep you inside the hospital till we repeat these hormone levels after 72 hours again to see that it has been working. So in case if it rupture at any stage, we can shift to the theater straight away. So we need to clearly tell the chance of failure is high. After the injection, it can still, even before the failure, it can rupture, and then the option will be to take you to theater to remove it surgically. If she says, well, I near very close to the hospital and all that stuff, then we can say, well, this is what will be more safer, but I will, I will discuss with the consultant, and then, we can make a plan for you, what is safer for you. So yeah, again, then, as long as you understand these type of where the patient chooses some option which according to our information is not safe, we conclude by saying, as long as you understand the best and the safer option in your particular circumstances is to remove it by the operation, and that if you choose this medical one, the chances of failure are quite high. The risk of this rupture and life-threatening bleeding is quite high. If you still want to go ahead with the medical management, it's absolutely okay. I'm going to discuss with my consultant, and then we will make arrangement for that, treatment to be started for you.
Here we have to put intracardiac injection to kill the baby.
Kill the baby. Please don't say that word. So that will be done ultrasound guided. So they will just put it wherever the
Directly
heartbeat is being.
methotrexate. Ma'am, directly methotrexate we can't give.
No, that will be KCL to stop the heartbeat first.
Okay. Then only we can go. Yes.
Yeah, and then she can have methotrexate intramuscular.
Okay.
Okay, so Sadia, are you with us? Sadia Khakwani?
Yes, I am, Dr. Jabin.
I like your name, Sadia Khakwani.
Thank you.
It's a beautiful name. Okay, so we're gonna give you this next one.
Okay.
That's about the same scenario. Okay, let's have a slightly different play with another
Okay.
ectopic. Your 2 minutes start now.
Okay.
Okay, that's your first 2 minutes, Sadia.
Hello,
Time
my name
starts.
is Dr. Sapania. I'm one of the registrars covering this clinic. May I confirm your name and date of birth, please?
Yes, doctor. My name is Louise Shred. I'm 31 years old.
Thank you. How do you want me to call you?
You can call me Louise.
Okay, Louise. Louise, I can understand that you came in the early pregnancy unit 2 days ago, and I have those reports along with the ultrasound scan with me. Is that right?
Yeah, that's right, doctor.
And you reported some abdominal pain, which was mild. How is your pain now?
Well, that's better now, doctor. I don't have pain afterwards. Just on the day when I came in.
Okay, okay. So I will quickly ask a few questions from you, and I will then explain to you what these levels and these reports these mean and what is the diagnosis. And then we can mutually decide some management plan for you according to what you wish for. Is that all right?
Yeah, that's fine. I mean, I came 2 days ago. They did some blood tests and the scan,
Hmm.
and they said they couldn't see the pregnancy. So
Hmm.
today they again called me to repeat the blood test and the scan.
Okay.
Mm.
So has anyone told you about what to expect and what is the report?
No, not really, not yet. They just wanted me to. They told me you'll come and tell me. So yeah.
Okay, so by dates, you are about 7 weeks in your
Yeah,
pregnancy. Your
yeah.
hormone levels show yes, you are pregnant, but as ultrasound scan could not see the pregnancy. So sometimes it happens when the pregnancy is too early to be seen, but we usually expect the pregnancy to be seen on ultrasound scan around the level of the hormone that we have for you, like above 2000 we expect to see the pregnancy, and your today's level is 2200. And the pregnancy was not seen on the scan, so it means you are pregnant,
Wow.
but this
Yeah.
pregnancy is on of unknown location. We don't know where this pregnancy is.
Oh, right. Okay. So what does that mean? Means the pregnancy is somewhere, but it's not inside the womb.
It might be one of the case. So we call it pregnancy of unknown location, and you can sometimes find it on internet if you have done some research or from some of the friends. It's called PUL. So it means that in one in 5 pregnancy of unknown locations, women in your situation, they can have ectopic pregnancy, in which the pregnancy is outside the womb but not inside the womb.
Yeah.
However,
Okay.
it takes some time to then make itself evident on the scan. At the moment, we could not see any pregnancy inside the womb, and there
Yeah.
was, from what report I'm reading, it seems like no pregnancy was seen even outside the womb. I will double check it with the sonographer as well. Okay.
All right. Okay. I mean, I know about this tubal pregnancy or ectopic because I had that last time as well.
Mm-hmm.
By you saying it's not in the tube either, so where is it growing then? Where is the pregnancy growing?
Mm-hmm. This is difficult for me to tell at this point, because until we have seen the pregnancy on the scan, I cannot be 100% sure where it is. And as I told, that in 1 in 5 women with unknown pregnancy location, they end up having actually ectopic pregnancy, which is the tubal pregnancy like you have had before. So is it okay if I quickly ask a few more details from
Yeah.
your history so I can
Yeah,
then
that's fine. Yeah.
yeah. So this is your second pregnancy?
No, this is my 4th pregnancy. I
Okay.
have 1 child already,
Mm-hmm.
and then I have 2 ectopic pregnancies.
Okay. And were the ectopic pregnancy both on the same side?
No, the first one was in my left tube, and they did open that tube and
Okay.
remove the pregnancy. And the second time it was again in my left tube, in the
Okay.
same tube. So that time they took that tube away. So I had only 1 tube now, my right
Okay.
tube.
Okay. And so left tube has had the ectopic pregnancy on 2 different occasions. On one, it
Yeah,
was not taken away. On the second, it was taken away.
that's right.
Did they mention anything about your right tube? Did they say it was healthy looking, or was there any problem at the time of your operation that they could see?
But I wasn't told anything other than they saw like the right tube looks okay, and unhealthy.
Okay, that's good. And did you ever have any previous infections like STIs or any pelvic infections in the past?
I did. I was treated for chlamydia twice when I was like 17, 18 years old.
Mm-hmm.
Second time, I developed pelvic inflammatory disease with that chlamydia as well, which was treated.
Okay. And any previous pelvic surgery other than these 2 ectopic pregnancy surgeries?
No, I didn't have any other operations, no.
Okay. And what about your general health otherwise? Are you fit and well or have any
Yeah,
medical?
I'm quite okay otherwise. No, I'm fit. I'm not taking any medication.
And are you allergic to any medication at all?
No, as far I'm aware of, no.
Okay. So you have had, now it makes the situation more clear to me with previous STIs and previous 2 times ectopic pregnancy, when you have had the surgeries, the pelvic surgeries as well. So you are at increased risk of having another ectopic pregnancy. Uh, normally what happens, I would try to draw a picture for you and explain to you. Like, I mean, we have one tube, the next tube can still be a focus for another ectopic pregnancy.
Yeah.
And regarding these hormone levels, when if the pregnancy gets implanted in the tube, the hormone levels do not increase like they should increase in a normal ongoing pregnancy, which is inside the womb.
Yeah.
So normally we expect the hormone levels to go up by at least 63% over 48 hours period if it is an ongoing normal intrauterine pregnancy inside the womb.
Yeah. Yeah.
If it is a failing pregnancy, then we expect them to fall more than 50%, so more than half within a 48 hours period. Okay.
All right. Okay.
So anything in between these two can be a risk and a hint towards a possible ectopic pregnancy.
Yeah. Okay. Yeah, I do understand that, doctor. I mean, this pregnancy was unplanned pregnancy. I don't really want to continue with that. You know, I wanted to have a termination, but you know, when I came initially, they told me they will just do that after 2 days. They will tell me. So, I mean, I don't want to go ahead with this pregnancy. I didn't want to go ahead with this pregnancy anyway. So, yeah. So, I mean, if I can have something for the termination, really, you know, those tablets to start the termination.
I'm sorry, Louise, we cannot just simply terminate with the medication in this situation, because if this if this pregnancy is starts to bleed at any point, it can actually be ending up in bleeding inside your abdomen, and it can be life-threatening sometimes. As we said that we could not see that this pregnancy was inside the womb. So rather than giving you those medication, we should be dealing with in a different way. Yes, this pregnancy cannot be continued or should not be continued because of the risk of ectopic pregnancy. However, there are some more options. Would you like me to discuss and
Yeah,
tell you
yeah, I
about
would, because yeah, I really want this pregnancy to be, you know, terminated
Yeah.
as soon as possible. Yeah.
Okay, so in this case, sometimes, so there are three different options for this situation. Number one is the expectant management, in which we let the nature take its course. We don't intervene. However, in your case, I don't recommend the expectant management, because we can definitely see wherever this pregnancy, it is still growing because the hormone level is increasing slowly. It is about 29% higher than what it was 2 days ago.
Right.
Okay.
Yeah. Yeah, I understand that. Yeah.
So
Okay,
I
so
would
what's the
encourage.
other option then? Yeah.
So the other option is the medical management, in which we give you an injection, and it has certain side effects as well. I will discuss it with you. One of them is that it can affect your liver function test. So we will definitely do some blood tests to see, and we will
Okay.
continue monitoring then. It's a
Your time
small,
is over, Sadia, but you can continue. Yeah.
okay.
Okay.
There is a small risk of it affecting your liver functions. Don't worry, we'll keep a continuous eye on that. So you will have to have contraception for at least 3 months. As you said, you are not planning on this pregnancy. I would recommend using some reliable contraception for the next 3 months after the injections. There is a small risk of still needing surgical intervention, even if you are having those injections. That is because there can be sudden abdominal pain, and you can become dizzy or unwell, and we end up having to have moved forward to a further, which is a surgical option, and that is our third option, surgical. Okay.
Okay. And what's
But
that?
so the surgical option is where we put you to sleep in theater, and we do a camera test through your belly
Okay, so
button.
the same way as I had last time.
Yes, it's about the
Yeah.
same way, but
Okay.
it has
No, yeah, doctor,
sorry.
I don't really want to go for that surgical one, because yes, I know I don't want this pregnancy, but you know, I would like to have another child in future. So
Oh,
obviously by that one, this tube, they might remove this tube as well, and then I won't be able to get pregnant. So I would really
okay.
like to go for the medical one.
Okay, that's fine. I would give you the information leaflet about that as well. And it's really important for a successful medical management that you keep coming for the hormone test. So usually we will give you the medication on the day one, and we will give you we will test all your blood tests. And then we call you on day 4, and then day 7, and then weekly thereafter. So for the first week, you have to come twice, and then after that weekly, till actually the
Okay.
pregnancy level has, this hormone level has gone down to non-pregnant range.
All right. Okay. Yeah. Yeah, that's fine.
Okay.
And like, I mean, is it going to terminate the pregnancy, this treatment?
Yes, it will. Yeah, it will end up this pregnancy wherever this is. Most probably chances are that it is ectopic, so it will end up this pregnancy.
All right. Okay. Yeah, that's fine. Okay. And how long usually it can take?
Usually it can take, depending upon how quickly your hormone level falls, because in about 15% cases, you might need the second injection as well. But usually it takes
Okay.
about a couple of months to come back to a non-pregnant range. And this is not a promise, this is just a rough estimate. But different women respond in a different way.
All right. Okay. And how will I know that this treatment has been successful? You know, you said like if it start coming down, and then how will I know that, it's completely terminated?
So it is just one injection, or then sometimes it can be given second dose may be required, and then it's just monitoring. So we will keep monitoring you, how well your symptoms are, if the pain is increasing or anything. And the most important thing is by checking your hormone levels on a weekly basis till actually they go back to the non-pregnant range. And when they go back to non-pregnant range, we know that you are treated 100%.
All right. Okay. So till then, I will need to keep coming every week to have the blood test done.
Yes, yeah.
All right. Okay. Yeah, no, that's fine. Yeah, I will like to do it by medical management. I really want to save this tube.
Okay, Louise, that's
Thank
perfectly
you.
fine. So I will give you the information leaflet, and I will start the medical management after discussion with my consultant.
Yeah, that's absolutely fine, doctor. Thank you. Right. Okay. Thank you, Sadia.
Thank you.
Good. Okay. Yeah, your communication style was good. That's fine, but I understand you work here in this country. Good. Right then. So, but obviously time organization, yeah. So these stations can be, obviously they are quite long stations where we need to basically explain the diagnosis and then counseling management options. So it's more of a practice to organize the time in those 10 minutes in a way that we give all the information as well. The few points here, this woman is saying, so I'm just actually starting from your last points. Is that going to really work, with this medical treatment? Is that going to work? So although, yes, before that, you have told me by saying that we give one injection and sometimes we need to give the second injection. When this woman particularly saying, and even if she's not asking, it's very important that we do tell her, because what her concern is, she wants to save her tube. But we do know with the medical management, yes, there is quite a good response to the medical treatment and it will be successful. But then equally, we know it can fail even after the second injection. And we may end up then removing it by surgically anyway. Or if it ruptured and started bleeding, then that is also the time we will need to take to theater. So it's very important and safety points to be mentioned, to this woman that it works. However, there is a small chance that we may end up in this situation. All right. So to start with, yes, your opening was good. Introduction, ask her about just with the short opening to say, I understand you're 7 weeks pregnant and you came 2 days ago with pain and that discomfort and you had some blood tests done. So before I go into the details of the reports, tell me about your pain, how is that? And then just few more signs as well. Are you feeling any dizzy, any shoulder pain and lightheadedness at all? Any bleeding down there? And then after that, you say, you will start saying, by no, this woman obviously have some background knowledge by now. Although at this stage, we don't know she had ectopic already. But when the beta HCG and the scan was done 2 days ago, she was given all that information. So we can start on fairly bit comfortable ground by saying, so, you know, we did the blood test 2 days ago to check for the levels of the pregnancy hormone. And also we did a scan to see if the pregnancy is in the womb. Your blood test showed that you were pregnant and they were rising, but there was no pregnancy seen inside the womb. So that's why we call you again today to repeat the blood test and the scan, and I have the results with me. I always like to make a picture right from the beginning. So, you know, I hope you would have been given this information already, but I'm just going to make a quick picture here that will help us to, you know, that will help to understand what I'm talking about. So just quickly again, the tube and womb. So normally, you know, the egg and the sperm meet in the tube, and then the developing pregnancy comes down and get implanted and grow inside the womb. When the pregnancy is growing inside the womb, then obviously there is a larger space for it to grow. We expect this pregnancy hormone to almost double up, or at least more than, if you want to go more precise with the numbers, then you can say about more than 63% or 65%. So much increase. But if the pregnancy is not growing inside the womb and is growing somewhere else, and the possible places can be, so you know, when she's repeatedly asking where it can be, where it is, yes, we can't tell her where exactly it is, but we can give her an idea to say, well, at this stage we do not know, because we have not been able to see on the scan where it is growing. But usually the possible places can be either inside the tube, and the picture you can see it can be inside the tube and the ovary, or, you know, sometimes it can be on the covering of the abdomen as well. We call it peritoneum. So this yet is to be established where it is. However, the pregnancy hormone levels which we have done today, they have increased, which means the pregnancy is still ongoing. However, that increase is not as much as we would expect it if it was inside the womb. Okay, so that means this pregnancy, and on the scan also, we're not again able to see pregnancy inside the womb, and we're not actually able to see, you know, outside here in the tube in this area either. However, there are always some limitation. It depends on the position of the tube and the ovary as well, sometimes that we're not able to see. Okay, but pregnancy is certainly ongoing. And then you need to obviously start. You can tell about the levels though. Your previous pregnancy hormone level was 1700. After 48 hours, we would have expected it to go above 3000, but it's not. It just raised a little bit up. It's gone up to 2200. So that means it is growing all that, blah, blah, blah. And then you say, okay, so before I discuss the management options with you, I would like to get some information. At that stage, she might have volunteered already by saying, yes, I know, understand this ectopic, blah, blah, because I have these 2 pregnancies before already. Otherwise, you can ask, if it's not given already, what number of pregnancy it is. So tell us from simple questions what number of pregnancy it is. And then I won't worry about, I know you didn't ask about, but I won't go about this, whether your period is regular or what's happening. By the these beta HCG levels, no, we know she's, you know, we should be able to say. So all I'm going to say is okay, so tell me. So she started telling about previous tubal pregnancies. She told, okay, that was a good question to ask. So when you had those surgeries, was you told about, were there any adhesions or scarring inside your pelvis? What they tell you about the other tube? Was it healthy? Or did they tell you anything about it? Yeah. And then you can progress just few more questions. So think about, first of all, again, the possible causes or the risk factors for the ectopic. So they was fine. You did ask about the surgeries, obviously the history of adhesions and any sexually transmitted infections and PID. So she gave strong history of PID and repeated. So probably she had those adhesions going on. So yes, so we can say, yeah, okay, so that can be, you know, one of the possible reasons, because of this sexually transmitted infection, they can cause inflammation inside, and that can result in scarring and adhesions. And because of this, you know, the tube may become scarred and the pregnancy can get stuck in there, or even it can, you know, build up on the tube, on the ovary. And then you will say, and meanwhile, if she starts doing by saying, well, I want the termination anyway, so go ahead with the termination, blah, blah, blah. Can you give me those medicines? Okay, those medicines, Louisa, I can see, you know, you want to have this termination done as soon as possible. However, this pregnancy, yes, it cannot grow, it cannot continue where it's growing. We need to remove and terminate this pregnancy, but that needs to be done in a different way. Those tablets which are routinely used for termination of pregnancy, they work if the pregnancy is growing inside the womb. Okay, so that's the reason basically why we're not, she's talking about typical termination like mifepristone and misoprostol. So we need to tell that won't that work for if the pregnancy is growing inside the womb. In this case, however, because it's growing outside the womb somewhere else, so the options will be, basically I will start from the first possible option which we think is better option, like, and that will be laparoscopic, because that will help us to locate the pregnancy as well. So I can start with that, but it's up to you, it doesn't matter, you can start from any option. So the one is, yes, we can just observe it, because this pregnancy cannot grow longer anyway, so it will itself start failing. So we can leave for some time, and then we can just do these hormone levels again. We can repeat in a week time or 2 weeks time to see if they have started coming down. However, there will be a risk that if this pregnancy continue to grow, then it can rupture and cause life-threatening bleeding at any stage. So in that circumstances, it's very important that if you opt for that option, if you feel any strong pain in your tummy, lightheadedness, or any dizziness or pain in shoulder, then you must immediately call the ambulance. The other option is you can talk maybe about the surgical option now, to put a camera inside the tummy. By putting you to sleep, by giving you anesthesia, put a camera inside, have a look directly, try to find out where exactly this pregnancy is growing, and then remove it, from there. So if she is okay with that, or she doesn't say, then you can just continue and say, however, there are some risks associated with this procedure. You do have, 2 of laparoscopies already, and then it looks like from your PI, pelvic inflammatory disease you had and the infections, probably there will be some adhesions. I will have a look into your notes. Okay, so this is what we need to say from your previous, because sometimes patients don't remember. So if she has those ectopic, obviously the surgeons would have written those pelvic findings over there, laparoscopic findings. So you will have a look on there to see if there were any adhesions. However, there can be a risk of those adhesions, which can result obviously in a bleeding, risk of injury to the bladder, bowels, and maybe quite a lot of bleeding. So I will explain to you that in more detail if you would like to go for that option. Yeah, so we can just leave with a shorter important information. And then you talk about the third option is medical one, in which we basically what we will do, we'll give you an injection called methotrexate. This injection will stop your pregnancy from growing. However, this injection do have some, it can affect the liver and the kidneys function. So first of all, we will need to do the blood test to make sure your liver and kidney are already, they are functioning normal and it's safe to give you this medication. Then we will give you that injection at your bum, and then we will monitor you here for a few hours, and then we can send you home. We will then repeat your pregnancy hormone levels after 72 hours or on the 4th day to see whether they have started coming down. So if it's a successful treatment, the pregnancy hormone levels either will stop where they are and they start falling, or they might have been falling already. However, sometime it may not work at this stage. So if we repeat the blood test and your hormone levels are still rising, that means the first injection hasn't worked. So in that case, again, we will discuss with you if we would like to consider to have that, keyhole surgery and remove their pregnancy. Otherwise, we give you another injection at that stage. However, the risk of a rupture of their pregnancy and life-threatening bleeding will become quite high in those circumstances. All right. So if you choose that option, then just like the first one I said, if you feel any long, pain and all that stuff, then you will need to call for the ambulance immediately. After giving these, unless clearly she right from the beginning, she chose one and said, no, I would like to go for the medical, or I try to save your time from the surgical one. And I said, no, I don't want that because I want to keep my tube, tell me medical, then obviously you can go in detail. Otherwise, if she's indecisive, you tell her these options and then ask how you feel. What would you like us to do? All right, and then if she chooses some option, particular one, then you can give further more information. If you think anything is left, I need to tell more I haven't told, like this about, you know, the if she say, for example, chooses for methotrexate, then we can say, okay, so that will be the done, and then it's important you don't get pregnant for 3 months after that treatment. So we will discuss and start you with, you know, some safe and reliable contraceptive method before you go home. So instead of leaving her, you must start or you should start, obviously we will discuss. Yeah, this is our responsibility from safety point of view, that we discuss at least and do the signposting. So this further information I will give from that stage when she has chosen. Then she said, I just actually extended a little bit more to say, okay, how I will know that I'm, you know, if that has worked. So we don't need to repeat, and we, you know, from these hospitals, you understand, Sadi, it's not possible basically to keep bringing them for, if their levels are going down, once we do beta ECG, it's not always possible to keep doing their beta ECG every week. So we basically ask them to do pregnancy tests. Once we are satisfied that this treatment has started working, the beta HCG studies have started going down, then we just offer them to do, you know, we give them those signs again. You know, if you feel any sudden pain, any lightheadedness, any, you know, then you need to come to the hospital immediately. Otherwise, after so many weeks, you can do the pregnancy test. If that's negative, that's fine. If that's positive, then you immediately need to contact us. All right. I'll give you some written information. If she's not quite clear at the end what I want, well, I want to wait for my partner to come. That says it's absolutely okay. I give you the written information for all these 3 options with you. And yes, you can wait for your partner, but it's important that you do, you know, make some decision today. What would you like to do? And then we can make arrangements accordingly. Any questions? So practice it again, keeping these points in mind. Write down them in a bullet point first, then record your session, all of you, and then listen and see, have you included these points? And could you manage to do that in 10 minutes? If not, then rephrase again. Make your, you know, arrangement of sentences or the shortening of sentences, phrases in a way that you can manage to complete them in 10 minutes.
Thank you, Dr. Nabin, for the detailed feedback.
You're
And I
welcome.
would like to ask about, you mentioned about repeating the pregnancy test every time.
I could not hear. There's quite a lot of noise. So can you please say again?
So regarding the follow-up, like, I mean, we normally do weekly beta HCG till it is in the non-pregnant state. And I did not read about where we have to stop if they are falling down and then ask them to do the pregnancy test in 3 weeks' time. What do you suggest in this case? Because this, according to my understanding, for PGL, if you are giving methotrexate, then you have to still continue doing weekly tests.
So you can offer that one as well. I mean, she probably won't go into that detail, what I need to do. You can explain that way. But if you say like after, if she takes the medical, or if you just tell her like once we are sure after, you know, 1 or 2 tests that they are certainly going down, then we can do pregnancy tests in so many weeks, or it's absolutely okay. You can call her for weekly as well. You can say like, we'll give you the form to get this done every week.
Okay.
Yeah, we can
Thank
do
you.
that. Yeah. Okay, anything else?
Does she have to come to our for doing this beta HCG, or she can follow up with her GP?
So that depends again. We usually give that to GP when we discharge them. So we just write that in, you know, when we do that, and we will do that station as well actually at some stage, writing discharge letter. So we then give that out to the community. But the first couple of tests we will be doing in the hospital, we will be calling her on EPAU to do that, to make sure they have started going down, and then we can give it to GP. Or sometime we do an EPAU as well. That works, and is important on the individual hospitals, to be honest. The big hospitals who have really busy EPAUs, they don't bring them weekly for them. They can leave it to the GPs. But that, don't worry about that. Will that be done by the GP or with us? That's not important. Important is you know what the follow-up is, okay? But the first 2, at least 2, like one test confirm is going down, then another test to make sure yes, it's still going down, will be done on EPAU. That's the main thing.
Okay.
But you won't be caught for these points in the discussion, who will be doing that and all that stuff. Okay.
Okay.
Right. Okay. How many stations have we done? Are we done up to 5 or not yet to take a break?
Yes. 5. 5 stations we did.
Have we done 5 stations?
Yes. Yes.
Okay. Let's take some break now to eat and drink. So let's take about 20 minutes break and then come back. So we are. So it's 10 to 2, so we'll be back at 10 past 2, yeah, in 20 minutes. Right, who is next? Selena? Hello, Selena, are you with us?
Yes.
Yes, Selena, the next one will be for you. Okay, this is for you.
Thank you. Can I start?
Yep, your 2 minutes are just now. You can start.
Hi. Hello. Is Tracy?
Yes, hello, doctor.
Okay. My name is Sarina Chaudhary. I am one of the doctor on call today. So can I please again check your full name and date of birth, please?
Yes, my name is Tracy Thompson, doctor, and I'm 16 years old.
Okay. So Tracy, nice to meet you. So I understand that you are here to discuss emergency contraception. Is that right?
Yes, doctor, that's right. I just want to have a morning after pill.
Yes, and you had unprotected sexual intercourse, I understand from your note. So is it okay if I ask you a few questions to know a little bit more about you?
Yes, of course, doctor. Yeah.
Okay, but Tracy, before I ask you any question, I want to assure you that the thing we will discuss here will remain confidential. So you can share anything you want with me, unless and until there is anything that will um, hamper your safeguarding or something. Otherwise, we will keep everything confidential between us. Is that okay?
That's absolutely okay, doctor. Yeah.
Okay, so could you kindly tell me about the what happened and when did it happen? That unprotected sexual intercourse.
Yeah, so we had sex last night about 10-ish, and we just ran out of condoms, really. So we didn't use condom.
Okay, and was that happened with your regular partner or a new partner?
Yeah, no, it's my regular partner. It's my boyfriend.
Okay, and are you on any contraception?
No, we have been using condoms.
Okay, and was that happen under any, like you were drinking alcohol or in a party?
No, no.
Okay, and When can I ask you a little bit about your period? When was your last period?
So my last period was about 13 days ago.
Okay. And do you have any other unprotected sexual intercourse in this cycle?
Yeah, I had a condom accident 4 days ago as well.
Okay. And did you take any emergency contraception for that?
No, I didn't.
Okay. And do you have any history of pelvic infection or sexually transmitted infection?
No, I never had any. I have never been tested actually.
Okay. And can I ask you something about your regular partner? How old is he?
He's same age as mine, 16.
Okay. Where did you meet him?
Well, he just is from my school, like he's my class fellow.
Okay. And are your parents or aware that you are sexually active?
No, I haven't told my mom. No.
Okay. Do you live with your parents or?
No, I live with mom. I live with my mom.
Okay. And do you smoke?
No, I don't smoke.
Drink alcohol?
I do, yes, over sometime over weekends.
Okay. Is it occasional or you regularly drink every day?
No, I don't drink every day, just on weekends sometimes.
Okay. Any recreational drug?
No,
Okay. Do you have any other problem like tummy pain or excessive vaginal discharge?
no, doctor.
Okay. Do you have any medical disease like asthma or any other disease?
I do suffer with migraines,
Okay.
nothing else, yeah.
Are you taking any medication for that?
No, I just take ibuprofen when I get really bad headaches.
Okay, sorry to hear that. And any other regular medication, only this ibuprofen?
Yeah, no, nothing regular, no.
Okay.
Yeah.
Are you allergic to anything?
I'm allergic to penicillin.
Okay, so I'm documented it. And what type of reaction do you have?
My mom told I had a really bad rash when I was a child.
Okay. And you told me that you are using condom as a contraception. Am I right?
That's right, yeah.
Okay. So just one point I forget to ask you. So do you have your period regularly every 28 days?
Yeah, they're pretty regular, yeah.
And how many days it lasts?
I bleed about 5 days.
Okay. So Tracy, thank you for sharing the information. So you have come here for emergency contraception. So I'm offering you, we have few options and we will discuss it. The most effective option is the copper coil. Have you ever heard of it?
Yes, some of my friends have, one of my friend had this, but I don't really want to go for the copper coil.
Okay,
I just
no
want to
worries. I'll
have
give you all
one,
the
yeah.
options. Okay, no
Yeah.
worries. I'll give you all the option, whichever you think is suited you or you want. I will try to offer you that. But so you don't want to know about the copper coil?
Well, I'm really scared of having that.
Okay.
mean, yeah.
There's nothing to be scared, Tracy. We do. There is a little bit of cramping pain, but it is the most long-term one, and you can continue it if you want to continue contraception. But if you don't want it, then I can discuss the other options. There are two options. The first one we prefer is the Ella one. That is more than 85% effective. That is, if 100%, it will be effective in 85% in preventing the pregnancy. Does that make any sense?
Yeah.
Okay, and you can take it after 120 hours of your unprotected sex. So you had it on 10 o'clock yesterday, but still it is time. You can have it if you want it. But the way it works is that it prevent your ovulation. But I am seeing that you are on 13 days. So usually if you have a so if you told me that you have a regular cycle every 28 days, we usually expect that the ovary to release the ovum by 14 days. So you are very near to that 13 days. It might that your ovum has already released, so it might not be that effective, but still we can expect that as you have a regular cycle, it will release on 14 days. So you can have it, but I will give you some safety precaution if you want it. And there is another option we give, that is Levenala. It's a little bit less effective than Ela-1, but you can also have it. It also acts by preventing the release of egg from your ovary, but it can be given up to 72 hours. And it is also, if you take it, there is some risk, but it's 85, more than up to 85% effective. So what do you think?
Yeah,
Okay.
I'm not really sure. I don't know.
Okay, don't worry.
Yeah.
I'll give you some patient information leaflet, but before that, giving you any contraception, I would try to examine you, just a speculum examination, and see whether there is any discharge present. If that happen, I will take some swab. Is that okay with you?
Yeah. Okay.
Okay. Do you need more time to think about which one you prefer?
Yeah. So I think I can have the coil. But can I come tomorrow or day after with my mom, because I'm feeling a bit scared of having that
Don't worry,
procedure.
you can come with your mom, but Tracy, you have to take, I want to recommend that you take some oral emergency contraceptive pill, so that it will prevent the risk of pregnancy. So is it okay if I just give you some prescription until you come for your copper coil? Because
yeah, okay, yeah, I can do that.
Okay, but I will also advise you that if you vomit within 3 hours of taking this pill, you have to take another dose, and you will inform us, so that we will can give you another dose.
All right.
Also, you told me that you are taking copper coil, but you have to continue taking contraception, because there is a chance because this medication only delays the ovum release. It might release, and if you have another act of intercourse, you might get pregnant. So I will recommend that you use condom after using this until you have your copper coil. Is that okay?
Right. Yeah, that's okay. So when can I have the copper coil done then?
As soon as you can come, we can do it here.
Okay. Right. Okay.
But there is some safety precaution, because you are having frequent unprotected sexual intercourse. I will recommend that you use a regular contraception, and also I will I recommend that you have some screening for sexually transmitted infection.
Yeah. Yeah.
And
that's okay.
there
Yeah,
are a
that's
few
fine.
one which are very common, like chlamydia and gonorrhea, and they have a little bit of window period. So we will try to check it by your GP. Is that okay?
That's fine. Okay, that's fine. Thank you. Excellent. That was really nicely done, Selena. So, very good.
I was not prepared, so I get frightened.
You did what?
I was not prepared, so I got a little bit nervous.
Okay, that's excellent then, if you did that without being prepared. Okay, that's good. Yeah, so I would recommend, I have sent those links of previous recorded courses, so everybody try to listen them. That just helps you to be a bit more focused when you do the stations.
Yes, I'll write it.
Yeah. So yeah, that was fine. So this 16 years old girl coming for contraception. Just about the services, contraception services, and previously called GUM service or GUM service. They are single integrated service now. They're called sexual health services collectively. So that means if anybody is coming to you for contraception point of view, we are also obliged to offer them sexually health screens, like STI screen, and vice versa. If somebody is coming with any discharge or any STI, we need to make sure that we check they are on some regular contraception, and if not, then we briefly offer them about that, that is important you do so there will always be marked for the other component. So these are the two aspects which needs to be covered when you're reading outside. The third one is she's under 18, girl, 16 years old. So we need, the third main aspect here is to do the safeguarding assessment. which you did. There will be a few more questions, important ones, which needs to be included. Let me just talk about the copper when that will be done point first, because I might forget otherwise. So she did ask about when I can have the copper coil insertion. We can do it as soon as possible when you will come. We need to give her a clear, precise. She's only a young girl, 16 years old. So although you did tell her someday the copper coil needs to be done, or I don't know, I might forgot. Didn't concentrate. I think she did tell for 120 hours. So we need to basically on that answer, whenever she, even if she doesn't ask, we need to say, okay, so if you want to have a copper coil insertion, we can arrange it for you. And if you say, well, I want to bring my mom with me, I'm going to put her straight away for tomorrow. Okay, so I will say, okay, that's absolutely okay. I'll give you the information. I can book you to come in and have the procedure done tomorrow with your mom. Will that be okay? And then say yes. Or meanwhile, I would like you to offer you to have this morning after pill as well, just to be on the safer side, so that in case for any reason, if you couldn't come back, or for any reason we could not put the coil in, at least you will be covered with your morning after pill. Okay. So that's the answer. We can't leave this girl longer. I know even for the coil it says up to 5 days, or even for the pills as well. But obviously we do understand as well the efficacy does reduce a little bit as if we leave the interval longer. So this should always be done immediately and straight away. So I will actually tell that girl to come tomorrow. That's one point. The second one, okay. So in the beginning, yes, the young people, we need to reassure them safety first and the confidentiality. So opening was fine. First of all, you say, Tracy, so and so on this, and so tell me why you're here. She then tells you, okay, I have this unprotected second, blah, blah. Then we need to say, okay, so Tracy, let me reassure you first. All the conversation between you and me will be confidential. I will not share that information with any third party unless I have serious concerns about your safety. Okay, and even in that case, I will discuss with you first. So that's reassurance from that. And then you're going to address things, three main headings. One is regarding your contraception, the other one will be regarding STIs, and the third one will be safeguarding. So because she's mainly coming for contraception, let's start from here. So just say, tell me what time last night you had the sex. She tells you some hour time. You can roughly make some idea about the hours. Okay, so it was 10 last time, it's 11 a.m. now, so it's about 11 hours ago. So did you, was it condom accident, or you did not use any condoms at all? So she tells you we ran out of the condoms and blah, blah, blah. Are you using any regular contraception method? And she says, no, we have been using condoms. Is there any other unprotected sex in this cycle since your last period? Have you taken any emergency contraception in this period, since your last period? And then you will ask about when was your last period? I bleed for so many days, and is it regular? So, okay, so your regular sexual on average is 28 days. What is your shortest cycle? Okay. Do you ever have any, periods before 28-day cycle? So because it's very important, if they have some shortest cycle, then we need to calculate the ovulation date from the shortest cycle, right? Because we don't know, obviously, this cycle is going to be the shortest cycle or which one. So it's very important question. Basically, this is a mark for it. What is the length of your shortest cycle? Then you will be coming to, so that's regarding her contraception point of view. Then I will go to the details of maybe sexual history. And from that point of view, I will ask, okay, so the sex you had last night, is that with your regular partner? She says, yes, that's my boyfriend. Then the very important question is, yes, she has a boyfriend, but she might have sex with somebody else as well, right? So the next question always should follow, do you have sex with anybody else in last 3 months' time? Have you noticed any change in your discharge? Is there any pain in your tummy or any pain during sex? Okay, these 3-4 questions are to exclude immediate, like any current active STI or PID. Yeah, because in case she says she has a permanent discharge and she has abdominal pain or dyspareunia, then if we are suspecting PID, even if she wants to have a copper coil, we can't insert copper coil. Yeah, so that's why these 3 questions are important. And also asking the race, has she has sex with anybody else? All right. Then we will be coming to a bit more details about the partner. So, okay, so, and it's okay to tell them for everybody under the age of 18, we like to ask you questions to make sure that, your sexual and the social lifestyle is safe. So there are two aspects. One is sexual, the other one is social. You can start from anyone. So you can start from maybe sexual. So tell me about your partner, how old your partner is, how did you meet? Are you having sex? Now, the next three questions are very important. Are you having sex with your own consent? Are you feel being forced or intimidated, threatened to have sex? Have you ever been offered any gifts or money to have the sex? Do you feel empowered enough to say no to sex if you don't want to? All right. Then come to the social aspect to say who you live with. Is there anybody at home who you can talk to if you had any problems in your sexual relationships or any kind of bullying? And then do you go to school regular or whatever you're doing study point of view? Is there anybody at school as well you can talk to if you have any issues with your sexual relationships or any kind of bullying or harassment? Okay. These 4 or 5 questions are mandatory questions from safeguarding point of view. And then you will come to the contraception methods and you will say, okay, so there are two different types of emergency contraception available. One is in the form of pills, which you also mentioned as a morning after pill. The way these pills work, they delay the release. So ovulation, ovum, these words people don't at young age understand. They delay the release of eggs from your ovaries, then just quickly make a line, horizontal line and a vertical line in the form of, X and Y axis. And just say on that one, make that graph of ovulation, just simply 0 on 1 and 28 days. In the middle, put line on the 14 and say, for someone who has a regular cycle of 20 days, their ovaries will release egg around about 14 days before the next period. So in your case, your period is 20-day cycle, you will be releasing egg around about 14 days, day 14 of your cycle, right? So from your cycle, the information you've given me, you're on day 13. So the morning after that they work, they delay the release of egg. Okay, so it may be, they may be effective if you take. However, if the process of release, which causes the release started already, then it may not be successful because it's right on day 13, just at that stage. But if you wanted to, that can be taken. This pill can stop. It's effective in 85% means it will stop 80. It will prevent 85 pregnancy out of 100 in your particular circumstances. Okay. And then you can say, so the other method and more reliable method, and what we usually and strongly recommend for anybody to have, is to have a copper coil. Quickly draw the uterus and size. So in this method, basically, we put this one small device called copper coil inside the womb. It releases the copper, which kills the sperms, and it also prevents, in case if still pregnancy happen, it prevents the pregnancy from growing up into the womb. So it is very effective. It prevents 98 out of 100 pregnancies in your particular circumstances. So that is more effective, and we would recommend you to consider this. The other benefit of that is that can be used and kept as an ongoing contraceptive method. But if you didn't want it to continue as an ongoing contraceptive, you can remove it after 1 or 2 months' time. Once this, emergency, this one is excluded. At this stage, I will ask her what method you would like to go ahead. So whatever she choose, I will go into the details of that method then. So here she said, okay, routinely, if she says I want to go for a morning after pill, and before that, she has said, I don't have any abnormal discharge and abdominal pain and dyspareunia, this girl does not need speculum examination or anything, okay? All we need to do in that case is if she opts for oral, then we need to say, okay, so, if this is what you want to do, however, I just want you to be aware that there is a small risk that being on day 13, if your process of release of egg has started already, then the pill may not work. She still said, yeah, no, yeah, I understand, and I'm okay to take the risk. Then say, okay, so I will give you this, but I need to get some information now before I go. And then you can ask about the medical history, surgical, any medicine, and any allergies. And then you can say, okay, so this pill, there are two types of these pills. One is called, you can say, ulipristal, and the other one is Lebanol. The difference is ulipristal can work up to much later in this process of release and delay. It's much more effective as compared to Lebanol. And obviously, if in the history there's no indication, then you can say we recommend you to take this pill. So take this pill. If you vomit within 3 hours, or if you have a diarrhea, then this pill may not work. In that case, you will need to either come back to us or go to walk-in center or even GP or pharmacies to get another pill. It's important you do pregnancy test after 3 weeks to make sure this pill has worked for you. This pill can alter your next period. Okay, so you may get early period or late periods. It's very important you do pregnancy test in 3 weeks time. So that's about the pill. If she chooses for copper coil at this stage, then we can briefly tell about the copper coil procedure. Okay, so that will involve some procedure. In that is first I will examine you in the presence of a chaperone and in the presence of a nurse. Put the speculum inside, have a look in the womb, and then we will put the coil in. This procedure is a bit uncomfortable. You will have some strong tummy-like cramps. But it's like, it's quite commonly done in the outpatient. But at any stage, if you feel you can't actually tolerate the procedure, you can always tell us to stop. At the same time, I will also take some swabs to take for infections like chlamydia and gonorrhea. We can also offer you blood tests to complete your sexual health screen for HIV and syphilis. Now, depending upon if she has this boyfriend for a long time and she doesn't have any other partner in last 3-6 months time, then we can't just do that, just the no symptoms, then we could just do the swabs. In case if she had, this is a new partner, new boyfriend for about like 4, 5 or 6 weeks time, and then there might be another one in last 3 months time, then even if she's asymptomatic, we will take the swab, but we will give her some prophylactic treatment for chlamydia. So we will put her on azithromycin. And the treatment for chlamydia or prophylactic treatment for chlamydia, I'm aware you all are aware the guideline has changed for last year. So it's 1 gram stat followed by 500 milligram daily for next 2 days. Okay. Again, pregnancy test in 3 weeks. This girl, when she said, yeah, we have covered that already, I'm happy to have the coil, but I will have it tomorrow. Okay, in that case, I give you this pill. It will be better to have on the safer side to have this as well. And then we will arrange your appointment tomorrow as well. I give you written information. If you have any questions to ask me before we do the procedure, I will be happy to answer. All right. If she doesn't want to go for copper coil and she opted only for oral pill, then obviously that will save you time talking about the copper insertion and all that stuff. You would use some of that time just rapidly to say, okay, so we'll give you this morning after pill today, and then I would really strongly recommend you to start some regular contraceptive method as well. We have different methods in the form of pill, implant, or injection. I'll give you that detailed information at the end of this consultation. I feel it's really important that we do discuss this today and arrange some regular method for you as well. Okay, we will discuss that end of this consultation because you won't have the time to go into details of the methods and stuff. But by saying that you are recording, you are aware, being such a young person and regarding, 2 episodes of unprotected sex requiring emergency contraception, we have to sort out right from today to start her on some quick start method as well. Okay, any questions?
Dr. Sophia, as regard the pills which we'll give to her.
With regard to the pills, if she chooses for the pills.
Yeah, we'll give her Ella1 only because she has an unprotected intercourse 4 days ago. So it is more than 3 days will be most effective than Ella1. Yeah.
Yeah, Ella, Ulipristal is always more effective because it can actually delay the ovulation even when the LHH surge has started. Okay, so that's why unless there is a contraindication for Ella1, you want to put your mics off. And the contraindications are mainly 2 contraindications. Oh, such an echo. Okay. So there are 2 contraindications for Ulipristal. One is if somebody is severely asthmatic and taking steroids. And the other one is if the person has taken any progesterone-containing method in last 5 days. Yeah. So that's why we ask the question: are you on any contraceptive method. All right. So as long as these conditions are not there, we always prefer to give Elavon instead of Levonormand. The third condition, when you may not give the Elavon, well, you will not give the Elavon, is if they have already taken Levonormand as an emergency contraception a few days ago for another episode, yeah, then you will go for Levonormand again. So these are three conditions. Otherwise, always go for the Elavon, Ulipristal, just because it's effective till up to the late up to the surge of the LH. So if we have given that one, then first thing, as a part of this particular wish is for emergency contraception, she won't go for the pill and take you into the detail of the pill and stuff, because you won't have the time, because you have to explain all that. But let's assume you managed to finish that as well, and then there was still time, and she asked you to say, yes, I'm happy to start some pill. In that case, we just simply needs to say to her, okay, after obviously excluding, so this girl has migraine. If we think about this particular woman, then migraine, then we need to obviously ask her about aura. In the presence of migraine, obviously she's not suitable for combiner oral contraceptive pill. We will be starting her on progesterone only pill. So the other second point we need to consider is if she's taking Ulipristal, then we need to tell her that you need to wait for 5 days before you start taking your regular pill, because the this pill I'm giving you for morning after pill and your regular pill will kind of work, you know, the way they work. If you started taking that pill straight away now, your emergency pill will not work, your morning after pill will not work. So the only important point here is to ask her to wait for 5 days. If she chooses, you know, anything else, if she's happy to start a implant as a quick method, even in that case, we need to bring her after 5 days to start. Now, if she says, well, I want to have an implant, but then I can't come after 5 days, you know, I need to have it done today, then we can give her Levonormand and then give implant or start pill, whatever. If she's confused by saying, well, after 5 days, I might forget to start, I would really want to start straight away today. So obviously, then we need to make sure they don't take any progesterone. With Ulipristal, no progesterone containing method 5 days prior and 5 days after. Simple. All right. But that won't come as a part of emergency contraception, to be honest, because just there is no time, but you need to understand. So someone has asked, what about having migraine and prescribing Elavon? Elavon is fine with the migraine, Rabab. It's only the medical conditions point of view, it's only the severe asthmatic, and sometimes if the women are on antacids, proton pump inhibitors, then we might not give them Elavon, rather we consider them to give Levonormand. With the migraine, Ulipristal is fine. Okay.
Ma'am, what about the second episode of UPSI in same cycle? Like we can put like this first tablet and then copper coil and all.
Sorry, so this girl here, where she has another episode 4 days ago? Okay. You want to repeat your question? Okay, so what I understand, if they have another second episode. So this girl, she had 4 days ago as well. So even if we give her Ulipristal, that's going to cover her this previous episode as well, because that is still within 120 hours. Yeah, 4 days ago. But if she had even more than that, like even beyond 5 days window, about at 6 days ago or something like that, from the last, because she's still pre-ovulatory, we can give her still Ulipristal. But obviously we will recommend, even with no other problem, we will recommend IUCD first. Is that the answer? Is that the question?
Yes, doctor. That was the question. Yeah.
But if somebody is coming with the second episode of unprotected sex, mic off, please. So if somebody is coming with the second episode of sex, so say for example, this lady has unprotected sex last night, and then she has another episode about maybe 7 days ago, and now her day of the cycle is say 17, day 17. All right. In that case, obviously, Ulipristal is not going to be effective, because first of all, you need to think about the last episode. Is that within last 120 hours? Yes, it is. is that like pre-ovulatory or post-ovulatory period? So it's a post-ovulatory. So our oral pills go out of the window. Now we're left only with the copper coil on day 17. Then the second question from copper coil point of view, we need to ask, does she has another episode of unprotected sex? Yes. Was that within last 5 days? No. When was there, like 7 days or 8 days? Anyway, it can be more than 2 episodes, you know. Okay, so are we still within the 5 days of expected date of ovulation? For somebody who has the cycle of 28 days, their expected date of ovulation is day 14, right? So as long as we are still within the 5 days post ovulation, copper coil can be effective irrespective of how many episodes of unprotected sex she has. Because in this way now, the copper coil is actually going to prevent implantation, right? So as long as we are within the 5 days, you know, post ovulation, so for somebody of day 28 day cycle, the 5 days post ovulation will be day 19. Up till day 19, we can do copper coil as an emergency contraception. Beyond that, if it was, say, day 20, with the same history, last night unprotected sex in another episode 8 days ago, we actually can't do copper coil in her case because we have gone beyond the window of 5 days post ovulatory date. So in that case, we do not know from the first episode, there might have been implantation happened already. So if we do the copper coil, we're going to induce miscarriage. All right, so copper coil is contraindicated in that case. So she actually is not suitable for any emergency contraception. However, it will be out of license use, but we do know there has been some studies and some data on Levonorel that it may have some role in post-implantation. And because Levonorel doesn't have any teratogenic effect or anything, it's not going to cause any miscarriage or something, we do offer them to have a Levonorel for the last episode. You know, we can offer them, but we need to tell them it will be out of license use and it may not work. But that is just like there's a little on that evidence, so you can try that if you like to. But it's out of license use. Do pregnancy test in 3 weeks. All right. Okay, who is next?
So ma'am, more than 1 week, more than 5 days of expected ovulations, answer should be like Levonorel, not a copper coil, no, not Ulipristal.
More than 5 days from the date of ovulation. If there are more than 1 episode of sex, if it's only single episode, can you put the mic off, please? If it's only a single episode and we're still within 5 days, then it doesn't matter what day of cycle we are, right? Because so 2 questions you need to ask for the copper coil. Are we, this episode, is it within 5 days? Yes. Is there any other episode of sex in this cycle? No. What day of cycle we are? 23. It's okay. We're still fine because we don't have any risk of implantation from any previous content. You know, we can still do it irrespective of what day is. That 5 day story post ovulation comes only if they have another episode of unprotected sex in the same cycle. Then we will have the risk of implantation from the previous sex. So that's why we won't do that beyond day 19 in someone with a regular cycle of 28 days.
Hello, Dr. Safia.
Yeah.
Dr. Safia, I think so. You already mentioned. I want to confirm it. Means suppose if the unprotected sex after ovulation time and the client refuse for IUCD as emergency contraception, then you said only the Levonorel is option. We will say it's not sure will cover the prevent the pregnancy, but this is the only option, not Ulipristal.
Sorry, which one? Say again.
Dr. Safia, if the client will come after, suppose after the ovulation, means unprotected after the time of ovulation.
Yeah.
And she is declining for, suppose if she is within 5 days of the ovulation, we can offer for IUCD.
Yeah.
But if she totally declines, suppose she will decline totally for IUCD. Then we have only option for the oral. In the oral only we will give Levonorel or both options. Ulipristal also we.
Okay. So be clear first one. We won't say the only option is oral because there is no option now basically, right? IUCD is the only option. If she doesn't agree, then oral basically is not an option. For the oral one, then what we are going to say to her then, that okay, well, these morning after pills that can work only to delay the ovulation, so that actually is not going to be effective, right? However, there is small evidence available in where in some cases this Levonorel has worked because it can stop, it has stopped that pregnancy from growing in the womb. So if you want, you can try, but this will be out of license use. Yeah, there is no sufficient data to suggest that it is effective.
Dr. Safia, Levonorel can be given up to the 5 days, I think, but before the ovulation. So in this scenario, it can be given because she has another episode 4 days before. So still she has time.
We're not talking
So
about this particular scenario now, darling. We're talking about now the different. So this particular woman, let's not confuse things, okay? So if we want to stick to our particular scenario, this woman have both options for both oral methods and for
yeah,
copper IUCD because she's still pre-ovulatory. The other
yeah,
episode is
but
also within
yeah,
5 days. So when
yeah,
we are, so she can have the oral and IUCD. We will recommend IUCD because we always recommend IUCD as a first
yeah.
line.
IUCD is more efficacy,
Yeah.
but after
So
the ovulation, this even the 11 or any oral morning pills is not an option.
okay, so let me just go as sequence wise. So okay, stick to the still our own patient. So if she doesn't take IUCD, then we can't give her oral pill by telling that if their surge has started already, it may not be effective. Then between L11 and Levonorel, you will choose L11 unless there is a contraindication. Okay, is that clear? The other ones, they were talking about other possible scenarios. Yeah. Okay.
Thank you, Dr. Safia, for clearing.
You're
Thank you.
welcome.
Sorry, Dr. Safia, I think so, as you said, after the uliprestol, I think so, we have not take contraceptive pill for 7 days. Before 5 days, after 7 days, I think so.
No, 5 days prior, 5 days after.
Okay, thank you, Dr. Safia.
Okay. There is that scenario gun. One more from let's okay. That's the next one. And who is next one? Who is left from the new batch? Who hasn't done the case yet?
Myself, actually, there was some net issues. I don't know if it's still going to be there. Sapna.
Okay. Sapna, this is for you. Okay, that's your first 2 minutes.
Okay. Hello, I am Dr. Sapna, one of the doctors in the clinic. May I please confirm your name and age, please?
Yes, doctor. My name is Sharon Cobland. I'm 21 years old.
Okay, how would you like me to address you?
You can call me Sharon.
Okay. So Sharon, I'm aware of the unfortunate events that you have been through. I'm really sorry for that, and I'm here to listen to you and support you in this regard. Sharon? Okay, I'm really that I'm taking you back again through the bad memories, but then I need to ask you a few questions because it's important to formulate a better management plan. Is it okay?
Yeah, that's fine, doctor.
Okay. So Sharon, how are you coping with the situation right now?
I'm doing okay. I'm doing all right, doctor.
Okay. Have you told about this to anyone?
No, I haven't. I haven't spoken to anybody about this. I'm here today because, you know, I was told to come here to get some swabs done.
Yes. How do you feel now? I mean, do you have any pain or bleeding or discharge? Any symptoms of that kind or any fever?
No, I haven't noticed anything different now.
Okay. Can you recollect what actually happened? I mean, how many were there, and were they black or white, and what actually happened? Was it an actual penetration?
Yeah, so this happened 2 days ago. We were in my one of my friends' birthday party.
Okay.
And we all were drinking, and then this, you know, these two guys, they came, you know, and they just joined us as well and started drinking. And I think they spiced my drink. So, I mean, I just vaguely remember of that they took me to their flat with them, and then they had sex with me without my consent.
Okay. Do you remember what day of your menstrual cycle were you on?
I had my periods about 2 weeks ago.
Oh, okay. And were you using any contraceptive methods?
Yes, I do have an implant in place.
Okay. And have you been following the GP for any other medical conditions?
No, I don't have any health issues now.
Okay. And have you been pregnant before?
No, I have never been pregnant before, no.
Okay. And I'm sorry if I'm being intrusive, but I need to ask you a few more personal questions. Are you into a habit of smoking or having drinks?
Yeah.
Okay. And are you aware of your weight to height ratio?
Yes, my BMI is 19.
Okay. And any surgeries in the past?
I haven't had any surgeries, no.
Okay. Sharon, I can understand that you are really in a difficult situation, but sometimes, you know, feeling depressed or some can be depressed to the extent of suicidal thoughts. So have you felt so? Do you feel you require support for that?
No, I don't feel at this stage. I will be okay.
Okay. Okay, sure. So I need to examine you. Thank you for sharing this information. I need to examine you in the presence of Chevron to look at your general condition. I need to look from down below and take some swabs to rule out any sexually shared infections, and also to collect some evidences as well. Is it okay?
Yeah.
Okay. So Sharon, now coming to the like how we move forward, do you feel you are safe to go home, or do you need some aid or some shelter?
Sorry, doctor, what you mean? No, I'm
I
living
mean,
with my
if you feel you don't feel you're safe in going home, I can offer you admission. So what do you think?
No, I'm okay. I don't have any problems.
Okay. And since you told me you had your periods 2 weeks back, you you are at the risk of having a pregnancy, but you told me that you have an implant inside. Am I right?
Yeah.
Okay. So when was the implant inserted?
I had that last year, so it's only 1 year. It's been in place.
Okay. So then regarding the, we do not know the condition of the culprit, so we'll have to screen, we'll have to provide you with antibiotics to protect you from sexually shared infections. And also we'll have to give you certain prophylactic methods like to protect you against certain infections called HIV. So we'll have to give you and we'll be following you up as well for sequential testing. And also there is some other infection, that is hepatitis B, that can be transmitted through sexual contact. So we'll have to provide you with hepatitis B vaccine as well, which we'll give you today, and we'll follow you up in 1 week and 3 weeks time. And also, have you noticed any bites or any bruises around?
I haven't noticed any bruises or anything.
Okay, if that's the case, then because usually we offer tetanus toxoid injection as well to prevent these infections from happening. Okay.
No, but I don't think so, because I went to SARC after that and I had an examination, and they said there was no bruises or any lacerations or anything.
Okay. So I'll besides, I'll also provide you with support groups as well. I know you need better support at this time, so we have different groups like Women's Aid Group, and we are going to follow you up after 1 week after the present injection of hepatitis B for the second dose, and again after 3 weeks for the third dose of hepatitis B vaccine. And we'll be seeing you again after 4 weeks to check for your HIV status, and also again at 3 months. Any more concerns, Sharon?
No, that's all. I mean, if that's what I need to do, yeah.
Okay, so I'll also provide you with a 24/7 hospital contact number. So if you feel you have some problems like any pain or bleeding or any other kind of problems, please feel free to contact, or you can drop in at any time.
All right. Okay, doctor. Yeah.
Okay. Okay.
That's
Thank
all
you.
right. Thank you. Right. Okay. Good. Thank you for doing this, and well done. You covered most of the points.
Okay.
Right then. So, yes, sexual assault. There are 4 main aspects. You can write on your bullet points when you're reading this scenario in 2 minutes before your station starts. So one will be to gather the information about the incidents in a sensitive manner from the patient. The second one is to do the STI risk assessment, and also to do the measures for the prevention of STI. So offer her prophylaxis about different infections which is required. The third main point will be to offer her support ongoing support from counseling point of view or any other aspects. The fourth one is to touch briefly about the safeguarding issues of this woman. Okay, so if we take them now, so say by safeguarding issues, I mean we need to. So there was quite abrupt question to say, do you feel safe to go back to home, or should we provide you any assistance? I can see that point, what you probably meant there, but that will be, again, we need to relate to the tailored and individualized case here. Does this woman actually have the history of being sexually assaulted or abused by the partner? Is she victim of domestic abuse? What are we worried about that we are asking her, is she okay to go home? Yeah. She has been home for last 2 days. The incidents happened 2 days ago, and she already been home for 2 days. So that might have a little bit of negative effect of asking something like that just out of the context. And then so this thing you need to worry about doing the safeguarding assessment is, I will be asking this person, and you started right in the beginning to say, have you shared this information, or have you talked about this to anybody around you? And I will establish at that stage, is she in a relationship? Does she has a partner? Have you spoken to your partner? And if not, why? Is there any particular reason? Is there like you feel he might be upset by hearing this, or you're worried about his reaction? Okay, so that's where we will assess that safeguarding from partner point of view. Because obviously, even naturally, it's not something easy to let the partner know. Yes, we might be worried about his emotional well-being. That obviously it can be very upsetting for him. He may become very aggressive and angry, and he might take some extreme step to go against, start fighting with those people or something like that. It can be as simple as that, or it may be that if we told the partner is always already an aggressive and a kind of abusive person, and if he knew this has happened, he might just go and start hitting this woman again. So that's why that one is important. So this is how you should ask about it. And the second point we need to ask is, some people are just prone, they are vulnerable to have these sexual assault or abuse and things like that for various reasons. Maybe she might have some learning difficulties, or she might be just alcoholic. She drinks too much and become drunk so much that she doesn't know, and the people take the advantage of her situation. Or she uses drugs, and that's why people can give her drugs and then take advantage of her their situation. All right, so safeguarding point of these three questions were asked. So if we just start and summarize. So first of all, you need to take the incidents, details of the incidents. I won't linger on too much about that it's unfortunate and all that stuff, because more of these words you will add up. So yeah, I understand you want to express your empathy, but empathy needs to come more from your body and from your tone and things and behavior, rather than using these type of words. Because sometimes even these words hurt, when say something bad has happened to you, or I'm sorry this bad has happened to you, or this unfortunate thing has happened to you. Instead, I'm just going to start very open and simple way by saying, hello, Sharon. I'm going to take my tone empathetic and sympathetic, well, not sympathetic, but empathetic way, right? So I'm not going to be really just very professional robotic questions. The way I will approach this, I will say, hello, Sharon Copley, my name is this and this. So can I take your name and date? But then after that, I will say, I'm sorry that you have gone through, that stressful experience 2 days ago. So, would you like to give me some details about that? Because that will just help me to decide what we should be doing for you. All right. So by just saying that, I mean, don't say it's going to take you to those memories and stuff and blah. No. When you say, I'm sorry, but would you like to? Because that's going to help me about, to make some management plan for you. And then tell her, so just be quiet now. Just let her say when happened and what happened and what happened. Yeah. So she will tell you, okay, that happened these days ago and we were drinking and this happened. So again, I'm not just going to straight away ask question by say in the beginning, I'm not going to give the leading question by saying how many were, tell me about the incidents, how many people were there, and were they black and white. I mean, we don't use the word black and white in that way. All we will say, the way, so once she has told us whatever she knows, there might be a lot of information already given in there. So please listen carefully and take the answers from there, and then don't ask those questions again to her. So if she has already told you there were 2 boys, and this happened and did the sex without consent and all that stuff, I will actually start establishing from there. So when she's finished, I will say, okay, so right, okay, so there were two of them, and you think both of them actually had tried to do sex with you. And then I'm going to ask, do you, I mean, it can be quite difficult to rethink, but do you remember they were like what ethnic group they were? And then I'm going to straight away give the reason as well, because some infections like HIV and hepatitis, they're more common in certain areas of the world than others. So I've given the reason as well. So I don't sound racist by saying white or black or who, yeah? So I will ask that question if she hasn't told already. And then I will say, okay, so was that sex like, that was like vaginal penetration only, or there was oral or back passage penetration as well? Okay. So after asking these questions, then the next question I will ask to her will be about, because it says she has been, it's a SARC referral, means she has been already seen from sexual assault referral center. They would have done the forensic samples, but we can still ask you. So I understand you have been seen in that center already. Have you informed the police? Has police been informed? Right, and then you can ask her at that stage, because the tetanus and stuff, if that was required, SARC will sort it out at that stage, because they have seen immediately. We're seeing after 2 days, right? So if you want to ask, you can ask. Otherwise, are those physical injuries needs would have been addressed by now? Okay, if not, you can still ask if you want to. Just ask like, were there any bruises, any injury down there, any tear, any lacerations when they examined you in that center? And if he says no, that's fine. We don't need to talk about tetanus and stuff. So that's the details of the incidents. And then the other important thing we need to ask is, although she volunteered that information to say we were drinking, they came, I think they spiked my dinner, sorry, my drink, and that's why I can then remember. I would like to now, kind of exclude the vulnerability of this woman to think by saying, okay, so here I understand you said, they might have put something into your drink, but tell me about your otherwise routine pattern of drinking, like how much you drink in a week. Is it, quite common that you become drunk? Like you may drink that much? Because if she is a person who can actually drink so much, become drunk and stuff, then obviously she can be, the victim of these. She's more vulnerable. Do you use any drugs at all? Yeah. And then after that, then that's the immediate information we have taken. Then you can say, the next one is, you will say, I can see it's obviously very difficult. How are you coping with this? You can ask this established well-being even right in the beginning as well, to say, I'm sorry that you have gone through that difficult experience. How have you been coping with this? Or at this stage, after the details, you can ask about how you've been coping with this all. Have you spoken to anybody, any family member, friend, or your partner, if you have one, about this incidents? And if she says yes, then it's okay. If she says no, then you will say, you can ask if she hasn't already given any voluntary information about the partner. You say, do you have a partner? Have you spoken to your partner about this incident? If she says no, then just those two questions asked, like why you haven't. Do you think, is that because you feel he might become upset, or you feel he might react quite aggressively to these incidents? Do you feel otherwise safe, supported with your partner? Okay, so that's done the partnering safeguarding thing. Now, the other two main things which we need to, one is about the emergency contraception and ongoing contraception if she's not already, and the second one is about the STIs risk assessment and the prevention. All right. So let's sort out the contraception first, because that's a bit quicker one. So ask about like, okay, so we also need to make sure that, we cover and there is no unplanned pregnancy from that incident. So so just start straight away, ask, are you on any regular contraception already? If she says yes, then it's fine. We don't need to talk about emergency contraception and about the cycle and the period and stuff. Okay. If she says no, then we will say, okay, so have you been given any emergency contraception at SARC? Because they are the first place to be seen. They usually give, well, not usually, they always give emergency contraception if it is required. So just establish that. Have you been given any emergency contraception? So most likely answer should be yes. If not, then you can say, okay, in that case, then I will need to arrange some emergency contraception for you. And we can also discuss some ongoing method of contraception for you. I will explain you these both in detail at the end of this consultation. In this case, now you can ask when was your last period, what day of cycle you are. When was the last time, other than this incident, that you have a sex with your partner or anybody else? All right. Then ask about established now any existing STI. Have you noticed any change in the discharge? Is there any bleeding in between your periods or after sex? Is there pain in your tummy? Is sex painful? Okay, so that's done your STI risk assessment. And if there is answer yes to something, then obviously we will address the treatment accordingly. Then talk about the prevention. So what we will do then, we will say no, because these people, and then you can also ask, well, do you know these people? Like they're known people to you, or they are just stranger? So if they are stranger, or even if they're known people, then we can say, because we don't know about these people, what type of sexual lifestyle they have, it would be a good idea if we take some, tests to make sure that they haven't passed on any infection to you. So what we can't do, so instead of like we need to have or we have or you have to know, simply what we can't do then, we can take some swabs from your vagina, depending upon what information she gave to us, penetrative sex, whether it's only vaginal or a rectal, then we can say that like we can take swabs from these areas, and same for the testing like chlamydia and gonorrhea infection. We can also do a blood test to check for infections called HIV, syphilis, and hepatitis. Okay, we can do these tests at this stage. Now, before I start about the follow-up of these, then I will say, no, because again, we are not sure about the sexual lifestyle of these people, we can also start you on some medication to prevent the infection of HIV to build up in your body in case if there has been any risk of that. We call this HIV prophylaxis, post-exposure prophylaxis. How you feel about it. Before I go into the detail, I will check with her whether she would like to take it or not. And I've told the reason as well, right? So with how you feel about it, would you like us to start you on those medicines? If she says yes, then I say, okay, that's fine. I will arrange that for you. And I'm going to give you, the detail of the medicine and explain how you take to at the end. Now, leave that as well. Then the other thing we can also cover is the risk of hepatitis B infection. So that we can't do. We can give you some vaccination against it. That will involve 3 injections. If you like to go ahead, then we will give you 1 injection today. Second one will be given in 1 week, and the third one 3 weeks from today. Would you like to consider that, or would you like to go ahead with it? Yes, if you have talked about, don't say we're going to do this and this. We need to say we can't do, there can be risk of these, we can do this. How you feel, would you like to do this? And if she said, you can say, okay, so I will arrange these injections for you. And also, we can give you some antibiotics if you would like to prevent any possible infection of chlamydia. And again, if she says yes, they say, okay, so I will give you those tablets as well and explain. Okay, that's done for your prevention and prophylaxis. Then you will say, after this, then you're going to say, and so I'm going to arrange your other appointment in 1 week time to come for your second injection. Then we will see after further 2 weeks, we will see you back to repeat your swabs and these tests for chlamydia and gonorrhea, because they have a window period of 2 weeks. So they may not show up today, they are too early. So we'll just finally do after 2 weeks again. And if they're negative, then we can be reassured it's negative. And then depending upon if she has accepted HIV prophylaxis, then we can say, okay, so you will take those medicines for 4 weeks, and then we will leave you for another 6 weeks and repeat your blood test. So the window period and incubation period of HIV is changed, if you guys have seen the recent guideline. So it's not 4 weeks anymore, it's 6 weeks now, right? So we'll say we will repeat that in 6 weeks after you finish your those tablets. So that will be done for you. So that's done for about her testing and all that stuff. Now I need to make sure, in the beginning I did establish a little bit how she's coping. Now I'm going to say it's not unusual, obviously, to find this very stressful and difficult to cope with. So how you feel about if I arrange your appointment to be seen by one of our counselors, as talking to them can help you to deal in a better way with this problem, with this, stress and all that anxiety. difficult experience you're going through. If she accepts that, says yes, that's fine, that would be helpful, then you say, okay, so I arrange that appointment for you. If she says no, I'm okay, I don't need it this way, you say, okay, that's fine. But what I will do, I'm going to give you the contact details for you to keep with you in case in coming days or weeks, if you feel you're really struggling or you're finding it difficult to cope, you can contact them. All right, so always give them a number. It's very common for these women straight away to refuse for the counseling because they are kind of fed up already. They've been seen, SARC has interviewed the same things, then police has spoken to them, then some other clinician might have spoken, then we have spoken. They really want to get rid, we're fine, I don't need any support. But then slowly, when all these interventions come to end and the things start sinking in, then they start feeling, that anger and everything, why I am subjected to this. So don't just leave them by saying they don't want to have immediately, that's absolutely fine, but give them the contact details. So if they feel to have that help, they can contact. All right. Any quick questions?
Hello, Dr. Safia. Hello.
Yeah. Yes.
Dr. Safia, you said this HIV test we will do after 6 weeks. So means after 8 weeks of finishing this medicine, then after 6 weeks. Means total 10. In total 10 weeks.
4 weeks and 6 weeks total. Yes. So yes. So HIV prophylaxis will be for 4 weeks, and then we'll leave for another 6 weeks. Yes, that's right. 10 weeks.
Okay.
But we are going to do one baseline test today. Yeah.
Okay. Okay. And the 2 weeks for the chlamydia and gonorrhea. 2 weeks follow-up on chlamydia and gonorrhea.
Okay. So yes. So the incubation period for chlamydia and gonorrhea is 14 days, 2 days to 14 days. So they will be repeated after 2 days. HIV, syphilis, and hepatitis is up to 3 months. And the initial one is six weeks for HIV, and then total incubation is 6. For hepatitis C, the third one will be done at 6 months.
Okay. Hepatitis C at 6 months.
So, madam, for HIV, how many times testing? On day 1 when she comes, and then directly after 6 weeks?
So yeah, if she doesn't want to have HIV prophylaxis, then in 6 weeks, if she starts HIV prophylaxis, then let her complete that prophylaxis in 4 weeks and then leave for another 6 weeks. So after 10 weeks altogether.
And what are we giving in prophylaxis?
Okay, so prophylaxis, you wouldn't be expected to know that. However, I can tell you for your knowledge. All you need to say is, if she says yes, I'm happy to start with, then you can say, okay, I will explain, and arrange these medicine at the end of this consultation. The medicines we give them is one medicine is called tenofovir and amitriptyline. That's called simple words. It's also known by Truvada. This Truvada is given 1 tablet every day, once a day for 4 weeks, for 28 days. The other medicine which is given, that's called raltegravir, and that's given, now the dose regime of that has been changed as well. So that is now 1200 milligram once a day for 28 days. Previously, it used to be 400 milligram twice daily. But since March, the guidance has changed. So both are single dose. So Truvada, 1 daily, and raltegravir also, but that dose is increased quite a lot. So it's 1200 milligram once a day for 28 days.
Oh, yeah. For 4 weeks, no?
Yeah, 28 days.
28
but
days.
I wouldn't expect you to be asked this, but obviously there's no harm to know this and memorize it.
Yeah, and madam, for hepatitis B, when to do follow-up? Vaccinations and for the titer also.
Yes, so the vaccination is done. There are 3 injections, 0, 7, and 21 days. And then we can do the antibodies after 6 weeks. But you don't need to worry. We routinely don't check for antibodies.
Okay. Thank you, ma'am.
Ma'am, regarding this post-exposure prophylaxis, ideally it has to be started within 24 hours. So will the SARC people will start it?
Okay, so post-exposure prophylaxis needs to be started within 72 hours. So no, SARC does not start prophylaxis. There's more sexual health services. That's why they send here. They will take forensic samples. They will do, they will give them emergency contraception. And if there are any injuries or anything, if there is any acute need required, they will send them to A&E. And all these sexual screen, prophylaxis, and they all need to be done by us. If they when they do discuss though, they do discuss with them at that stage. So if we can see within 72 hours, like the sexual health clinic see them within 72 hours, they will send over there. If not, then emergency A&E can also start prophylaxis. They do have a pack for 5 days. So what happens if it's weekend or something like that, and the sexual health services obviously are closed over the weekend, then they will go to A&E. A&E will give them for 5 days medication. They will start, and then they will come to you, to the sexual health service, to continue with the rest. All right?
Okay.
So yes, it needs to be started within 72 days, 72 hours. Right, okay. Okay, this is the next one. Who else has not done? There should be still quite few people from new batch. Anybody from new batch who wants to do this, hasn't done yet?
I have not done, ma'am.
Okay. Is that Dipti?
Yes, ma'am.
Good for you, Dipti.
Hello, can I start now?
No, I would like you to take your 2 minutes, properly write down your points, what you're going to say. So you still have 1 minute to go. Okay, now you can start.
Yes, doctor. Hello, I'm Dr. Dipti here. May I know your name and age, please?
Yes, doctor. My name is Rebecca Wine, and I'm 36 years old.
Nice to see you, Rebecca. Rebecca, I just got the referral letter from your GP doctor, and I came to know that you are 6 weeks pregnant, and this is your second pregnancy, and you had first miscarriage. Is this true?
That's right, doctor. Yeah.
Yeah. So, can I just know what is your concerns to see me today?
Yeah, so I have, I had one miscarriage in my first pregnancy when I was about 17 weeks. And then I had to have this LETS about 2 times in the past. So, some of my friends told me that because of this procedure I had, that might have been reason for my miscarriage. And I have done some, search in Google and stuff, and I'm really worried because I've read that yes, that can actually lead to the miscarriage. So I just want to know, is there anything I can do this time to, prevent any miscarriage so I can continue with my pregnancy?
Yeah, I understand your concerns, Rebecca. Don't worry, whatever is the best possible preventive measures, I would like to go through that. Before that, can I ask you a few basic questions to know you much in detail?
Yes, doctor.
Yeah. So your period was, when was your last period date?
My last period was about, well, I am now 6 weeks pregnant, so 6 weeks ago.
Okay, was it regular period?
Yeah, my periods have been really regular.
Okay. And do you have any other, did you started taking folic acid?
Yes, I have. I started actually before, when I planned.
Very good. And did you check your dating scan? Did you check your pregnancy is inside the uterus and all?
No, that has not been done yet. I think I was told I will have 1 or 12 weeks.
Yeah. Okay, no worries. And are you taking any other medications from your GP?
No, I'm not taking anything.
Any surgery before?
No, other than
Any
these LEDs procedures, nothing.
Okay. Any family history of any concerns?
No, I can't think of anything.
Okay. And what's your blood group?
My blood group is A positive.
Any reservation for blood transfusion?
No.
Well, and don't mind me asking, do you smoke?
No, I had stopped. I don't smoke during pregnancy.
That's lovely. What about taking alcohol or recreational drug?
No, nothing. No, not at all. No.
Very good. With whom do you live?
I live with my partner.
Okay. How is support at home? You're happy there?
Yeah.
Very good. So Rebecca, and what is your BMI? Are you aware of your BMI?
Yes, my BMI is 24.
Okay. Any kind of drug allergy? I forgot to ask.
Sorry. No, doctor, I'm not aware of any allergies.
That's good. And any kind of like feeling low, depressed, or anxious in last 4 months, 4 weeks?
No, doctor.
That's good. So, Deepika, I understand that except previous history of LEDs 2 times and 1 miscarriage, you don't have any positive worrisome points. So, don't worry about that, Rebecca. The thing is, and first of all, you have to continue folic acid tablet. Okay, for the 3 months, you have to complete the 12 weeks, and then we have to do the regular serology testing just to rule out there is no infections is there and all. Okay, and we will do that Down syndrome screening test and all. Okay, and just to prevent this miscarriage, we would recommend to do the monitoring of your neck of your womb. And we may just put a stitch there in case if it is a stitch there around 14 to 16 weeks like that. Okay. Are you getting my point?
Yeah, okay. So what is that stitch? I mean, how will that be done? Is that not going to be a risk for having that?
There are, and we can put you some on tablets also, that is called progesterone tablet. It will support your pregnancy, and for the stage usually we can put between 14 to 16 weeks, and it will be under anesthesia. You will be put at a sleep, and it will be done under the hospital, in the hospital by a consultant.
Okay.
Okay, and then there will be the regular checkups with the consultant and your midwife, and your GP doctor will be under the loop. So don't worry about that. At 20 weeks, you will be going for that structural anomaly scan for the baby. Okay.
Okay.
Yeah, and we will continue the same monitoring of your pregnancy. Okay, but
Right.
in case if you have any kind of pain in tummy, or you feel some discharge or some kind of a watery discharge, something like that, you have to report to the your GP doctor or your midwife immediately, and we can take care of that. Okay.
Okay. Right. Okay. So I will have a stitch at 14 weeks, you said, is it?
Yes, yes. And at 20 weeks, we will keep on checking your length of your neck of your womb. Okay, so and if it we will monitor frequently, and we will see. And I will put you on the progesterone tablet. You may have to insert inside your vagina, so that it will quieten your tummy, it will quieten your womb, and
So
chances
when,
of
okay, so when I need to start those tablets?
you can start these tablets immediately, like after the confirmation of pregnancy we can start. That's not a problem.
So obviously my pregnancy is confirmed now. I'm 6 weeks. So, so am I supposed to start now then those progesterone tablets?
Yeah, we can start that to prevent the miscarriage.
Right. And how is those tablets going to help?
This tablet usually it quietens the womb, and yes, that can help you.
Okay.
And but there are chances of like your delivery can be little early than the normal expected time. So to safeguard the baby's lungs and all, we will give you injections also to protect your baby's lung maturity, so that your baby can breathe normally after the delivery, in case in untoward situations of early delivery. Okay.
All right. And what injections will those be, doctor?
This will be injection beta, we call it steroid injections, betamethasone, to mature your baby's lungs, so that
Right.
baby, yeah.
So when I need to have those injections?
In case of if you find that you are likely to go for early labor, early delivery, in that case, at least 24 to 48 hours before that, we give that injections.
All right. Okay.
Okay.
Okay. Yeah.
Do you have any other questions for me?
No, I mean, that's okay. You told me I can have this, I'm gonna have this stitch, and that's going to keep my pregnancy ongoing.
Yes, and you have to have consultant led delivery, because in the hospital there will be a lot of facility. In case if you are going for preterm, then the baby's admission should be easy for you, and we will keep informing your pediatric baby doctor and your midwife, GP doctor all, so that in emergency you can contact us immediately.
Okay, so pediatrics baby doctors, why I need to, is this condition going to affect my baby?
In case if you are going for early delivery, in that case, your baby doctor should be aware of it.
Okay. Right, okay. Yeah, that's okay.
Your mode of delivery can be vaginal, and but it depends on the situation that time. How
Right.
is your baby's condition?
All right, your time is over. Right, thank you, Dipti, for doing this.
Got so much bundle.
Don't worry, it's okay. It's very first session today. So yeah, there needs to be a bit organization. I think it's very important that we do understand what is the theme of this station, and then at which point, what are the points we need to give the maximum time, of our time. I wouldn't be worried about our mode of delivery at this stage and all that stuff. But the steroid stuff, that is okay. You can mention that. But before that, there is a lot to talk about what LEDs is, how LEDs actually decreases or reduces the length of the cervix, and what happened, why people with LEDs actually can have a early miscarriage. Reassurance as well. Having one miscarriage, we need to establish what were the, how that miscarriage happened. Was it painless? What happened? Was there gush of how that happened? Was it painful? She started pains or bleeding, and then, we need to first establish that as well, and then we need to explain why and what we can do. What are the ways we will be measuring the length of the cervical length, or and we can't just randomly tell her you can have the progesterone as well and the progesterone. So, and then don't just give a small thing and then just go quiet. The role player may not be that helpful to just keep giving you those questions to continue, tell me more about this particular. So if we are saying like progesterone, then we need to tell why we want her, how that is going to help, when we will need to start, how that will be, what is the evidence behind the use of that. About if we're talking about offering her stitch, also we need to know how that will be done, what are the risks associated with that doing, what are the benefits, is it really going to stop her from having the miscarriage. These are important points we need to. So there is a main chunk should basically, should be talking about the management from now till 20 weeks, what we can do to prevent their cervical incompetence, if there was a reason or if that is going to be a reason. And also the keeping an option just to monitor. We don't necessarily have to do any intervention. And then it's not us who are going to say you have to have this. We're just going to tell her, then she's the one we need to ask, what would you like us to do? So yeah, just to keep reminding all of you, the word have to, have you, have to is not the words, we don't use them. Instead we will say it's important, instead of saying you have to have, or you have to be under the care of a consultant, instead we say it's important that we book you under the care of consultant in this pregnancy to monitor, the length of your neck of the womb and all that, to assess. It is important that we do. Don't just say you. It's not, we're not putting her, go and arrange that, or you must do this. Yeah, this is what we do. Okay, so before I give that kind of how we need to do it, Pramila, are you still there with us?
Yes, ma'am.
Okay, so can you just give us a very quick and brief summary of the role of cervical cerclage and the progesterone in prevention of recurrent miscarriages? Just a brief summary of important points.
Yes, I think there are three things that can happen. One is you might have had a previous history of second trimester miscarriage or an early preterm labor before 34 weeks. In such a scenario, you will be offered ultrasound scanning from 16 to 24 weeks. And if the cervical length is less than 2.5, then you can take either cerclage or progesterone. The second scenario is where you don't have any history previously, but just with a routine ultrasound, incidentally, you are found to have a small cervical length. In that instance, your option is progesterone. The third one is where you had PPROM, or whether, like this patient, where there was a trauma to the cervix. In that instance, again, you will be given cervical length monitoring between 16 to 24 weeks. And if it is less than 2.5, your option is cerclage.
Good, thank you very much. Okay, so just to refresh your points. Okay, so coming to our particular patient, she has previous miscarriage 17 weeks. So first of all, yes, she's worried about her LEDs procedures, and that yes, we know the women who have repeated LEDs or any other surgery on the cervical length, which can reduce a shorten the cervical length, they are at risk of cervical incompetence. But before that, so we need to acknowledge first by saying, yes, I can see, I can appreciate your concerns, and I'm sorry that you had a miscarriage in your first pregnancy. I would like you to, give me some details about that miscarriage. So what exactly happened at that miscarriage? Did you start it with the pain? how that miscarriage happened. Okay, so let her start with, because again, we know if it's cervical incontinence is the reason, then they usually have, they start with the painless, bleeding, or they might just notice some leakage, gush of fluid, and then they have a very quick miscarriage. So just try to establish that detail. And then, like, about the details of the LETS procedures as well. So when did she have these LETS procedures? Were they both before her first pregnancy? Were they both after her first pregnancy, or one before or birth? So we need to establish that as well. When she had these procedures done, when were they done? And then also to just quickly check on that by, again, we can't isolate everything here because she's coming to us to know about the pregnancy. Let's just double check, just check that as well. If she was diagnosed AN3 and then she said she recently had LEDs, or when she had, we can check with her to say, okay, so does she had any smear done after that, and was that normal or what? Yeah, so just check that. Again, take a holistic approach, being clinician. And then you can start by saying, explaining her first of all what happens. Let me explain you with the help of this picture what happens with the lead procedure. So then you just make a uterus and obviously the cervix with a bit of length. And then you say, so in the LETS procedure, what happens? This is how this much of the part of the cervix is removed. And as a result, obviously, because of the scarring as well, and because of the length of the total length of the neck of the womb becomes shortened. And obviously, if you have a repeat procedure, that can further reduce the length of this neck of the womb. And when the pregnancy starts advancing, the uterus or the womb needs to extend. And the result of that, because of that stretch on the cervix, if it's a short cervix already, the neck of the womb is short already, it can stretch and start opening and start giving the way. The typical word we use is to start giving the way. And because of that, then water bag can actually, hang through this, or it can rupture, and it can result into the miscarriage. However, if obviously, she give us no history of that, any cervical length measurement done in first miscarriage and stuff, then obviously we don't have the evidence. So we'll say, because that your first miscarriage happened so quickly and so suddenly, you told there was no scan done, so we don't exactly know what would have been the reason. And if she has given it was a painless one, then you can say it might be, it looks like, from the history that probably this probably was the reason. However, obviously we can't say that certainly. So what we can do now in this pregnancy then? So one, we need to tell her to say, so let me reassure first to you that, these procedures which you had already, the only risk because of them is obviously if they have caused the shortening of the length of the neck of the womb, that can result either in a miscarriage or even later on in early labor because of the shortening. Otherwise, it's not going to affect your baby's well-being or growth in any matter. Okay, so let me reassure you that first. Now, what we can do now to help you to actually have your pregnancy, continued, there are different options we can do. The one is, yes, you can talk about this progesterone one, that we can start you with this one from now as one, because that helps basically to prevent any irritation or contractions of the womb, which may also result in the stretching or opening of the neck of the womb. So that can be started from now, straight away, if you would like to go ahead with that. And the second thing we can do is that we will do the internal scans to measure the length of your neck of the womb. So what happens when, the length of the womb starts shortening, if it become up to 2.5 or less than 2.5, then there is a high risk that it can, start opening, and that can result in a miscarriage. So if the length is less than 2.5, then we can put a stitch around the neck, and you have made the picture. You can tell actually where the stitch will go to try to keep it closed and prevent that stretching and opening. Okay, we call this as a cervical cerclage. It can usually be done, from down below, from the vagina, by putting the stitch. But if the length of the womb, the neck of the womb is gone really shortened, sometime it may not be possible then to put this, that stitch from down below. Then we can do a keyhole surgery, put a camera inside, and then, make just abdomen on the top, and from the top just show her, like we can, just put stitch around from here as well. However, we will give you that detail when we come to that stage. However, there is a small risk of having a miscarriage because of this procedure itself. Okay, so you need to tell that as well. That's important. So then you will say, okay, so your first, then your routine, have you had your any scan done? You had 6 weeks. Usually, it's, unless somebody has a previous history of ectopic pregnancy, at 6-8 weeks, nobody kind of have booking scan. As I said, like unless there has been any previous risk of this molar or something where we want to establish it's a normal intrauterine pregnancy. Otherwise, usually 10 to 12 weeks is the time when they have a booking scan, and the nuchal translucency scan as well at the same time. So we can then just say, so rest of your pregnancy will be looked after just like any other woman. So at 12 weeks, you will have a scan done to, check the your pregnancy, and also, we can do the part of down screening as well, which I will discuss in detail with you afterwards. And you can have a down screening. Then at 20 weeks there will be detailed scan. So don't forget about the rest of the pregnancy. 20-week scan as well. Now if she's very anxious, so the routine time we will tell her will be, obviously we will say that we will start doing those regular scans, internal scans, from 16 weeks onwards to measure the length of the neck of the womb. And if we notice that, then we will put that. If she's very anxious and she says, well, no, that might be too late or something like that, we can actually offer her one internal scan at 12 weeks as well to measure the length of the the neck of the womb, to establish the initial length, what is, because sometime we may decide we may need to actually, if she has a twice that length procedure, her length might be already much reduced. So we might actually put prophylactic stitch much earlier than 16 weeks or after. If she's very anxious about to say, well, yeah, I'm really worried, and then start her on progesterone as well from now. Although we do know if it's just because of, the shortening, then progesterone may not have quite a lot role in there. No, then she says, okay, so if I have that stage, that means then, I can safely continue with my pregnancy. So I can't 100% promise and say yes, because there could be other reasons of miscarriage as well. Yeah. So then we will say yes. Once we have this stitch done, then the risk of your miscarriage because of this reason, shortening and opening, will be reduced quite a lot. Yeah. So even we can't 100%, we can't stop that. Will be reduced quite a lot, and we will be giving you continuous monitoring as well. Or we will, give you the instructions as well. Like if you feel like any, start having any contractions, any pains, or any bleeding, you need to attend hospital immediately. However, unfortunately, there can be some other causes of miscarriage as well. So if unfortunately, there is some other reason to cause the miscarriage that obviously not preventable, then just having this procedure done. Yes, we need to make sure we can't just give her false reassurance to say, and it's technically not right either, because we don't know. She might just have early miscarriage this time, just at 8 weeks or 10 weeks. We haven't investigated her for her miscarriage reason. So these are the few things you need to keep in the background as well. Yeah, and then again, we can't just say you will have this and we will have this. All we need to say is we can do this, how you feel about it. And if still there is a time, then you can continue go beyond 20 weeks, then you can say, so because of this particular condition, the baby's growth and nothing else, is not going to be affected. Pregnancy should be monitored, but there will be a risk of going into labor early. So what we will do then, when you will be about 30 weeks pregnant, we will reassess, and we may consider to give you some steroids to increase the lung maturity of your baby. So in case if you go in early labor, then we can, the baby's lungs are quite matured and ready to breathe. And if at any stage, you feel any contraction starting, or you start feeling any leakage or anything, you must immediately attend the hospital. So here now we can use the word must immediately. Can you see the difference between not using must in other circumstances and here? Here we are emphasizing the importance. You must attend. Yeah. So yeah, that's all. I won't be worried about the mode of delivery and stuff. There won't be time left anyway.
Doctor, after putting the stitch also, we have to continue progesterone after 16 weeks. As per the guidelines, I understood that it only the stitch is the solutions because it is previous too late. But in practice, we are starting Dufaston quite early, no? In such
No,
cases.
in this particular scenario, basically the measurement of the cervical length and then stitch either when it's required or prophylactic is the option. Progesterone will come only if she's very anxious and she, she feels like, then we can say, but we need to say that it may not have quite a lot role into this.
But we can say
So
in
Dr.
exam that,
Safia,
Hello?
doctor, we can say in exam that to start progesterone from 6 weeks onwards. Practically, we are doing here like that. So in the
No,
exam, same thing.
so in the exam, you have to say only what is given in the guideline. Okay.
so Dr. Safia, we will start the cervical length from 16 week.
So routinely, yes, we should be doing cervical length from 16 weeks.
Yes,
That's what the guidelines
16
say.
week, and if
Yeah,
the cervix start less than 2.5, so we will
yeah,
offer the cervical cerclage because she has a twice list.
yeah.
Only this option is available as per NICE guideline.
Yeah, but if she's very anxious and she goes like, I had that 17 weeks and I might get my miscarriage even earlier, if she appears very anxious, then we can't just, ignore and say, well, and these women can't be very anxious. So then instead of our offering and going for progesterone, my option to speak to her will be, but we can't do then when we do your booking scan at 12 weeks. For your as a part of down screening and for this one, then at that stage we may consider to do internal scan to measure the length of your neck of the womb.
Yeah.
And if it is shortened already or we think is quite, then we may consider to put that stitch even earlier.
Yeah, so this is my question because she has a list twice. So in history, we can ask how much length of the cervix they removed because she has a
won't.
twice.
Okay, so first
Yeah,
thing, she wouldn't know that. Okay, she can't tell
she will. Yeah,
how much, right? Number one. And
yeah,
the second, if
yeah,
she has the twice procedures, it's not something which even at that time when the surgeons removed it, they can even tell you by saying now that yes, no, it wasn't, so we should be fine because we don't know how
yeah.
that scarring happened, how that was healed, what happened. So if we want to know the length of that, then we can't do at 12 weeks. Right from the
Yeah.
beginning, she's
So
very
yeah,
anxious and she says, no, well, I'm worried. Otherwise, we'll just simply say, if you feel any symptoms before that, then you come to us immediately. But if
so
she's too worried, yeah,
my other question, like she has a miscarriage, second trimester miscarriage, and she has a cervical lids twice. So we can directly offer to her or
that's
this, yeah,
yeah,
because she has a clear history.
yeah. So that's what we are doing. Yeah, we're telling her we will
Yeah.
do this and but we are not going to put the cerclage without measuring the length of the
Okay.
cervix. So that
Yeah.
scan
Okay.
needs to happen. So that's why we're saying we will offer her. Because routinely, otherwise, we won't be offering to somebody just because of the 17-week miscarriage. Yeah, we are offering her because she has extra risk factor. We know she has LEDs twice, so she's a high risk to have cervical incompetency. That's why we're offering her screening, those measuring the length from 16 weeks. But if she's too worried about it, we can do one baseline measurement of the cervical length at 12 weeks scan.
So, doctor, history indicated cerclage we will not put. In any case, we have to measure cervical length and then decide.
Yeah, yes. Because it's just a common sense as well. Listen, I mean, how long it take to do a vaginal scan to do this procedure. Second, that is also important because then you need to decide, depending upon the length of the cervix, whether you're going to do vaginally or you're going to do through the abdominal route, right?
Yes, yes, okay, doctor. And in this case, what is role of progesterone? Like we can only give progesterone only, or till she goes for the stitch, or no need for progesterone only? We will measure the cervix. If it is short, we'll put stitch.
So principally, progesterone doesn't have any role here as per evidence. That one just is an additional reassurance if she would like to, but then we also need to tell her that that may not actually, prevent this. So she needs stitch. She needs cerclage. Okay.
So in this case, when patient asks when I can start progesterone, so what we should say? There is no need for progesterone.
Yeah, so first I will say, because of the risk factors you have, it's likely to be that you have this is what you require. But again, if she's very much stressed, then the guidelines say obviously we can offer them, but we need to tell them the evidence is minimum. But progesterone alone is not a offer for her. Okay, so progesterone alone is not an option in this case.
And doctor, in such
Dr. Safia,
young a young lady of average height and weight of BMI 25.
hello, Dr. Safia.
Yeah.
Yes, in this particular case, she has the two risks. One is the cervical trauma, and the other one she has pregnancy loss or early or second trimesteric miscarriage. So we can offer in this case also progesterone because she has another history, another risk. If only leads without any preterm labor before or without any pregnancy loss, so we will not offer this progesterone.
But we need to establish the details, Sama. We are saying about the first miscarriage. Yeah. She might have that first miscarriage and there was a retroplacental clot.
Yeah, if
I'm
normal
just saying.
miscarriage only, so
we need
nothing.
so if there is a history of painless
miscarriage. If second trimesteric miscarriage means we can offer
yes, so we are offering. Yes, we are offering.
Yeah.
The debate is here. Can that be just progesterone on its own can be an option?
Yeah.
Okay.
So progesterone will be not an option in this case because she has a short cervix, so we have to give the strength to the cervix.
Yes,
so,
yes, girls, yes.
Yeah.
The cerclage is the mainstay of the treatment.
Only option is per NICE. We have a flow chart. So in that, a patient has a history of any trauma to the cervix, and so in that case we will measure the cervix, and if it is a short less than 2.5, so
yeah,
cerclage is the only option.
Hello, Dr. Safia. As she has the choice, if it's not possible to do vaginally, then in the pregnancy we are doing laparoscopically, abdominally.
Yeah.
Okay. Thank you.
Cerclage is done. Because I think you all are tired now, for God's sake. Cervical cerclage. But incompetence is required in pregnancy, and you do know there is a transabdominal route as well. Okay, have some drink, stand up tall, do a little bit of stretching, up and down. So wake up.
Dr. Safia, just I wanted to ask, in such scenarios, we have to narrate the full antenatal care, like every 6 weeks, this and this days and that days, everything we have to tell.
No, just the main two, three important things. 12 weeks scan and the nuclear translucency is a part of down screening and 20 weeks scan. That's enough. You don't need to go into the weeks because that's not the stay. There might be somebody coming if they want you to listen for that month, somebody just coming for booking and want to know how she will be looked after.
So no need to tell till delivery and all, no? Okay.
No.
And doctor, what is the word to use for 20-weeker scan? Anomaly scan, I think they don't understand, no?
There will be detailed scans at 20 weeks to see if the baby's organs, heart, brain, and everything is formed normally.
That's all.
Detailed scan. Yeah.
Details. Okay. And for Down syndrome and anti-scan, same anti-scan only we can use the terminology?
No, just say we do a scan also that helps as a part of the Down screening. And if it is particularly for Down's, station is for Down, then yes, you can go into the details of, what is that and the 20 weeks. At 12 weeks, what we will be doing in 11 to 14 weeks, this scan and this weekend, then there's a different thing, obviously. Then you will tell in detail about we're going to measure the thickness of the, this neck, and we call it nuclear translucency scan, and then we will be doing these tests. So that's like kind of a common judgment, yeah. So if that is what the station is, that somebody wants to discuss about the risk of Downs and want to know what screening is available, then obviously you will be going into much details, because then the main theme of the station is to discuss about Down screening. Okay, here the main the thing is about to explain her how LEDs could affect it, what we can do, the scans, measurements, and what we can do to help her prevent, and then possibility of early labor later on, and safety netting. Okay, I'm gonna move from here because otherwise this topic will be getting more and more confused.
Okay.
Okay. Um, who is next?
Can I do Dr. Safia?
Yeah, who else is in this batch? Let me just see how many
Me.
stations we have. So Rina and who else is not have not done from the new batch? Sukanya is not here because she's not feeling well. Dipti has done. Anila has done. Okay. Lubna, are you there? Shazia? Rabab? Okay, yes, Rina, you start this one. And then Lubna, if you are there, next one will be for you, please. And if Rabab is here. Right, okay, so yes, Rina?
Yeah, I just make a key.
So we have two Rina, one has already done. Okay, is that Rina two?
Yeah.
Okay, so there is a little change in this scenario. So she is not
Yes.
a 16 years old. She is I don't know where that slide is gone. So that's a Talib's one. So this woman is, you can call her Tracy Wood. She is 27 years old and she is 23 weeks pregnant. And on the scan, she has been told that there is isolated Talibs in one foot, and she wants to have a termination done.
Yeah, so fetal anomalies.
Yeah.
23 week. So I have to explain about the Talipis also.
Sorry, you need to do what?
I have to discuss. Minke, it is a plant, and she came for the termination, or I have to.
She is here to discuss. So she on the plan she was scanned. She was told to have this, and no, she has come to discuss with you because she wants to have a termination.
So I have to explain the ultrasound report and about the Talipis also.
Well, she's aware of Talibs already.
So little confusion I have. So Talipis is not an indication for the termination.
It's not about whether it is indication or not. It's about like she's been told the child has this, the baby has this, and she wants to go for termination, and that's what you are supposed to discuss and address and listen her and then tell what is right and what she can do and what. Yeah.
Okay. Okay, I will try it. Hello, I'm Dr. Reena Kumari, doctor in Sexual Health Clinic today. May I confirm your name and age, please?
Yes, doctor. My name is Tracy Wood, and I'm 28 years old.
How would you like to be addressed?
You can call me Tracy.
Tracy, from your case notes, I understand that you are 23-week pregnant, and you have a concern about your baby, and that's why you want to terminate your pregnancy. Is that right?
Yes, that's right. I have scan done, and I mean that was 2-3 weeks ago. And they told me my baby has a club foot. I mean, my partner and I have talked about it, and we have decided to have a termination done because we don't really want our baby to suffer.
Okay. Any other concern, any expectation with this consultation?
No, that's all about. Yeah, this about to discuss and book for the termination, really.
Okay. So, any other, why you don't want to terminate this baby? Because you have a club foot or any other, you have an issue or anything?
No, I'm not told anything else. They said like otherwise, you know, the rest scan was fine, but the baby has club foot.
So anybody discuss about this club foot, about the treatment, what can be done? Because this is a minor structure defect in the baby, which can be corrected.
Yes, I know. They did tell me it can be corrected, but you know, I have seen that, you know, it doesn't really get corrected. One of my friends' brother did have that, and I saw him suffering, you know, in the school. He needed to use the crutches, and then all the other children used to make fun of him. And I don't really want my baby to go through that or trauma.
Yeah, I can understand you are very anxious about that. But Tracy, every case is different from the other case, because now medical is very advanced, and there are a lot of the treatment they can make. Really, we have seen the lot of the children, they are running, and they are doing the life as a normal children.
I mean, I don't know, you know, I have read on the internet and stuff. It says like if the baby is a club foot, there could be some other problems with the baby as well, you know. So, I mean, we don't know. We don't want our baby to be disabled.
Yeah, but if you want really, we have a good sonographer, and we have a fetal medicine unit, so I can refer you so they can do the ultrasound, and we can send an urgent referral, and they can do ultrasound and to find out if any other health issue they baby have, so we can decide about that.
No, doctor, because well, we consider that as well, but that's gonna take time for those tests and everything to be done, and then I will be bypassed 24 weeks, and then I won't be able to have the termination done. So I don't really want to waste any time doing those tests and stuff or whatever. So I mean, we have had a thought about it, and this is what I know. It's not an easy decision for us, you know, but I have seen this. I don't want. We can't see our baby suffering afterwards, being disabled and struggling with crutches and all that stuff. That's just too heartbreaking.
Yeah, whatever your wishes, I will respect your wishes. So, Tracy, is that okay if I ask you few more questions
Yeah.
about your health?
Yeah.
Tracy, can you tell me more about your health? Do you have any health issue for that you're following to your GP?
No, I don't have any health problems.
Okay, so are you on any regular medication?
No, just taking those pregnancy vitamins.
Okay. Have you ever been pregnant before?
I have one child before.
And how's he? How old?
He is fine. He's absolutely fine.
Okay. How you deliver?
That was normal vaginal birth. There was no problems in
Okay.
that pregnancy.
Okay. Do you have any surgery down below?
No.
Okay. Any health issue in your family that you want to discuss with me?
No, there isn't anything particularly.
Okay. And what you do for a living?
I work in a factory.
Okay. Do you have enough support at home?
Yeah, my partner is quite supportive. Yeah.
Okay. Do you smoke?
No, I don't. I stopped smoking in pregnancy.
Okay. Do you drink alcohol?
No.
Okay. Are you aware about your height weight ratio?
Yes, my height weight ratio is 26.
Okay. What about your blood group?
It's B negative.
Okay. Did you have any concern about the blood transfusion if you need?
No, I don't have any problems.
Okay. Do you have any allergy to any medication?
No, as far I'm aware of.
Okay. Thanks for information. So now come to your care plan. And regarding your baby is 23 week. So and you want a termination of pregnancy. So uh, so in that case, we have an option that only one that is we will give you some medication. Okay, and first I will contact with my consultant and we will discuss your case.
Okay.
Okay, and in that case, because before the termination, we need the signature of the my consultant and two obstetrician, and we will give you some before the termination. We will give you some medication to your baby and to stop the heartbeat. And then we will give you some medication from the down below, and which we will stop the hormone cause the producing progesterone, and then we will repeat another medication after the 24 hours.
Right.
Okay. Yeah. So in that case, you will start the pain. And first we will give you the medication, then you can go home, and after 24 hours you have to come again. We will repeat the medication, and that medication will start the labor pain, and which can cause this softening of the nape of womb, and you will start the labor pain.
Okay.
Okay. And sometimes these medication may not work. In that case, we need to repeat again the course.
All right.
Do you
Okay.
have any question?
No, I just want to know if there are any risks with this procedure and.
Yeah, in that case, you may have a pain. For that, we will give you pain management painkillers, and sometimes you may have excessive bleeding, and for that might you need blood blood transfusion, and sometimes you may get infection, and these are the only list. Do you have any question?
No, that's all. Okay, so when this termination will be started.
Yeah, so I will contact with my consultant, and after discussing your case, so then we can start this termination.
Okay. Yeah.
So quite difficult this station because she's a 23-week, and
Yeah.
because there is a risk baby can born and they have a sign of the viability, and
Yeah.
I don't know how to manage. These are the risk with this.
That's right. So that's why we will be doing post
Yeah.
fetocide, yeah, and
Yeah,
then
fetocide.
yeah,
Yeah,
then there
fetocide.
is. I'm glad that you didn't kept going on and on that saying, but that this is not an indication for termination, so you can't have the termination. In this scenario, yes, it will be it will be high risk and difficult termination of pregnancy, and we also need to make sure it's going to be quite difficult to see in for her, and it's going to be quite a lot traumatic and a stressful experience for her as well. A lot more than anybody else. The reason for that is because she has been repeatedly told that this club foot itself is not really, going to cause some indication of termination. So there is quite a lot of risk she might have regret later on, or she might feel quite a lot more guilty than anybody else choosing to have termination of pregnancy. So please do not forget to provide her support and acknowledge that, I can see it must be a very difficult decision and process you are going through. And then arranging the support for her counseling and for the partner. To start with, there shouldn't be any hesitation to arrange termination of pregnancy for this woman, because she still is within that duration in which she can have termination under clause C. So why not? She has some concerns there. If she feels she's so much stressed mentally that there's going to be, and we do understand, obviously, if we didn't, she clearly has some stress which can affect her mental health and the partner. Yeah, but yes, it's important we do give her information, but I will be giving that information in a very non-judgmental way. I wouldn't say that this itself is, I don't want to feel her guilty later on, at this stage. All I will say, this beginning was not right, okay, to start with by saying, okay, so yes, I can see you have the scan and then your baby is. Just establish a bit more information on that, to say, ask her that, on the scan, are you told, because we're not given the rest of the scan findings. So first ask that as well. Have you been told is the rest of the scan being reported normal, or there has been any other concerns? Were there any other concerns about the baby's development at all? So you need to establish it, is this is only the reason. And then you need to establish about just overall her pregnancy so far as well. So what about your scan and the down screening? Have they been reported normal? Do you have any other problems in this pregnancy so far, like high blood pressure, diabetes, or anything? Yeah, so just establish those one up till now.
Yeah,
Then
I was
just
thinking to ask or not. It came in my mind,
no,
but I
you
was
should
confused.
just normal. Yeah, no, just take it normal.
Yeah.
And then just again, couple of other questions we do need to ask, because so for every pregnant woman, you must exclude three things. Number one is VTE risk. Number two is domestic violence. And number three is their mental health. We might just take she's wanting this termination and totally forget she might be suffering with severe mental health conditions already or something. Or she might actually have a pressure from the partner, some abuse going on, which has further added up to thing by saying the baby has a club foot, and no, the partner is putting pressure to have. So the first, you will open up by asking, okay, so yes, I can see this, that's one, but there is, would you like to tell me in a bit more detail what exactly your concerns are? And then she give the history to the background by saying that my friend's brother has this and he struggled throughout, and kids needs to used to make all this one. So I won't say no, there is a different time and we have all the distance. No, first you need to acknowledge. Okay, so first I will acknowledge and will say, I'm really sorry to hear this all, that you watched that, and I'm really sorry for your friend and her brother as well, that they experienced that difficult situation at that stage. However, at this stage now, there is quite a lot corrective procedures available now, and they're quite manageable. And most of the kids, their foot can be actually corrected, its position can be corrected up to 18 months within 2 years time. And then there is a lot more awareness as well now in the public to how to deal, with people if they have any problems, so that they're not subjected to any abuse or anything. So there's a lot more awareness about this. Yeah, so that's first we need to make her sure that, he may not go through all that which she's thinking. But if she's very adamant and say, no, I know, but I still want to go ahead, then the other thing we need to make sure is to say, like, has she had any other test done or anything else to, because, if it is, then you need to give a little bit more detail to say if this clubfoot is just the only one defect on its own, then it is easily correctable, there is blah, blah, blah. But if there are other conditions or other any abnormalities, or any illness or infections related to that, then yes, there could be. So have she had any, you can ask about any viral illnesses. You can ask about, has she been offered any tests so far? If not, then you can offer, okay, so after this information about, and if she is interested, you can tell what costs and corrective procedures are available. All these are available, and then you can say, so if you'd like to, we can make arrangement to do some tests on you to say, but the way I'm going to say is I will say how you feel if we do some more tests, because I said, like, I have read that the kids with the clubfoot can have some other problems as well. Then my answer will be at this stage to say, okay, so yes, that's right. If there are, other abnormalities and stuff, then obviously there can be issues. However, if this condition is just on its own, then it's easily correctable now these days, and blah, blah, blah. How you feel about if we arrange all those tests to try to exclude other associated conditions? Okay. So let's see what she says. And if she's already very clear about these things and she says, no, I don't want to, because no, I'm coming to that situation, and then I don't want to go beyond, because then I won't be able to. So this is very important, this statement, if she says that, right? We can't now force this woman not to have the termination just because this is not, it does not come under the list of medical terminations if she goes beyond 24. At the same time, we don't want her to take that decision just in the fear that I'm 24, I need to get, and then she regret, maybe if I would have done the test, I would have been, because it maybe she's a lot more worried. There might be some other underlying condition as well, which make baby more disabled when the baby is born. But then I don't have the time to do this. And she said that, didn't she? I don't have that time, yet if I do, then I will be beyond, and then I will lose that option. We need to be, yes, according to law, this is what it said, but we are seeing her, this consultation is still under 24 weeks. Yeah. So we can, again, there can be some variations which we can take. So while I'm not going to say we can do this, but what I will say, if that's your worry, how you feel about having this test? Do you think if, so I'm going to make it more clear to her now. I will say, okay, so let's forget about the time limit for the time being. You just let me, help to understand if we can do those tests for you, and if they're normal, and you can be reassured that, this clubfoot is just the single defect this baby have, will you be more likely to continue with your pregnancy? Yeah. And if she says, well, no, I'm really worried. No, even if they are normal, we have made the mind, we want to go ahead with that. That's fine. That solves my discussion here. But if she say, yes, I could, but my worry is, because obviously if I do that, there's only 2 or 3, 4, whatever the days left for me to reach to this limit of time. And if I go beyond, I won't be able to do that. No, I can be empathetic here to say, I see your stress and I see your reason as well. However, I wouldn't encourage you to take this decision and terminate this pregnancy only because of these limitations of the time. What I can do, I can go and discuss with my consultant, and we can see if it is possible that, because we're still seeing you before 24 weeks, but if we can offer you the test, and if that test, show there is no, there are some issues, then obviously you still can go on medical grounds. You still can have the termination done. All right. But that will all depend if she, beforehand, she acknowledges that, yes, if you do the test and they're normal, then I may consider to continue with the pregnancy. Then I will offer her. And I will say, well, don't worry about that. Don't be pressurized with the limits of time. If your test shows other, risk as well, then you can have that under grounds of your medical grounds, the termination being done. So give her that reassurance. She can make like kind of, again, very independent, well-informed decision. And if she still say, no, I don't want to, no, we have made the mind and we are prepared to go ahead with this procedure, then it's okay. Just like as we will offer to anybody else, we will say, okay, if after that information you understand you did have these options and you feel that you would like to go for, you want to go or you would go for termination, we can arrange it for you. So I need to discuss with my consultant, because then there is a particular form we need to complete, which two clinicians need to sign off. So let me give you the information about the process, procedure, how that will be done. It can be quite high risk, and there can be quite a high risk of complications in this case because the pregnancy is quite advanced. And then you can explain how to say, first what we need to do is we will need to give some injection under the guidance of ultrasound state into the heart of the baby to stop the heartbeat, and then start the termination. So the termination, you can then explain, you will be given those tablets, which will be followed by after some with other oral misoprostol or vaginal prostol, and then you will start contractions and bleeding. So, and then the pregnancy obviously will be your uterus start contraction, and then obviously it will be removed. However, there can be a risk of heavy bleeding during that, or that expulsion may not be completed. There may be some retained tissue of the pregnancy left that may require us to take you to theater. So just tell about the termination of the risk as well. Don't forget those, yeah? So tell about and that the risk, pain relief you will be given, and then give her time to say, okay, that's okay. We will just, I bring those forms to complete, and I discuss with my consultant as well, and then we can arrange your termination to be started soon. Any quick questions?
No, very nicely you explained.
Good. Any
Thank you.
questions? Thank you.
So we are basically we are putting this under the category that if we don't terminate, it might cause grievous mental injury to her. Is that so?
Yeah, that's the clause. Yes.
Okay.
So this will be, madam, clause C or?
That's clause C.
Yeah, clause C. Okay.
Okay, so before I go to the next, couple of people are saying, can we do only one module a week? I wish we could, but if we started doing just, well, the major modules will be only one module a week. But if we do just 1 week, that will require us, I think, I don't know how many weeks then. We have 10 sessions, so we will be covering 2 modules of at least 5 questions from each. But additional one, as I said, we can continue in our discussions, in group discussions, okay? You can cover the rest.
And Dr. Safia, if you could limit the duration of because our thought process will also not work. I hope all of us will agree to this, because such long sessions will not be able to think itself. So if you could cut down it to 4 hours or so, that would be fine. I feel so. I think most of them would agree to it. I don't know.
Time is very limited now, so we have to cover as much as possible.
Okay, so regarding the timings, we used to have 3 to 4 hours, but then we were covering 3 stations. Yeah, sorry, 7 stations in one session. So just for you guys to become more benefited, to be honest, I have increased the number of stations to 10 per session. For me, it's not a problem. I can reduce. Either I can shorten the discussions on the stations, and try to finish them. I mean, we'll still do 10 stations, but we don't go into long discussion. That will be up to you guys. Instead of asking extra questions during the session, you can ask in the group. We can do over there and save the time, or I can reduce the number of stations. It's really up to you.
No, doctor,
if the questions are...
because we have to cover maximum stations.
Yeah, if we have only 10 sessions means, then it will be better that we cover
so what
10 cases in a session.
After every session, we can take only 1 or 2 quick questions. We will not go into detailed discussions or any conflicted discussions. They can be done in the group. Okay, so this is how we can try to
Yeah.
And then I understand what you're saying is, but the issue is if you are preparing for November exam, then you should be. I mean, I am the one which is doing the main part of talking, and if I can sit and talk for 5 hours, you guys are just listening. In between, stand up, do a bit of jumping. Your cameras are off, your speakers are off. Do a bit of jumping, take cold drinks or warm drinks, whatever you need to, because this is the time now. You are under exam situation, under exam conditions kind of thing. This is the time now you should be working hard instead of
Yes,
last
doctor,
minute.
I withdraw my statement. I'm sorry.
Yeah, no, it's okay. It's okay. I liked it. I liked it. I would like it to be interactive. You guys to drive what would you like to do. So if you feel much tired, you can go off because you will have the recording later on. You can listen that and do, and then this sport will continue. Do not worry. If you think in one session I haven't actually, there can be other reasons as well, things to do and stuff. You can't leave in between. Okay, listen to the recording, then you can individually discuss with me as well, stations. All right, so don't feel pressure. But
I
yes,
feel when we
I
do
will.
for longer time, it actually improves our concentration capacity during the exams.
No, it's fine. I mean, it's for everyone it's different. So the people who can't sit for longer hours, they obviously can in between go because you have the recording, so you won't be missing anything. Okay, after you have presented your station. Because later on the option, the one option is the what you can't do basically. You can, when you're listening the recording later on, you can actually omit the discussion in between. You can just listen my part of discussion. All right, so there are all possible ways. I fully understand you all have different circumstances, obviously, yes. But we need to really crack on and try to cover as much. Okay, so this 9 years one we have discussed in that our open session of the day. So let's do, there was another one. Come on, where is that one gone? Yeah, this one. Right, who is next to do?
I am ready, Dr. Rabab.
Okay, good. This is for you then, Dr. Rabab.
Okay.
Okay, that's your first 2 minutes.
Okay. Yeah, Doctor. Hello, I am Dr. Rabab, one of the doctors in the clinic today. May I confirm your name and age, please?
Yes, doctor. My name is Jade Bennett and I'm 14 years old.
How you want me to call you?
You can call me Jade.
Okay. I understood that you are referred from your GP doctor, and you have painful rashes from down below and tummy pain as well. Also, you have burning in during passing urine. Is this correct?
That's right, doctor. Yes, I have got really these sores down there and I'm in a lot of pain because of that.
Okay. Do you have any more concern and expectation from today's meeting?
Well, I just want to, these sores to be sorted out. I want to have some medicine to stop this pain really and get this healed.
Yeah. Sure, coming to your help, but would like to ask you a few questions at any time you have any concern, you can ask me. Is this okay for you?
Yeah, that's okay, doctor.
Okay. So can you tell me more about your complaint?
So I started, I noticed a few blisters a couple of days ago, and then it started becoming more painful. And then, this morning I noticed it was very painful, and I can actually see there are open sores. And when I pass urine, it stings so badly that I'm really afraid of passing urine now. So I'm in a lot of pain down there, and lower part of tummy as well now.
Sorry for what I'm hearing now. Do you want me to provide you with painkiller?
Well, the nurse has given me some paracetamol, which I've taken.
So are you okay now to continue?
Yeah, I'm a bit better, yeah.
Okay. So is this the first time to have this painful ulcers?
Yeah, I never had this before.
Where it is exactly in your body?
They are down on my bits, like, on my folds. What is that called? It's a vulva.
Mm-hmm. Yeah, okay. Do you have any fever?
No, I don't have fever, just a bit of like flu-like symptoms.
Okay. Do you have any headache or dizziness?
No.
Okay. Did you start your period?
Yes, I have started my period for about 2 years.
Okay. And when was the last period?
Last period was 10 days ago.
Okay. Sorry to ask you. Are you sexually active?
Yeah.
Uh-huh. Okay. With whom? Who is your boyfriend?
Well, I don't really want to go into those details, doctor. Can you just sort out these sores, please, and give me some medicine?
Yeah, sure. Help is available. So how you are doing at school?
I'm doing okay. I don't like studies much, but anyway, I'm doing okay, not bad.
Do you feel safe at school?
Yeah.
Yeah. Okay. Otherwise, do you have any other health issues you are visiting your doctor?
I do get some migraines, but I haven't seen the doctor for that.
Okay. Did you have any surgeries before?
No.
Do you smoke?
No, doctor.
Do you drink alcohol?
No.
Do you use any recreational drugs?
No.
What are you doing? Studying?
I study, yeah.
And do you have support at home?
Well, yeah, I mean, I live with my grandma, and yeah, she's nice.
Okay. Do you have any drug allergy?
No.
Are you on a special medicine?
No.
Do you have any family history of concern you would like to mention?
I'm not aware of anything.
Okay. Thank you for sharing the information with me. Coming to your concern, would like to reassure you that this consultation is confidential and nothing will be gone outside this consultation.
Okay.
Okay. So I would like to examine you with the results of Chapron, and after your permission, I will check your height, your weight, and your height to weight ratio, your blood pressure, heart rate, and temperature. Is this okay?
Yeah, okay.
And I will examine you from down below to see how is this rashes and if it is present in your other parts of the body.
All right.
I would like to, okay. I would like to send I will also examine your tummy, and I would like to send some workup for you. I will take a swab from from these lesions, and I will send a blood test as well to look at this type of to look exactly what type of infection is this. I will also collect other blood tests to see the complete blood picture and to reassess you. Is
So
this okay?
you need to take a swab from the source. It's so painful, doctor.
Yeah, I can apply a cream, a special cream, and it will help you in collecting the swab.
Okay. Yeah. All right.
Okay. Okay. Did you ever experience any sexually shared infection?
No, I have never been checked before.
Okay. So right now, I will offer you, if you are not well and if you are not able to pass urine, I can, or you feel that if it is very painful, I can offer you admission to the hospital. Is this okay for you?
I can't go to the hospital. I don't want to be. So if I mean, you know, the medicine which you will give me after that, I think I will be okay to pass urine.
Okay, so I can put a tube inside a tube, and it will help you to pass the urine, and you will get the relief. Plus, I will prescribe you a medicine called acyclovir. According to the swab, will provide it. It will relieve your sore rashes. Is this okay for you?
Yeah, that's all right.
Okay. I will give you also painkiller and local anesthetic cream, and this will continue for 5 days. The treatment. If you feel not well at any time, you can come and contact us for help. I will also advise you for safe sex using the condom with your partner. Is your mother aware about your relationship?
No, I haven't told her.
Okay, no worries. I can encourage you if it is suitable to inform your mom. Otherwise, if any problem, you can come and ask for help.
Well, I don't want to really to talk to my mom about this. She's always so busy. She never had the time for me.
Yeah. But anything you will mention here, it is confidential, so we can provide help for you at any time.
Okay.
So, okay. Do you have any more concern?
No, I just want to have this medicine.
Yeah. I'm providing you with patient information leaflet and support group, and I will write back to your GP. And at any time you have any problem, you can come back to us.
Okay, thank you, doctor.
Thank you.
Okay, good, thank you. Right. So No, that's fine. But I will say like kind of it was a 50% of the station attempted. So, okay. And why that? You did fine from diagnosis and the management of genital herpes follow-up. You did touch, you were coming to the safeguarding, but then you were just shying away again. So 14 years old girl coming with STI, as we said in the beginning as well, sexual health, AGISUM, and the contraception services, they are single integrated service now. So somebody coming, so the first thing you need to look at is she's coming for some sexual health problem. That means we need to just check with her contraception and sort out contraception as well, number one. Second is if we see her sexual transmitted infection issue. And the third is because she's under 18, we have to do safeguarding risk assessment for her. Yeah, so keep it 3 simple categories under those categories and you won't miss things. So first of all, because STI is the presenting problem here, start from there, just ask about the history, start the reassurance of confidentiality right from the beginning to say, it's confidential, will not be shared with anybody unless we have serious concerns about your safety. And then ask about, okay, tell me about your condition. So then if she gives you the details about these blisters and sores and all that, when it started, do you have any fever, any rash in any other part of the body? That was fine. Is that the first time you had it? You had this before? So just build up your rapport first. Just stay on your STI bit first, and then say, okay, so I can see your GP has examined you. Has he given you any medicine or anything? So we can take the diagnosis from here. We can tell her it's genital herpes. Yeah. So if it's given, we can take the diagnosis. So you can say, okay, I can see your doctor has examined you and it's genital herpes, which you have got. So what I would like to do, so tell me first about the pain, how your pain is at the moment. Okay, I have the pain relief. Okay, so are we okay to go ahead with that? And then ask about the urine. Retention is another urgent thing to sort out here first. So she says, I find it difficult now to pass urine. So I need to obviously ask now, okay, so when was the last time you have passed urine? So do you think you have been emptying your bladder properly? If there is any concern that there could be some urinary retention, then we are going to offer her application of local anesthetic and lidocaine straight away. So we'll say, okay, so what we can do, how you feel about if I apply some numbing gel on your sores, it will make it numb and take your pain away, and then you try to pass urine. So hopefully you will be able to pass urine, because it's very important you do empty your bladder properly. If not, then you can build up some infection in your urine, which can go up into your kidneys. So if she says, yes, I can try that, that's fine. You say, okay, but don't worry, if you couldn't pass urine properly, but that way, then I can empty your bladder with the help of very small tube after applying some more gel. Then come to the examination and stuff to say, okay, and then I would also like to have a look down there on those sores to confirm, and also take a swab from those sores to send it off to check, for the confirmation of genital herpes. Is important that if you have this one infection, it's very important you get checked for other possible sexually transmitted infections as well. And then you can ask about the signs and symptoms. Have you noticed any change on discharge before you develop these sores? Was there any pain in your tummy? Did you get any pain during sex? And do you have any irregular bleeding in between your periods or after sex? Okay. And then you can say, okay, so I'm just going to ask, okay, so now tell me, when was the last time you had a sex? Okay, so now I'm coming towards where I'm going to address her contraception and safeguarding stuff now. So ask her about, again, keep a natural flow towards the situation. When was the last time you had a sex, right? So no, there can be 2 possible options. She might just say, that day, because it's not always that they are sexually abused. Sometimes they are groomed and exploited. So those girls and those children, they are, because they feel it's right, because they are being given gifts or some other attractions and gifts to do that, they feel it's okay, that person is doing so much for us, it's okay to do this bit for that person as well. So they may not appear stressed, they may not appear as sexually abused kind of depressed children or anything. She might just be okay and confident. So when was the last time you had the sex? Is that your regular partner? That was just casual one-off. Okay, so some answer will come here. If she says regular partner, or even if she starts saying, no, I don't want to talk about that, just give me the medication, and that means she might just be abused or something. Okay, you can leave at that stage for that question, but then I will still ask her to say, okay, would you like to share with me, are there any concerns? Why don't you want to talk about your partner? Okay, that might make her to actually talk about the partner something, or she may not, still says, no, well, I don't want to. Okay, leave that at this point. Okay, then we can go further and ask the next question, which we are supposed to ask anyway as a part of safeguarding assessment. Okay, so tell me, what's the age of the partner? All right, and if she again goes, either she will tell you the age, and that will help you to pick up if there is any abuse or grooming going on, like if there is a major, that person is an adult or in some position of trust, a teacher, anybody. And if she still doesn't tell, then we'll say, I will take a little bit more, encourage her to go. Then I will say, well, I can say there is something you're really worried and concerned about regarding the person you're having sexual activity with. Let me reassure you and give you full trust that whatever you discuss with me will be quite confidential, and it will not be shared with any third party. All right, unless we feel this is a serious risk for you or for other children. If she still doesn't know, then you can ask. I can, sometimes it's important this information to be shared. We do this assessment as a part of a routine to make sure that the child is safe, and then other children around them is safe. And then I will explain even why. I will be fine to say to her, because the certain relationship or the sexual activity with certain in certain positions is not right. So if the age of your partner is your partner is much older than you, or he is in some position of trust like your teacher or somebody else or some adult person, they should not have sex with you. Okay, it's not right. And if the person who's having sexual activity with you is in any one of these positions, then he might actually be having sex with other children as well and putting other children at risk. So giving them these type of open information encourages them to. So if there is anything after this, she will tell you. She's not going to hide. And if she still says, no, there is nothing. So either she will say, no, there's nothing like that, or she'll say, okay, well, I will see. Or she might say, she will start opening up at least. If she doesn't stay the name straight away, she might just say, well, I can't, I don't want to, because I can't do this. I will be in trouble. If I did this. And then you can ask, no, don't worry, you won't be in trouble. If you will share that information, the way we deal with this to ensure that you remain safe and you don't have to suffer with what is going on with you. We deal that in a very sensitive manner. And the people who deal with these such issues they are specially trained, and it's not uncommon. It happens. All right, it happens in the community, so we have trained team to deal with this, and this should stop. And they usually then open up. They will open up. An exam point of view, obviously they will open up. And then you continue with this one. So, if there is, she says, yes, it's a teacher or this and that, you can go into more detail to say, so what happens actually? Does he force you? Does he threaten you to get involved into sexual activity? Or does he give you any, because sometimes it's, yes, there is, he says, I don't tell to anybody, otherwise he will fail me in test or whatever. Or she might actually be saying, well, he helped me with, he passed me in every test and give me good marks and blah, blah, blah. And then I can do this at least for him. He gives me so many gifts and blah, blah. I think it's okay to do this for him. And then you need to say, no, that's not right. Okay, because he's in a position of power and it's illegal, it's wrong for any adult to involve any young child into sexual activity. And then it may not be only you, he might be having sex with other children as well. So this needs to really stop. Okay, and then you can reassure by saying, again, reassure if she's worried about you, do not worry, it will be done in an anonymous manner. Your name won't be coming up and nobody in the school will know about this. So then you can say, we do have a safeguarding team, we will discuss with them and they know how to deal this sensitively. Okay, in a sensitive manner without putting your ID, relief or any further risk of harm to you. Part of safeguarding assessment, we need to also ask that question, who you live with. Yeah. So if she says I'm living with grandma, then we need to ask, okay, so what about your parents? Yeah. Then she will tell something, father is not blah blah or whatever the mother is. Is there anybody at home you can talk to if you have any problems in sexual relationships or any bullying or any harassment? Do you, instead of saying like, how is your school or how your studies, just ask direct question. Do you go to school? Are you regular in your school? Is there anybody at school you can talk to if you have any problems? Are you bullying, harass, or any sexual relationship issues? Do you have good friends you can talk to? Yeah, so that's what you will be doing there. So from HSP point of view, yes, you did the swab, started on a cyclovir, give her amla gel or the lidocaine gel, and then offer her, once these ulcers and sores are healed, it will be really important that you come back so we can take some swabs to check you for other infections like chlamydia and gonorrhea. I will also offer and recommend you to have a blood test done. So if you are offering any test, tell which test. Yeah, don't just simply say we can do some blood tests, we can do some swabs. No, swabs for chlamydia and gonorrhea. We can also do. I will also encourage you to have a blood test done for HIV and syphilis and infections called hepatitis. These infections can be quite serious and damaging. So you never know. You know, these infections might have been passed on to you. So that's done with that one. And then come to the contraception point of view. When was the last period? Have you been using, does he use any condoms? Are you using any contraception? If not, then think about if you think there is a need of emergency contraception. All you need to say is when was the last time you had a sex? This much time. When was your last period? Do you have any other episode? Okay, that means we need to give you some emergency contraception as well, which we will sort out at the end of this consultation. We will also discuss about starting you on some long-term contraception meanwhile, and then ask additionally as well, do you have a boyfriend? Yeah, other than that person, obviously she might have a regular boyfriend as well. Right, any questions? So the rest of the procedure, obviously for consultation point of view, this is all we need to do. Assure her that we will be doing this, and safeguarding team, I will, speak to my consultant and also to the safeguarding team, and they know how to deal with it. Otherwise, just for your theoretical knowledge, I repeat again, we discuss in another session. The next step will be we speak to safeguarding. In this case, obviously, if it's a teacher or any adult involved, he may not be in a position of trust otherwise, but maybe any adult, because she's a child, is just illegal and rape, even if the child is actually involved in the sexual activity with the consent. So again, there will be police involved. So the order will be, we will discuss this with the consultant, with the safeguarding team, get advice from them. There needs to be, informed to the police immediately. And then we need to arrange a referral to Marak, multi-agency. Multi-agency referral conference where social services, police, education, health, and young people services, they are regular members who attend. Their service usually happen once in a week or fortnightly. And there will be proper assessment done regarding the safeguarding of this child, about the living arrangements of this child, or if there is any ongoing harm, any risk, about the obviously investigation and arrest of the person, whoever is involved to do this, to also ensure the safety of other children. We will also need to arrange some counseling otherwise for this child to go through this traumatic experience this age, obviously. So we need to do that as well. Okay. So that's conclude our today's course. Any quick questions? I will be taking only 2 questions, please.
Madam, how much would be the doses for acyclovir in a 14 years old girl?
So if she's a normal built girl and her weight is like about 45 kg or something, it's a normal dose of 400 milligrams 3 times a day. If her weight is less than that, then will be done. Then you will need to check what much is the child dose, how many milligrams per kg. That one you need to check.
And
But
gel is just,
if you don't really know, you can simply just check. I will check BNF, what dose exactly I should give you. You should know the name of the medicine and the route.
okay. And this gel is nothing but local anesthetic gel, no?
That's a local anesthetic lidocaine gel.
Okay. Thank you.
So we use the word numbing gel. Okay, so related to these 2 modules which we have done today, in the form of short questions, you can initiate the discussion on Telegram group. Okay, are you all in that group, or is there anybody who's not part of that group already?
I am not part of this group.
I'm also not a part, ma'am, in Telegram. Dr. Dipti, I'm not there.
Okay, send me a message and I
Yeah,
will add
Dr.
you.
Sapna also.
It's a WhatsApp, not Telegram group.
Okay, my Telegram group's name is Safia Jabin MRCUG group.
Ma'am,
I
but
will.
I just tried searching it, but I couldn't find your group. That is why.
Okay, I will
If you could just
see.
send the
I will.
link.
Oh, I wish I knew these things. I will ask my admin to find out what's
I
the way,
think
and
it
then I
was
will share.
deleted.
Madam, I am also not there. Dr. Dipti is also not there.
Who is there already then? Let me see. Pramila,
Dr.
are you
Satya.
there?
Yeah, I am there. I am
Pramila,
there,
are you
ma'am.
there? And do you know
Yes,
how
yes.
to do that link? But I don't know whether you will be able to copy that link from there. Can you take that link from there and put into the group? If not, I will put the link in the group. I will ask admin to do that.
Okay, ma'am. I am not sure how to do that.
That's all right. Don't worry. Okay, so I will put the link into WhatsApp group. So any discussion should happen over there now. Okay.
Thank you, Dr. Safia. Nice session.
Okay.
Dr. Safia, some more station if you put in the group, which we can prepare ourselves, like early pregnancy, and she has the X-ray of the knee, and you can guide us
Yeah, so
a
all of
mixed
you do
scenario.
have the previous recalls, yeah. So you need to take the initiative. So from those recalls, if anything you want to discuss, I won't be obviously discussing full station over there and giving you the model answer. I just simply can't do it, yeah, because I'm running part 2 course as well. But I can help with the short answers and the things. So but you guys need to take initiative yourself to put
Yeah,
the
we will if we have some any doubt or any question, we can ask
yeah.
in the group.
Of
So
course,
if you
that's what.
put
Yeah.
all the recall of this, so we can prepare ourselves, and if we have any problem, so we can ask you, like in the counseling, good sentence or something where we have some difficulty.
Yeah, you will. I will do that. I will help with those ones. But then, regarding your any extra stations, I mean, in every module, that's why I have tried to do some model answer. So, right, with this kind of ectopic pregnancy, and so you should be able to basically learn the phrases and words according to the scenario from these basically discussions
Yeah,
and the recordings,
like
and then try to apply those to other scenarios as well. Okay. And but then if there is anything you think is slightly different or tricky in those scenarios,
yeah,
that one question you can ask me over there.
yeah,
Okay.
like X-ray. She has a knee X-ray and she want to terminate the pregnancy. So how we can say like this X-ray not cause any harm? Like this is some sentence, beautiful sentence we have. So in that
Put
case,
that
like
question in that group. Yes. Put in there and I will answer.
yeah, okay, thank you.
All right. Thank you. Bye.
Thank you, ma'am. Good night.
Thank you.
Thank you, ma'am.
Thank you.